The stage, please. Okay, shall I use this? I think we. Testing.
It will work, I
So
think.
Okay.
So you can make it more.
Is it live now?
Yeah.
You're recording. It's like him.
So you can make it more informative. You can make more interactive. You can connect with the app. So you can just ask everyone to introduce themselves. Anything you want. You can add on whatever you want to do.
Okay.
Yeah.
All right.
So you can just start.
Okay. All right. Testing. Okay. A very good morning to all. I extend a warm welcome to all participants, students, and delegates for the Scientific Global Digital Gathering at the 11th American Nursing and Patient Safety Summit program. I am Ines Al-Khatib. So it's very awkward to talk about oneself, but in a summary, I'm a chartered project delivery professional. I've been working for the past 16 years in a spectrum of projects across the globe. Names among them is the COVID vaccine contract manufacturing in this pandemic, as everybody knows how much suffering we had to go through as professionals in this field. I've worked with a wonderful group of people building buildings like the likes of Cleveland Clinic across different locations, and in management consultancies, the likes of Booz Allen Hamilton, Royal College of Surgeon graduates. In a combination, as a background, I'm an engineer, but with a number of hats, be it in aviation sciences, in industrial engineering, and contract management. So I'm very glad to meet everybody. It was a very long trip all the way from Dubai, sunny Dubai, to freezing San Francisco, if I can compare it. I hope that today it's going to be an interactive session. We would love to hear from you, your backgrounds, your experiences, what you've been through over the past couple of years of battling this never-ending dilemma and pandemic. We do have quite a number of participants, and they all come from different backgrounds. So please don't shy away from asking questions. No question is trivial, and no question is not worth asking. Let's just put it this way. We do have a number of attendees online, so we want to make sure that everybody online also chimes in. So those online, I can't see them, but for those who are connected online, feel free to raise your hand and ask away. I'll move to Amal. She's going to give you a couple of intros around the events, around what's coming up from upcoming summits, and then I'll start the whole introduction to the speakers. Thank you.
And good morning, everyone. Thank you, Ms. Ines, for this lovely introduction. Let me introduce quickly myself. I am Amal Ibrahim from Jordan. I am the Middle East Organizing Secretariat coming abroad from Palestine. So I had a very hard trip to San Francisco. I would like to welcome all of you to the American Healthcare Summit, and I hope to enjoy your staying here with us and participation to our conference. Let me speak quickly about UCG conferences, who we are. We are a Utilitarian Conference Gathering, as we are offering a wide range of events, meetings, conferences, workshops, symposium. We have a dedicated team who are aimed to acquiring the technologies, adapting the knowledge of business needs, and accelerate with best ideas and strategies. Also, we are a pioneer in the area of event management, collaboration. We are a full event service provider specializing in the field of medical, clinical, healthcare, life sciences, pharma, and environmental science for academic and industrial sectors. We stand out distinctly from our competitors for our commitment to quality around the clock services and unmatched price. We are able to provide you the best event meeting experience under one roof. We are also sure that you as a client choose the most appropriate event. I thank you all for finding time in your busy schedule to be here with us today. Also today marks the major activity in the pre-extensions of the UCG conferences, a moment where we are interacting, sharing experience, and reflecting on a various area. The American Healthcare and Nursing Patient Safety Summit is a perfect platform to share experience, foster collaboration across industry and academia, and evaluate emerging technologies across the globe. We cordially welcome you to join us and witness the advance in the field together. The conference had attracted delegates who have come from all over the world, across the continents, and the subject of conference is surely of a global importance. UCG thank you all the individuals and organizations who have worked to make this conference a grand success. Also, UCG program committee has put in long hours with many creative efforts. And finally, I would like to extend my appreciation to the participants of this conference. We hope you will enjoy the conference and that our participation will contribute to our professional development and relationship. I would like to introduce the Pure Heart Nursing Leadership Academy International and Legally Mine. We are glad to have them with us today, and the representative will be doing a great workshop. Please don't hesitate to get in touch with them and also the team if you would like to know more. Let me briefly give you a small information. The speech timing for the keynote speakers will be around 40 minutes. For the speaker will be 25 minutes. Poster speaker will be only for 15 minutes, and workshop timing will be for 40 minutes. Regarding the certification, it will be provided on November 17 for in-person attendee, and for the online attendee, certification will be provided on November 20. So let me again give the speech and the stage for Ms. Inas to start the conference. Thank you very much.
Thank you. Okay. Now, the worst thing I can ever do is pronounce somebody's name wrongly. So if I do, I apologize in advance. It's a pleasure. I take immense pleasure to introduce the keynote speakers at this summit. Ms. Leanne Thiemann, Self-Care for Healthcare International USA, Dr. Janelle Ali Dinar from Self-Care for Healthcare International as well, Ms. Lauren Mooney, Speaking IN USA, and Mrs. Suzanne Raben Burgess from ELP AG Switzerland, and Dr. Unati McEwain, Dr. M Health Corner USA, and Ms. Lee Tomlinson, founder and chief inspirer, Patiently USA. So let's start with our first speaker. We've got Dr. Karen E. Hunter from the USA. I'm passing her the stage to deliver the speech on EHR Optimization Project Value. Hunter, please join us. Thank you.
The slides are here.
Yes.
Thank you. Good morning, everyone. Welcome to San Francisco. I'm happy to say I live in the area. I live in Oakland, just across the bridge. And so for me, it was easy to get here. And I'm grateful to each of you for coming. How many nurses in the room? Awesome. All right. How many of you use an electronic health record in your work? Awesome. Okay, good. So I'm going to talk about that today.
You can use this one.
Thank you. Use this one. Perfect. Yeah. All right. Again, welcome, Karen Hunter. I am a nurse informaticist at Common Spirit Health. And do I need to stand here? Just to, can you hear me? Awesome. Good.
You can use this.
Thank you. Awesome. Okay, good. And so I just introduced myself. I'm a nurse, and I was working in cardiothoracic step down several years ago as a nurse manager. And we had a fatal medical error where a patient was transplanted with a heart and lung of the wrong blood type. And everyone knows blood type is a crucial element in a transplant, but in 10,000 data points, it got overlooked. And I thought to myself, how can technology help us be better clinicians, safer clinicians? And so I went back to school, got my master's in nursing informatics, and never looked back. So today, that always is my motivation, is how do we use technology on the electronic health record to augment patient care, make it safer and better, right? So my project reflects that. It is our custom in our company to always start every presentation with a reflection quote. So my quote for you today is, for every complex problem, there's an answer that is clear, simple, and raw. And so Common Spirit Health, this is who we are. We are the largest Catholic healthcare system in the country, 150,000 workers, serving 21 states, 1,000 care centers, and 139 hospitals. So we had a problem in our company that I was trying to resolve, right? We use the electronic health record. We wanted to support evidence-based care. We wanted to help collect data and inform clinical decision-making, right? Fair enough. And over time, we optimize it, right? End users, such as yourselves, they come and say, I have an idea. I want this widget. I want this field. I want this change. It's going to make life better, make patients care safer, right? And we want to do that. And last year, I took a quick look at one of our markets. 21% of the changes promised a clinical outcome. However, an ineffective feedback loop, we didn't know if we succeeded. We didn't know if these changes actually made a difference, right? And we were unable to learn from it. In fact, we suspected some of them didn't help. So who's involved in this, right? We have clinical stakeholders every day working in the electronic health record. They're the ones that are generating requests. In the middle of it, we have informatics, people like myself, right? We're facilitating governance, prioritizations of those decisions. We participate in the design. And then we have IT at the bottom, right? Who's underlying everything, making sure the systems work. And they're the ones actually making the changes. And to date, we had just focused on speed and volume. How many changes can we make? How fast can we make them? But never thinking about, are we actually accomplishing anything? And then to be fair, there's a lot of work happening, right? And IT, those of you who are aware of your IT departments, they're busy. They've got hardware and infrastructure to maintain, right? They've got products going on. I know in our system, we're constantly updating hospitals. We acquire hospital, we invest in a new system, right? High dollar, big projects. Also, upgrades and maintenance, the non-sexy part of IT, right? Regulatory requirements, cybersecurity, all those things. What I'm talking about today is just this one corner up here. So these end user requests that come. So the solution is Project Value Hunter. How do we find the value in these changes? So we set out to measure and track the intention of each of these changes, right? We want to analyze them to see how do we apply them in future decisions. We're going to do a cost benefit analysis, and then we're going to scale it across the company. So all 150,000 employees. So it starts with evaluating the outcomes. What did they promise? They said, oh, if you'll make this change, it will add this blue widget. It's going to make my patient safer. How is that going to happen? We're going to track that, gather evidence. Did you accomplish that? And then we're going to track it. Then we're going to gain insights from this. What worked about this? What did make it better? We'll catch unintended consequences. Have you ever experienced an unintended consequence in the EHR where you enter something and then you find out, oh, it didn't work? We're going to identify themes that we can apply to future decisions for learning from this, reduce errors, right? And increase value capture overall. If you don't know this, your EHR is super expensive. In our company, we're talking about $1 billion or more. And so how we maintain it makes a difference. So then the last step, or the next to last step here, is cost benefit analysis. We wanted to look at each of the optimizations in the past year. Did we achieve a cost savings or cost efficiency? It's really important, particularly for healthcare in the US right now. We're really struggling. So I went back last year and just randomly picked 4 examples to say, what can I find here? What can I learn? First of all, we had a project where we diverted monoclonal antibody infusions from the ED into a separate area. You mentioned COVID, right? So at the time, we were surging in Texas, and 20,000 patients showed up in our ED in the last quarter of 2021 for these infusions, overwhelming the ED, taking valuable resources. Plus, the emergency room is a very expensive venue of care. We wanted to create a separate area where we could decrease costs, improve utilization. So we put this in place. Did it work? Did we save money? Was it more efficient? Nobody went. Nobody went back and worked. Another one, in the electronic health record, we wanted to change one of the orders in order to reduce unnecessary blood transfusions, to make it harder to order unnecessary blood transfusions. We know why, right? We know, first of all, cost savings. We know that decreasing infusions or giving unnecessary transfusions is associated with increased mortality. It extends healing time. So there are a lot of good reasons to work on this. Did we achieve it? I don't know. No one went back to look. We added a flag to identify abnormal blood pressures. This was an organizational board goal for us. We know it has great implications for population health. Did we achieve it? We don't know. We made the change in the EHR and we just left it. And finally, we built a standardized order set for elderly patients with hip fractures. This would support standards of care, best practice, right? It would decrease our length of stay potentially. It would enable us to capture more revenue through Medicare Shared Savings Plan. So we built it, launched it into the wild, but no one went back to see, did it achieve this? Did we achieve our goals? And all of this, of course, took time, money to do, and no evaluation. So definitely a gap in our process. And finally, to put a program together where we constantly monitor this, I estimated to be around 500,000 over 3 years. I think easily made up for with these 4 examples, not to mention the other 200 items we changed in EHR in the same course of time. So what did well, next, we're going to scale it across the organization. This process will just be a continuous improvement process, right? Learning, applying the learnings, and ensuring value. I would expect this to take a year, my initial proposal, and the first 90 days I've just finished. So I want to share with you some of the findings in the first 90 days of this process improvement. So I was able to evaluate 6% of the 200 changes that went in. We did a deep dive. Awesome. We did a deep dive on those changes. And unfortunately, or fortunately, found that 57% of them were positive, did deliver on the promise, and made a difference. 43% were negative. So roughly 60 cents of our dollars were bringing value. This 6% represents 233 hours of work, or 18 hours per item. The themes, and when I look at the ones that were negative, the themes I found were we were using alerts and hard stops to really manage poor process. Not a good tool. Right. Also, we found that sometimes a single use case that lacked broad application would be implemented, and so then it didn't get adopted. Also, we found people seeking to make a technical change rather than truly optimizing their workflow in patient care. And then back to the original 4 problems or examples I shared with you. What did we find when we went back and look at them? Remember the monoclonal antibody infusion clinic? We did move it over, very successful. We were able to recoup the money and save, decrease infection rates, cross-contamination, or ED, free up the ED to do what it's supposed to do. So this was a success. The second one I mentioned, changing an order in order to reduce unnecessary blood transfusions. This did not produce the effect we wanted. In fact, it was set up poorly, and that it was a hard stop at the request of the hospital. But the doctors just worked around it and did not accomplish what was set out to do. The third example was a flag on abnormal blood pressure. When I looked back at this, come to find out it was not a change, it was a mistake that had occurred in the original build. It was not flagging appropriately. So this was a correction. It should have never happened. It should have been fixed on day 1. Unfortunately, another opportunity to improve resource usage. And finally, our care plan, our order set for the hip fractures never got used. No one ever used it. So I went back to find out the original requester physician had left the organization, and because it had been set up based on personal preference of that physician, no one else wanted to use it. So again, a lesson learned for how we approach these. So what are we going to do differently now? This is what we've learned so far, and this is just 90 days in. We have to do a better job up front identifying the problem. Ask why 5 times. When someone says, I need this blue widget, we need to know why. What's the patient population? How is it going to affect you? Right? We need to establish return on investment or value upfront as a prerequisite for governance. It's cost a lot of time and energy and a lot of people to make these changes. And I found out we need to be better problem solvers. Maybe the blue widget isn't the solution, but there may be a better one. We need to look at that carefully together, pull in the right experts. We had a lot of people in the field just coming forward with ideas, and we would just do it without testing it. And then measure, measure, measure. And finally, as a governance body that I lead, we want to be accountable. We hold ourselves accountable to the organization and to each other to make sure we're doing our best for the resources we have. And that's my presentation. Any questions for me?
I do have a couple of questions already laid out, but I would love to hear from everybody in the audience. If you've got a question, please let's start with you, and then I'll pass on my question. Any questions from this center? Sure.
It is a well-known vendor that we use. We actually use multiple vendors, and it's a well-established vendor that we took out of the box and then made some modifications to fit our system.
So we find that the system that when it comes in originally is pretty good and you're okay with it at the beginning, but as you're using it, you find flaws. And the only reason I'm asking from a nursing perspective, most of the systems are designed by engineers. They think very differently. And I'm just wondering how, if we could get back to the design phase and bring more clinicians in, that means that would have a better system.
Absolutely, I agree with you. And I think that setting it up at the beginning is key, having the right clinicians at the table to make those decisions design up front. Yes.
Any other question? I mean, your question is very limited from one aspect and multiple aspects for one particular. I've always asked myself, when you're designing IT ERP systems or, complex multi-user systems, how come you don't focus on those that are users? The end user should dictate how to design, and the end user is the right person to tell you, I depend on player X, player Y, or player Z to do my job, to get my process streamlined and the value obtained from A. I like the word Z by the way, you'll notice that. So I've noticed that this is truly a problem with big. I've had the privilege of deploying two, EMR systems, two well-known names. We don't want to mention names here, but that was the main default. That was the biggest problem that we end up having the pipeline of SNAP at the UAT stage. User application testing for those who are not familiar with this, with this term. And this is the start of a couple of questions, if I may ask.
Absolutely.
Dee, you can chime in if you want to add to points. So I'll set the first question, which is, how come these solution architects never bring to the table the nurses, the largest population in any operator that uses the EMR are the nurses, and they're the biggest population anywhere. Why? I've never had an answer for that over the past year. So is there a reason for it, or do they consider them off the shelf with supplies and it's just a matter of localizing it? What's your take on that?
Absolutely. I think in our organization, we do bring nurses to the table, but they're busy. And particularly right now, getting a nurse to come to a meeting is like pulling teeth, right? They're so busy, they're overwhelmed, they're short-staffed, they're working overtime. And even the managers, the frontline managers who may be secondarily the best qualified to make decisions, they're in staffing now. So trying to get them to the table. And then a lot of these end user requests did come from frontline staff, but they didn't necessarily know how their work affects things downstream. So I think that process, user-centered design process, which includes everyone, is important.
You're absolutely right. And I think probably from today's summit, what we would highly recommend organizations to do is to work with those vendors to create questionnaires that are quick, can be answered virtually on the phone, and let them get consultants that are nurses or are physicians that have retired because they know what they've been doing for the past 35 plus years, right? If they can't get the people to get away from the front line,
their design model and methodology of approach needs to change. And this is the whole purpose of us meeting today. That is one thing that I'm very glad that your presentation touched on. And any question, any introduction on this pointer, or can we move on, please? It's all right.
Eric, so we go back a couple of slides, you had four items put up, put that one there. And the last one there, particularly addresses the orthopedics. And when they scientists began their program, they brought in key players. They brought in infants, they brought in physical therapists, they brought in the care manager, it was my role, and the social workers. So we all sat down, and it took many, many months to get the process in place. We tried it for a year, when we applied for drug commission certification. And as a group, we again presented that successfully. But the point going forward is very valid, really hard, we've seen that. Around cost.
Because we're asked to provide and present a cost, benefit analysis, visibility study before we introduce any of the cost of that. So pretty much. So that's actually not very big, because whenever an organization needs to kind of invest, there has to be a return on that. There has to be an ROI clear from day one. And probably that's what we're not probably doing in healthcare, if not in any other industry, because it applies anywhere. And why I'm saying this? Because usually the most people that know where the true problems are the people on the front line. They live with the patient, they deal with it. Even back then, not undermining the efforts of the back end folks, they know what needs to change, but they don't have that channel to communicate that and to make that change happen. So on the point of cost benefit analysis happening at the lab stage, that's a problem on its own.
I agree.
Yes. So how do you feel, or how do you think we can do better on that? And who truly defines what a positive ROI looks like? It comes back to that they say, well done, folks. That 5 million or that 2 million was worth the investment. And let us show you from data, are those people within our healthcare kind of operations in your opinion?
Absolutely. In my opinion, that is where your informatics staff can help, because most of us are clinicians already, and we understand the back end and we understand the front end. Now, we still do need our front end folks to come to the table and talk with us. But defining value, which is slightly different from ROI, is important. I do have some very specific examples in the collateral. If you get the slides, you'll see. One of those was, for example, an order for AZT during delivery for moms who are HIV positive to not pass HIV to the babies. Very complex dosing, timing regimen required, and the EHR, we built it to make it easier and eliminate mistakes. It was only used 4 times in a year. And so I was trying to think, how is this add value at only 4 patients? But then I looked at, well, those 4 babies, if they had contracted HIV at birth, the lifespan is 10 years. So we have 4 babies that now will live beyond 10 years of age. What price can you put on that? So I feel like it needs to be some of the clinical mindset, but then we need the financial acumen to come together. And we do need to do it up front. I totally agree with you.
The other point that was very interesting to hear is that you openly and transparently said order sets were built because of preference of the physician that led. That's a reality that we all go through. And the funny part, every time you deal with informatics, they always say order sets, let's go with order sets. And then let's tweak what other hospitals have done, or let's tweak what we've done for other clients. Now, order sets is not rocket science. It's a straightforward process. Now, the thing is, do you see that we are falling behind in terms of when we roll out order sets and it's time to train people on it? Are we training them well? Are we including the right people in the training? Are we having the right folks in the room telling them this is probably something that Dr. X has ordered or asked us to build, but you guys also need to know about it. How do we train folks on newly introduced order cuts is my question. What's your take on that one?
That's a great question. And to me, it's like a chicken or egg question, right? Because what comes first is the clinical knowledge that defines what goes in the order set. You're right, building an order set's easy. It's just who gets to decide what that content is. What is best practice? And is best practice the same in every hospital? And who gets to decide that? I think everyone struggles, and our organization is so big. We have so many doctors and 25,000 doctors, and trying to get 2 of them to agree on how they practice is impossible. I think that is the dilemma for the next year to figure that out.
Any take on this last point, please? And
So I think my question is, I'm tying it back to that conversation. So looking at the outcome number 2, that was unsuccessful. And in my mind, I question why. Was it a situation where an improper order set was part of the methodology into that design? And maybe they didn't take the caregiver, the physician's, plan of care into consideration when that logic was built out. So I was wanting to understand what was the rationale behind the physicians creating a workaround to not use that particular, methodology that was provided. And then with that, was there any learning from that? What was the outcome? And if that's something to be answered to.
That's great. I love that question. And so you're right, this order was only one component in a whole program around education, understanding patient needs, reporting, that sort of thing. And this came from a lab director who was erroneously, I think, tasked with being accountable for changing this practice, which shouldn't have happened. It should have been physician-led, right? It's a physician practice. So she was trying to force, physicians, because she can't tell them what to do, force them into this by creating this hard stop that you could not order blood outside these parameters. Well, that just doesn't work because it's not realistic. And so physicians found a backdoor and did what they did. So I think it was poorly thought out in the beginning, poorly designed. We had one person coming in with one point of view, and it was built for her. Does that answer your question? Yeah. And I hope that I'm not the only one that sees these things. Our organization is the only one, but I think until we expose this and talk about it, we can't fix it. Yeah.
You're absolutely right. Denial is our biggest enemy, I guess. The question I've always had is that when people look at informatics in hospitals, I think we need a mic, ladies. We need a mic to roam around so that we can all hear each other. Just gonna try and touch my face. I can see you. So when we look at informatics, we always tell you those are IT folks.
Can you speak
We
from
always
here?
classify them as IT folks.
Yeah.
Now, the best informatics I've ever worked with. The best, that's really loud. The best informatics I've ever worked with were actually ex-nurses or ex-clinicians.
Yes.
Because they are able to articulate what's in the minds of the caregivers into the word of IT based on their training and their certifications now. In your perspective, doctor, do you see that informatics should reside under what area within the organization for maximum and most optimization? Our talent today is all about optimizing our, EMR or our electronic health records. Where should they reside so that they've got the autonomy of application? They're able to push back on sensible requirements that come center, left, and right. And that brings me later on to the final question on my side is where should they start? Let's start with where should they reside in the organizations typically?
Sure, that's a great question. I was just having this conversation with my new boss yesterday, trying to orient her to informatics. So I agree, informatics should be clinical, usually 90% of us are clinicians. About 60% in the US reside in a clinical tower. They report up to the chief medical officer or chief nursing officer in an organization, and about 40% report to IT today. Personally, my preference is to report up to clinical leadership. We are clinicians and we advocate for clinical practice. And so I think that's where we should fall. That's my opinion. Yeah.
Well, your opinion actually matters a lot because I
thank you.
think most of us in the room see this, consider this the true dilemma. Is that not being under IT, puts us under, IT support limitations, the IT governance body, the whole pipeline of IT requirements that are not necessarily aligned with the model of operation and care that any organization wants to kind of provision. All right, that brings me,
Can I add to that just real quick?
course.
I think IT is wonderful. They do great work, but there's a real cultural divide. IT's vision of what's good enough and a clinical vision of what's good enough are very different. And so I worked at IT and I was told, shut up, sit in the back, you're causing problems by raising concerns. So that's my personal bias.
you're absolutely right. Yeah,
Thank you. Thank you. What I want to add, if we will analyze everything and we return back for the multidisciplinary approach in the together. When we go back for the process and we have everyone on the table from the clinician and from IT perspective, because they are designing the process, that the time we will have enough team with all the requirements. I found during all my experience that the healthcare practitioner, if they are not engaged in the beginning in the process, they will feel they are not part of this project, and by the end, they will not cooperate or they will not interested to come over with the notification required or to participate in the system.
Yeah.
Usually the clinicians are, and mainly the physician more than nursing, they are too much cooperative. But
Yeah.
physicians, they need to be engaged in the beginning. They need to understand the demand and how much is the value for them to add the process in the care. They have the concept that they all the time doing the care, they are treating the patient as patient. They not look for the system. They're not looking for electronic prescription. They not look for all those, and they found it all the time challenge, which is to make the process of the work.
Yeah.
So if you're not in the development, we understand the need demand. They to help us to design the process. You're not hold the ideas. So again, we will come back for the description for the team as we identify in the stage number 2. I think all the things is coming with the communication, and we need to have also the end user who really doing the documentation, because sometimes we are asking the managerial, which they are lifting the documentation long time, and they are not knowing the upgrading the process. And that's why we have the team, they are coming out of the process, and then when the system comes, they make shortcut to process.
Yes, yes.
Thank you.
Excellent point. Yes.
Okay, on that note, when you said that they typically go with, order sets to bypass broken processes or bottleneck processes for the sake of conversation. How does the change process in the world of informatics look like? Who dictates the change? Who approves it from a governance perspective? And when do you go through with it? And when do you terminate it early on? And who has that say? For those who are not very well versed about informatics and all the dynamics with it, obviously half of the group probably is very well versed, but for those online.
Excellent question. And I would say the beauty is in the eye of the beholder on this. What I have found to be most successful is to bring in the multidisciplinary team, have IT, frontline users, stakeholders at the table, and we design a process together and decision rights together. And it needs to be democratic, and it needs to have clear expectations up front. I think that's what's been lacking in this process. This is my third organization of standing up a process like this. And so where I've been successful in the past is to design it together. The decision rights, it has to be democratic because everyone should be able to have a way to stop the line. You guys are familiar with Toyota Lean methodology, right? Anybody should, something's wrong, this doesn't make sense. We have to figure out how to do it, make it fit for everyone across the board. Does that help? It's a great question, and I think a very complex issue.
It does
Hard to
very much.
articulate.
I mean, there are so many projects in healthcare that start and never finish.
Yes.
And nobody knows it. I can see people nodding their heads around them. And
Yes.
the true dilemma is that we never get that why. What went wrong? What should have we done better, right?
Yes.
And what lessons can we take for the next one? Do we have a repository of case studies that we can learn from? Do we have a spearheader within our organizations that drive change, be it informatics in nature, be it operational in nature, whether clinical or like business support, that is an issue. Do you see that often, like quite often in your field of operation, doctor?
Absolutely. And our organization has recently adopted practice of high reliability organizations. We're looking at those tenets and how to apply them. And I think establishing those standard practices to this is what we need to do. Learning from our mistakes. We don't know what we're doing sometimes. We go in and we're doing things that have never been done before, at least in our organization. So how do we do it well, do our best, but then constantly evaluate and measure, did we succeed, and iterate into a better solution? Yeah.
Dr. Barbara, right? All right. So you've mentioned something very interesting and intriguing. It's we were working together for the sake of readiness for JCI. How many of us in this room are very fixated on accreditations and getting that recognition? Show of hands, please. All right. So the thing is, where do you see informatics making a change for readiness? Whether for JCI, whether for leads, whether for methods, for the nurses, whether for pathway, any accreditation out there.
Yes.
Where does informatics come into the picture? We've got a wealth of data. Big data resides in our electronic medical records. Nobody's making use of it when it comes to, are we doing it the right way? I see you nodding your head.
Yep.
And shouldn't, I think the right question here, shouldn't informatics be the changer, the driver of change, whether for readiness for JCI or whether for any project, be it a strategic project, be it a normal operational project, that management should look at it in the management agenda of that particular year. I would love to hear your insights, ladies, because I really think that informatics has always been the receiver end of requirements, rather the generator and the engine of big data analysis within healthcare that drives change. What's your take on it? Love to hear from both of you.
Yes, good.
Just still perspective. Worked with the team for as long as I did. And having worked in care management. I think part of the problem is finding somebody who is skilled enough to gather that data. The data is out there, but as nurses, we're not necessarily taught those skills. So I think part of it comes down just to education.
That's a great point. I'm gonna add on that while we're getting the mic to you. So informatics is the study of information, right? And that's what we do, is we follow the information, and data analysis is part of that. And then just knowing where the information flies and how it all fits together. So we have that skill set to bring to the table. And so often we feel like we get called after the fact, oh, it's broken, or, oh, Joint Commission's here, come answer their questions. Like, oh, we could have prepared you. We could have had more to do with this. Thanks.
So yes, I am a nurse, but also work for a regulatory agency. I work for Food and Drug Administration.
Oh, nice.
So in hearing this conversation, we want to use the information, but we find it, the standardization of it prohibits us from using it in useful ways. So I don't know if it's education, don't know exactly what it is, but I'm really thrilled to hear this conversation, because from a regulatory perspective, we want to use this information, but it's really hard to, since it is all big data, to make sense of it. So
I can't agree more.
Yes.
And there's one thing that I've realized over the past 2 years in particular, when I kind of started researching into that arena, is that we don't have specialized organizations that the likes of the regulators, the likes of the operators, or even consultancies can tap into their expertise and make use of the data that resides in their day-to-day operation. And I don't know if you agree with me, probably that is one of the key takeaways from your section, Doctor, is that we need further deep dives into big data that supports the informatics world, so that we can drive change that truly makes a difference from a revenue perspective, from a patient journey and patient centricity, and from a regulatory guidance and accreditation. So do we agree on that as a summary? I'm glad to hear that. So
thank you.
Thank you so much, Doctor. It was very insightful. I think your experience in this arena says it all.
Mhm.
You've got a challenging project, I
Yes.
have to say,
Yes.
and we wish you all the best. Thank you so much.
Thank you so
Thank
much.
you.
Thank
Thank
you.
you.
Thank you. It was an honor. to speak to you.
Okay, I'm not gonna go to the podium, so I'm just gonna stand over here. Yes. Okay, we've got a couple of more minutes, so allow me just to present to you your certificate, Dr. Karen. Thank you so much for your time. It was very.
Where to state that, huh? Where to state?
No.
It's not, all right.
Let's move it into the light.
Yes. Okay. So much for your time.
And just see.
Okay. Okay, who's next? We have a packed schedule for today, so I'd like to invite our next presenter, which is Mr. Athmar Al-Hers from Saudi Arabia. Sorry? Miss Athmar.
Thank you so much.
Not
No problem at all.
To present our speech on opportunities and challenges for healthcare informatics. Informatics seems to be like the overarching discussion topic for today. And health informatics management profession from Saudi Arabia in particular. So I think there's a lot of case studies that you kind of take us through.
Yes.
Yeah, you've got case studies that you'd like to take us through?
It's
or
my
is it
research
your
study,
research?
qualitative studies.
Perfect. So I'm passing on the stage to you. Thank you.
Sure. Which one? Okay. That's it. Okay. Is there a microphone or does
Here,
he
you
need?
can- use that one.
Good morning, everybody. My name is Athmar Al-Hers. I'm health informatics specialist. I would like to present my research work, which is titled under the opportunities and challenges for health informatics and information management professions in KSA. So I will discuss a brief overview about the study, the main objective of the research, the methods that have been processed, the statistical analysis, the results that we come with it, the discussion, conclusion, limitation, and reference. In Saudi Arabia, healthcare authorities and governments have realized the significance of the health informatics and information management professions role and how much it has a huge impact on the quality and the services of the patient care. And they work very hard in order to promote the opportunities of the education. Hence, there are academic educational programs have been commenced by many different universities in order to produce a well and competent cadre in this field, such as King Saud bin Abdulaziz University for Health Science, where the College of the Public Health and Health Informatics provide the health informatics and training and education for the students with different backgrounds, such as nurses, physicians, and other healthcare providers. Also, it provides the program with other students with other different backgrounds, such as computer science and information technology. Also, we have Imam Abdurrahman bin Faisal, which is called also at Dammam University, where the College of the Public Health offers a bachelor degree of the health information management and technology for, in order to produce a distinguished academic qualified cadre in this field. Besides the educational opportunities, we found there is also clinical opportunities, like in Royal Commission Hospital in Al Jubail Industrial City has accomplished a great achievement that was cut off during the success digital health transformation journey. And one of the success stories is HIM7 accreditation, which means that the hospital is completely matured with electronic health record, external health information, data analytics, governance, and data privacy. Such these eminent achievements opened tremendous opportunities for the health information technology professionals to apply their job roles more effectively and with high efficiency, and to enhance their work performance. According to the several studies conducted, they have indicated that one of the major opportunity for the HIIM professionals is the top digital initiatives of Saudi Vision 2030, because it targets to promote the workforce competency and to enhance the education and the training for this profession. Sorry. Also, we have Saudi government leadership. Saudi governments are putting tremendous efforts for the investments of the information and communication technology. They have invested for around $15 billion since 2017, and this was a vital first step for the Saudi Vision 2030. Also, we have the rapid implementation of electronic health record were indicated as one of the major opportunity, because as I mentioned, it allowed the health information technology professionals to apply their job roles more effectively with high efficiency. Also, we have found availability of academic and educational programs as one of the major opportunity, like the academic and the training affairs in the Royal Commission Hospital has a strategic goal to enhance the HIT professionals through providing continuous technical business and project management programs. So we have also some of the studies, they found several challenges for the HIIM professionals, such as there is no clear linkage between the health information management educational program and job market demands to cover the growing demands of the professions in this field. Also, the second challenge, we found shortage of job activities and job titles of the HIIM professionals, and also the lack of information about the HIIM role. And we can gather these two challenges with the one reason, is that there is no specific career framework applied yet to be linked with the educational programs. Also, unsustainability of the profession's job title due to the rapid deployment and the massive changes of the nature of the work. And some of the several studies recommend to create career matrix model in order to incorporate multiple career pathways in this field. Also, the march into big data, the ubiquitously of the digital data, and how the data can be harnessed, managed, that requires inclusive understanding. So my research study again, in order to know the opportunities and challenges in this field. And beside this main objective, I have assessed the characteristics of the HIIM professionals from all over the levels: senior middle management professional, alumni students, and undergraduate students. Also, I have applied the SWOT analysis framework in order to determine the strengths, weakness, opportunities, and threats that are encountered by those professions. Then I've moved into the strategic objectives, where each strategy has a recommendation from the international bodies. The study has been processed with the three main stages. The first stage is the identification of the informants from all over the levels. Then I have conducted the interviews from many sites, such as King Saud bin Abdulaziz University for Health Science, National Guard Hospital, and Al-Ahsa University, and also in HIMSS conference, which was held in Riyadh. Then I have analyzed the data by using the in vivo qualitative data analysis software package. 45 informants consented to participate in this interview. And here's the profile of the key participants in my research. And here's the SWOT analysis framework. And here we are with the must SWOT that have been recognized and indicated by the informants. Let's go to the first point, which is the strengths. The first point is the rapid and the growth and motivation of the HIIM professionals. Many informants indicated that there is a rapid growth and motivation of the HIIM professionals because Saudi young generation in this field are open-minded and hardworking. Also, there is a skilled and qualified Saudi HIIM professionals, although there is a shortage and lack of experts and competent professionals in this field. It was noted that there is a very qualified and competent cadre. Also, a huge number of participation of the professionals in the conference were noted are rapidly increasing in the last few years. Beside the strengths, we will discuss about the weakness, shortage of specialized faculty in HII and KSA universities, because many of the faculty are with different backgrounds, such as computer science and information technology, and they are not specialized in this field. Also, we have found shortage of Saudi professionals of the HIIM field. The current number do not cover the growing demands of these professions in this field. The marketing and advocacy were noted also as one of the weakness, because there's no career framework applied yet, and this impacts the marketing. Workforce demands and related issues, such as the workforce shortage and the poor workforce planning. And some of the informants indicated that there is a need for a single body to represent all the issues of the workforce demands and career opportunities. Let's go to the opportunities now. The National Transformational Program by Saudi Vision 2030. This strategic objective is very purposive because it targets to provide the citizens with the required education and the training to cover their demands for these professions. Also, high-level and top leadership support from the government for promoting the HIIM professions. The Saudi government are putting tremendous efforts in order to provide the opportunities for the citizens, such as provide the needed education and the training. We have strong academic and training programs in King Saud bin Abdulaziz University and at Dammam University. We're noted as one of the opportunity, and specialized and expert faculty of the HIIM and KSA and at Dammam University. Let's go to the threats. We have lack of clarity of the HIIM career pathway and career opportunities. Because as I mentioned, there's no specific career framework applied yet to be linked to the educational programs. Inconsistency in the definition of the HIIM and misinterpretation of the nature of professions. Also, as I mentioned, because of the rapid deployments and massive changes. Health information technology colleges are ununified and there are no core modules applied yet to involve in the curriculum. There's a need for a single body to guide this curriculum of the education, such as Saudi Association for Health Informatics must cooperate and be engaged with the American Medical Informatics regional bodies, such as the Middle East Association for Health Informatics, to produce a unified HI curriculum. This is scattering promises and great opportunities. It takes a huge place due to the 2030 visionary innovation for the digital health transformation. And this targets to overcome the workforce demands by putting strong workforce planning. And there will be a clear career pathway in order to align the educational background with the profession's role. According to the Digital Health Blueprint for the top initiatives of the Saudi Vision 2030, they have both strategic objectives to enhance the HIIM professions and the growing demands of this field. One of the, we have highlighted 4 main strategic objectives. Each strategy has a recommendation from the international bodies. Let's discuss about the first strategic objective. We have the workforce planning. There is a resistant need to create Saudi health informatics and health information management career pathway and align it with the educational program. According to the Commission on Accreditation for Health Informatics and Information Management Education, they have recommended to develop the candidate enters career pathway to incorporate multiple career paths in this model. And this would be so recommended and suggested from them. We have Saudi HI or HIM colleges are united under a unified body. There is also, as I mentioned, there is a need for Saudi Association, for example, for health informatics to be engaged and cooperated with the with the American Medical Informatics Association to produce at least HI curricula. The same thing with the American Health Information Management Association to engage and be cooperated with the Commission on Accreditation for Health Informatics and Information Management education to produce at least health information management, unified health information management curricula. So let's go to the third strategic objective, building a strong collaboration among HIIM professionals and faculties. The HIIM professionals are required and recommended to work more collaboratively with each other. And according to the recommendation from the international bodies and from several studies, they have recommended to have strong collaborative efforts between the educational institutions in order to produce a well and competent cadre in this field. The final strategic objective we have, linking the educational program with the market needs. There is a need from the Ministry of Labor and from the national bodies to give us a vital information about the future market demands and what are the career opportunities that will be in this field. In conclusion, Crown Prince Mohammed bin Salman, God bless him, he stated success stories always start with a vision, and the most successful visions are those that build on strengths. And the digital top initiatives, the Saudi Vision 2030, will promote the strengths and the opportunities and to promise the people around this field to have a better skills and education through a clear roadmap of the required qualifications. Thank you. Any question?
Thank you so much.
Thank you so much.
Thank you so much for a lot of information, I
Yeah,
have to say.
very huge. I'm trying to say the high level.
No, actually,
Amazing.
it's a very interesting research topic, and I'll tell you why it's interesting, but I'd like to hear from the audience if they've got any questions on the slides that were presented before we start our kind of dialogue. Any specifics that the audience would like to ask? Not quite, okay. All right, is this a PhD or is this a dissertation?
Master.
Masters, so
Yeah.
it's a thesis for masters. Obviously, you've kind of articulated the true problem statement, the whole analysis, and the conclusion element of it. And you did a very insightful SWOT analysis, I have to say. So my questions, probably, and that of the audience, where I'd really depend on you to chime in, are on the challenges,
Sure.
the weaknesses, because I think it's not only for Saudi Arabia's market, it's for any developing market that puts long-term strategies. We're hearing it 2070, UAE, 2030, Saudi, mainly from the GCC area, but also in the MENA region, as we call it, which is Middle East and Levant areas. They also are looking into that element just from the researches that I'm reading. Now, coming into the US and the UK markets, I think I can see him wink over there, is that we do have a lot of work to be done as well in that arena. And this is where I'm going to start our dialogue.
Yeah.
So team, I'm not going to call you team now. Do we all know what HIMSS is all about in this room? Do we all know what HIMSS stands for? Right? So would you like to introduce us about it? Because I was concerned about that point.
HIMSS is the accreditation. We have reached the HIMSS 7, which means there are stages for the HIMSS. HIMSS 7 means that we have reached the final stage of the maturity for the electronic health record in the hospital. As I mentioned, that HIMSS 7 means that the hospital, when the hospital got HIMSS 7, that means that the hospital is completely matured with electronic health record, the external health information exchange, with the data governance, data security, and privacy. So the hospital is fully digitalized from all over the circumstances, and it's integrated with so many systems. So that's what I can say regarding the HIMSS 7.
Is coding part of the CID 10 and 11 and all the codes for
The system has us.
So first of all, it's a very great presentation that you presented just now. But my question is regarding the HIMSS itself.
As you say that it's accreditation, right?
Right.
Yeah, so it's like, it's an international accreditation or just a national
Yes.
level?
That's
International.
Yeah.
So regarding the type of the integration system that, what kind of system you're using in your current hospital, for example? Do you have a unified like HIS system? That's why you get the HIM based on that?
Yes.
Or there's like every hospital or every authority, health authority, they got, for example, a different, you know, like a HIS system, then they got HIM based on the, you know, like the governance of that and all of that. Because in UAE, we have three authorities, like Abu Dhabi,
Yes.
Dubai, and the North Emirates. And every sector, they have a special like HIS, for example, Cerner, we have like Vester, we have, you know, like Epic. So a
This
lot
is
of
the best
things.
care. Our hospital using this care.
So that's my question.
Yeah.
Like, do you have a unified system? That's why, based on the quality of the system, you get the hands accredited by hand.
Yes.
That's my question. Just ignore about it. Thank you.
Thank you so much for your question. We have reached HAM7, exactly. It's not just an accreditation directly to the HAM7. It reached the stages. First, it will go since, it will go since from the beginning until 6, then 7, like there are stages, okay? Previously, we got HAM6, which means that means there are several standards still we didn't meet these standards in the hospital. Not fully integrated with the other systems, like the patient safety standards in the system not fully met, and there are some points HIMSS are looking for. So that's why still that time we didn't reach the HIMSS7. But we have moved into the progress and the upgrade of the system to reach the requirements. Firstly, for the patient safety, lastly, for the accreditation for sure. And it was based on specific requirements from the HIMSS. We have moved into these requirements. Most of the requirements, as I said, for patient safety. Like, for example, we have the closed loop medication administration. It was one of the requirements for the HIMSS7, which means that the closed loop means that the nurse is giving the medication to the patient with the 5 rights. Five right patients, right medication, right time, right route, right dose. So we have to reach this technique, and we have to apply this technique more properly and correctly. We have did so many tests in order to make sure that this technique is working properly. And thanks God that it has been applied successfully. And this is one of the requirements, as I mentioned, from the HIMSS7. Yeah.
I have to build on your question because it's a very good question that you've raised. And luckily we've got in the room folks that have actually built those modules. So to answer your points, and probably that's where your expertise and your insights come from the research, assume you don't have a system, a proper module within the electronic medical records in the hospital that you operate in or whatever organization. Would you be able to do your processes that allows you to disassemble medical records accurately, safely, confidentially, and have a repository that doesn't fade away due to the elements of, you know, the weather and storage and all aspects of it? Would you be able to do that? Let's start with that pointer to come into the answer to your point.
Yes, for sure.
If you want to stand on the podium, that will be easier for you using that mic.
Okay. We have health information management departments in the hospital who are managing the medical records and to guarantee that the medical records are not disclosed to anybody. And there are restrictions in our system so that not all the healthcare givers, they can see the medical records, such as the psychiatry medical records is not disclosed for all the end users. There are privileges and rules. It should be given to the right person, and also with the approval from the management level. We have also confidentiality process we are moving into the system, such as other medical records. Some of the medical records with incidents it happens in the Saudi Arabia cases. It needs to be like this medical record to be restricted. So we do it in our database. So there are certain techniques and the process we are moving to it, so that to make sure that not all the medical records are disclosed, or it can be accessed by the healthcare providers easily.
Currently, what standard, to your question, what standard do you currently follow? Is it the HIPAA standards? Are there specific standards that you currently, because regardless of what country of operation, we all have to follow a standard for patient, confidentiality, if I'm not mistaken. Do you follow that?
Well,
Regardless of how many operators you have by territory?
well, definitely there will be a follow. I'm not gonna speak on their behalf because I'm not that shy. I'm prospective part because I'm a pharmacy manager, so I'm not that part. But definitely we have a system that to assure that the disclosure of all the medical record actually is on site. So
Okay.
to assure that it will be the safety, the storage proper, the how to reach it at the medical healthcare, how we can actually get the access to that record, how we can present it sometime, even the transmission from, for example, well, in the beginning of the day that in the initially that when we built the hospital like 8 years back, there was a manual, like record that we keep it. Then how we established the best, because we had the best coverage as well.
Yes.
So we have to actually upload that on the system. So the transition, like we got like a Gantt chart. We follow that to assure everything to avoid any leak, use data. So, but to hear about the accreditation, that's quite interesting because even I'm not like, IT or informatics perspective, but to hear that also it's kind of related to like as a healthcare, because at the end you make assure the safety and the confidentiality of the whole medical record, because at the end you have the input and that as well. So to assure that this is brilliant actually. So
Do
and
you
maybe go
feel
back
that we
to
have to standardize the way we handle our medical records in this industry? I mean, if we go into a number of hospitals, do we assume that we're going to get the same kind of processes in each and every? I can see the face and a smile. Do we feel that we have a standard way of handling our medical records in our operators? So that's the key thing here. Everybody's talking about digitalization, transformation, investing in IT, accreditation, standards, left, center, and right. But reality check is, if we can do it right manually, we can digitalize whatever we want out there. I'd like to hear your thoughts.
I would say something. One of our challenges in my country is to develop database, national database. And why we try to develop national database to help in a lot of the healthcare. As we know, and I'm from Jordan, as we know all of us that the healthcare is the most expensive or the costly in any country. And all the people, they have right to get the patient, the care itself. So once you develop the national database, which will be help to transfer the data for accessibility, more availability, and to facilitate reducing the cost. The main challenge was in that one that the coding for the data is not standardized based on everyone he has his way, and they develop the entering for the data in different methods, which is lead in unstandardized analysis. You cannot share it together. So again, if we are going for any system, we need to standardize the process, how to enter the data, because we are not looking for the data as data itself. All the time we are having a huge data, but how we are able to analyze it, how we are able to read it. Is it clear to be read? Is it correct? Is it accurate to have a judgment? And because we need the data to develop on that data, the management. We need to develop the action. We need to develop our strategy. We need to develop our budget as well. But in the beginning, if the data is not clean, not secure, is not in proper intent, everyone here has bias in his data, it will not help us.
I'm fully agree.
And that's the main issue.
Exactly.
with the data. Now, in the accreditation or HEMS, this is like a standard that to be sure that the system, what you have is aligned with the standard protecting the HIPAA standards, which is related to the patient right and the patient confidentiality, how you are releasing the data, how you are storage the data, how you are enter the diagnosis with ICD-10, how you are able to analyze and thinking in the future with market data. Also, if you have the system shut down, how you are able to how you are able to continue with the treatment for the patient during the shutdown, because this is also the safety main pillar. If you are going for modification for the data, what the method you are applying for modify the data, how you are sure that you have the original data going on modify based on what? Is it entered in the global standards or not? The risk matrix when you apply for the backup system, is it in the cloud solution or you have it in another way? You have the backup retrieving, all these things is into it. And all the business standard is used in the health certification.
Yes.
This system you are using. Are you applying those or not? In the end, we are looking for engagement patient or patient to have the right decision to take. So that's why the health is looking for the close grouping, see the input of the patient. Is he participate in the management or the care or no? That's why I highlighted the medication, patient identification in the sampling. Taking the patient also to be participant. Also some system they are integrated with the education to have the input in the education to participate. Because now all the people is develop patients in the care. So we need to be sure that our system will be clear, we also understand that. I hope that we are able to ask.
I mean, is this the case?
I would add for this, thank you so much for your feedback. Actually, yes, we've got the HIM7 also because we have, regarding the data backup, we have the contingency system. This contingency system is very useful once the best care is shut down, the system, the healthcare providers can view the patient's information, the diagnosis, all the history, the medications, the lab results. It is up to date every 1 hour. It retrieves the data. 1 hour, yes, up to date. And also he can print the lab results, the medications. It's very useful and they are very satisfied regarding this contingency. For the HIPAA, yes, we have the HIPAA standards and it's already implemented with the system. Let's say regarding the third point you mentioned regarding, regarding the data, how it can be used and how much it is useful in the department. We have the business intelligence and application management department. They are using TOAD, this TOAD to process the data and make it and then export dashboards and statistical analysis for the end user. Also, it is very useful in order, for example, to indicate the top 10 diseases, the top 10 diagnoses, the top 10 procedural purposes. This is very also useful. So, yeah, I hope I answered your inquiry.
A lot of great points. I mean, it does touch on all of us, all of our operating in different markets. And I think we can see the faces. All right. A couple of more pointers. If we can go back to the SWOT slide, if that's okay. So given the fact that we're trying to learn from the challenges of other arenas and other markets. The SWOT, exactly that one. Great. So the shortage of specialized faculty in HIMSS in KSA universities.
Yes.
If we take a step back and a show of hands, do you feel that the programs, whether in the US or whether in the UK or whether in any other market out there, do we have programs that will kind of graduate people that are technically capable, understanding what customer centricity is, dealing with a lot of medical records professionals over the years? There's one thing that unfortunately they're very good at. They're very technically savvy, they're very well trained, but they lack that human touch when they deal with family members, when they deal with a patient that just is discharging and they don't want to hear any more talks about how things are not working for them and their treatment plan. And they don't want to go into the loops and the hoops of approvals because it's at times very bureaucratic to get a medical record out of a hospital archive. Do you feel that those programs across the world are sufficient enough in healthcare to generate a generation of HIMSS professionals that know how to deal with patients, discharged patients and their family members. What's your take on that?
From my point of view, I don't think so. We have standards. We all of us know that standardization is very important. To have a standardized curriculum to guide the professionals in this field, to have a better knowledge and how to combine technical, clinical, and also the business side. We need this field to be more advanced, to be more standardized, and to be cooperated with the international bodies. It's very essential and important. I think it will make a huge impact if there will be a collaboration between the international and national bodies. Currently, me, from my experience, I'm a master's student in health informatics, graduate, and I have studied the curriculum, but I missed something. I didn't touch the experience in the clinical field. I didn't went to the organization, and I didn't see the electronic health record, how it is going on, how the healthcare professionals are using this system. It was really purely theoretical curriculum. And I missed the clinical side. So I just write like proposals and from my researches, when I looked to the research and I searched the articles, but I didn't experience that one, the healthcare technology professionals, how they are using the system. Unless I graduated, then I worked. Now I have 4 years experience in this field. Thanks God that now I can combine the aspects from the nursing side and from the technical side, because I have a bachelor degree of nursing. So this makes me feel very satisfied for my profession role, as I play a multidisciplinary role in this department.
Very refreshing answer for a reason. Obviously, placements, rotations for this particular line of business is essential, which is not what the programs are delivering to us. They're outputting people that are very conceptual, yes, but not ready to run and do the work to the level that we expect in healthcare. And this is where we call upon from the summit that more and more practical experience is injected into those programs. Placements, rotations for 6 months, if not the final year of graduation, should become a must. Or else you're going to be, nurses mainly, end up getting stuck with newbies coming through the door, not knowing what needs to be done where. And that is more burden for them, because usually the doctors expect everything to be done after the consultation is done. What do you think? Do we need such a change in those programs from a training perspective? I think there's nods. Yeah, it's a very good point. Thank you.
Thank you so much.
I think probably not the last question, but we'll see how it goes. It's very unfortunate that I've realized this career is very fixated on, if you're a female, you go into that career. The majority of people that are enrolled in this line of education and in this line of work happens to be females, mainly for cultural reasons. I'm just asking here because you've mentioned the case of Saudi Arabia.
Yes.
Even though there's a lot of interaction with the community, a lot of back and forth communication with discharged patients or the family members or their, family members after they're deceased. And do you feel that this is still the case there, or has it evolved into more opening for both genders to take this as a career profession?
Actually, let's say about female, maybe we have enthusiasm regarding this. But I have no specific answer to guarantee how much, if it is really the female are the majority of us are female who are heading to that profession. But I can guarantee to you that there is a very enthusiasm from both sides in Saudi Arabia, as long as we have a digital transformation program, and the Saudi Vision 2030 are heading to make the hospitals fully digitalized with the system. And we have really a huge number of students who are really interested to have a feedback and to have more information about this field. That's why they need to combine this, as I mentioned, the multidisciplinary aspect from the nursing or from the pharmacy or from the clinical care side with the technical side together to have a real vision for how the electronic health record is processing and how the digital health process is going on in the department.
For the rest of the minutes, I'm going to take this mic, roam around this room, and I'd love to hear your insights around, do you feel digitalization is the solution, be it for medical records or any aspect of healthcare operation? I'd really like to hear from you what you think about it, because I see a lot of the slides coming through are more leaning toward transformation, digitalization. But let's just set the tone and baseline the expectations. What is your say and what do you think about digitalizing in healthcare? Can that happen? Is it okay for me to roam around and answer a question? It does tie to your presentation and let's just understand from the audience. Is that fair? I think this is. All right, we'll start here. What do you think?
So I think that when it comes to digitalization in healthcare, I think that we're not all singing from the same hymn sheet or from the same page. I think there's various platforms from various places and they don't always interconnect. And I think it's a problem. It's like us with the ambulance, you know, we get GP records, but they're not always up to date. But we try and get them when we can, and we have to have patients' permission for that. But even so, the hospital records are not always up to date, and various hospitals, like you said earlier, you can't always guarantee that you're going to get the right information in the right place. You've got to sometimes repeat the information over and over and over again. I think if it was more universal, I think that would improve patient care in many ways, speed of treatment. If someone's coming in, they can't talk for themselves, or the family members don't know exactly what's going on, you can get more information, more accurate, up to date. And I think that all these things are very important in patient care.
I can agree more. You're absolutely right. And that touches on the modification piece that was said here. If something is identified wrongly on a record, how do we modify it, assuming that the physician in charge has left, not around anymore? What change should happen so that the authenticity of the content remains intact? To your points.
Yeah, so I will first talk more about like from patient specific. So country like in India, the government is coming with patient health card, where the entire treatment of the patient is captured at one place. So the thing is that it is very important for a patient to feel that their data is secure to a place, because these are like very personal data which no one wants to get leaked out, or no one will. So the trust needs to be built, even if we are making it digital. Although it will help a lot because the doctor will be able to access the entire medical history of a patient with that one card, just touch and give it, like whether you are getting treatment in US or whether in any country, that is very helpful. But the thing is that there is still as a patient or as a human, we are skeptical about the security measures which these technology will come, like they have the vulnerabilities there. So that needs to be here.
Hello. My take basically with digital transformation of anything, it depends on two things. One is digital literacy. It doesn't just come from the practitioner side, but you have to get the patients educated enough to understand what kind of digital products will be around. The second aspect is the main thing I've been missing is internet equity. If you don't have that, it doesn't matter. You just cannot get a nationalized program for a country like even India, which has one of the cheapest internet now in the world, but still, getting everyone onto a platform. India actually is getting into the main issues that health informatics system is suffering from its application. One is interoperability. Okay, so that we are always skipping that aspect. And second, what is also mentioned, the patient's perspective. Somehow, while we are talking about the nurse and the clinician are kept out of the conversation, it's actually the patient who has no say. There is no focus group or anything ever used in designing these systems. Okay, and another part which I would like to add before this thing is, what exactly are we capturing? You know, what exactly are we capturing when we are talking about health records? Because a patient's day-to-day activity has nothing to do with what you're capturing on health. Okay, what they are doing in the morning. And this is where the systems of fitness and sportsmen and wellness, where they are going for a more individualized and personalized approach, are showing a different path, which I think we should all embrace. So, I mean, everyone who knows here, systems don't talk to each other. You have to, I mean, in US, you still rely on facts. Okay, so I don't know what to talk about digital transformation over there. And,
It's not talking the same language, main system, not basic, anymore,
yes,
is a problem in
yes,
healthcare.
yes.
And so whenever someone designs a system, has to be an end-to-end system that talks smooth and gives us a record that's clear, accurate, and complete.
Yeah,
That's
sure.
ultimately important for federal record together. Are we agreeing on that? All right, okay, thank you so much for this. What's the difference? We've got 10 more minutes, so we're more in the area.
I believe that there's a place for digital information if it's used effectively and efficiently. So what that means is that it is used in a fashion that enhances communication and collaboration. Okay, you can have as many platforms as you want, but if there's no connection from A to Z, there's no point to it. For example, if you have multiple platforms and they don't speak to one another, there's a fraction of communication and collaboration, and there's no continuation of care. There's no continuum of care, and you will have your providers that don't communicate, which means that your patients are not taken care of, and then there's no point of care.
So, it's working for us operationally within those PMRs that has the module, that's the records. Is it working for them? Think nurses use it quite often, even physicians nowadays. It affects in your opinion.
Well, it's going to depend on the user. There are many platforms that are wonderful. It will depend on what your organization has purchased, how it's used, and how the user uses it in itself, what the education looks like, and what the understanding is.
From a pragmatic standpoint, and having the fact that those systems have been, in motion for more than 10 years, give or take the past era, are they working well for them? We communicate effectively for a better patient experience and stronger treatment plan. So the organization invests in the system, train our caregivers, some use it, some don't.
If they're used appropriately and efficiently, and there's communication with the EMR, yes, they can. The end result is with digital transformation. There's a reason why we move towards digitalizing everything, because the end result is communication from A to Z. It's more efficient that way because it's a platform that everyone can utilize, and everyone has access to. Digitalization is it's a digital highway. It's easier for everyone to have access to it. It opens up communication. But in order to have a digital highway and to open up communication, you need to be able to access it and to use it the same way, in the same fashion. Everyone has to, end result is everyone has to play by the rules and use it in the same way. There needs to be no fracture in communication.
Processes and getting to communicate better within healthcare setting. So we run towards speech language, say, you know what, I can't fix it, then why not have a system?
It's a great idea, and I think we're moving in the right direction. There are some kinks in the road, but I think that at the end of the day, I think we're moving in the right direction, is what I can say.
think we'll just wrap up this section. We're going to be conscious of the time and what's your opinion?
Yeah, I totally agree that digitalization is the way to go, but we don't want to boil the ocean. We want to start small. And I think there's so many organizations, it's worked for them. And healthcare is the last, we usually, healthcare doesn't accept everything very quickly. It takes a lot of time. You think about it a lot because people are involved. So you want to be careful. But you definitely want to go that way. I totally agree with you when you said that. And we're only as strong as our weakest link. So it's user dependent. It is the right way to go. I totally. I'm sorry. Yeah.
Totally agree with those insights. So it's subjective, I guess. It's going to take us a while. Thank you so much, everyone. Thank you so much for your presentation.
Thank you so much for. Thank you so much for your time. Thank you. Okay, moving on. I have Dr. Anurag Nair. He's a wellness futurist, forever student of the world medicine. That's how he likes to be introduced. And he's here to talk about the Ayurveda. Is that how you pronounce it?
Yes.
Yeah, perfect. A new age of wellness.
Yes.
So talk to us about wellness. Of course you can. Talk to us about wellness, especially nowadays. It's all about corporate wellness, mind, physical wellness, post-COVID wellness.
So that's actually what exactly defines wellness. Hopefully we can start with that. Just want to make sure that I don't take much time and we can get to the coffee break.
Just 2 minutes. Meanwhile, you can introduce yourself more.
Okay, so let me just give a brief introduction. I have a background in conventional medicine or modern medicine. 6 years back, I took a different route where I started exploring ethnomedicine or traditional medicine, not just for India, but also like in Chinese, African, Peruvian medicine, and every other thing. So one of the things that I came across during the research was like how badly we are interpreting what they had written in their programs. What we are currently practicing is somehow an ancient herbology, and it's not exactly how they had intended their things to be. And here I am right now to demystify the aspects of Ayurveda, which is a millennia-old system of healing based out of India, a sister science to yoga, which you all might be familiar with. And hopefully we can explore together on my journey of what Ayurveda can help us out in today's times. And another 30 minutes.
No worries. We're ahead of schedule, so we're good.
Yeah, thank you so much. We can come here. It's
Okay, so again, namaste, welcome and salam to everyone. Thank you for joining on this session. So Ayurveda, New Age of Wellness, I gave you a little brief. Let me just take you to another thing. So let me first start with the crime history. So our journey starts back in 1890. A British Indian lieutenant by the name of Hamilton Bower, who later became a major general in the Indian Army, he is commissioned to find a fugitive who has murdered a Scotsman and is making his way across the lands of Kashmir, Tibet, all the way to Xinjiang in China. You're talking about almost 100 years prior in those times when this person is making this journey. So this gentleman, during his time to capture this fugitive, ends up meeting few treasure hunters. Through these treasure hunters, he comes discovery of few manuscripts, something scribbled in some ancient language he couldn't understand. He could have thrown that document there and then. He could have not, given the right response to it, what you might have. But this person decided to make sure he not only gets hold of that thing, but also give it to the Asiatic Society of Bengal for its translation. And what we get in that time is something we call as the Boer manuscript. This is the first archaeological, the most oldest archaeological evidence about the Indian system found in China. Okay, and it talks about a certain individual and his practices, and he's given the norm, whom we call as Sushruth. So this is a depiction of Sushruth. Sushruth, whom we now recognize as the father of surgery all across the world. Okay, not Joseph Lister or anyone, way before you can imagine. He was giving prescriptions on how to do nasal deconstruction surgeries, cataract surgeries, prostate gland operations. And you can just imagine during those times, like, how is it possible? But he was the first person, because till then, physicians, until Hippocrates came, every used to attribute everything to God or some heavenly power giving you as a punishment, the diseases that you're suffering from. It's when the Hippocratic thought comes into process and people like Sushruth come in that we have to intervene, and there is more to health. You know, there is environment, there is your behavior, there is a social component also. And these aspects were discussed almost 4,000 years back. But, and it, what we call as, so if you see this thing, you see the sophistication that they follow. They had a proper segregated system where they had a general medicine section, general surgery, pediatrics, toxicology, ophthalmology, psychiatry, rejuvenation or age medicine, you can call it, and sexuology and fertility. So you're talking about such a sophisticated system that existed during that time. But before I further get into this thing, how exactly can Ayurveda help us now? Are we saying that we get into a system where we start practicing this? Not at all. I am trying to say that there are certain things that we can borrow, certain observations, protocols, which can be used in creation of wellness programs and products, which we can use to cater to the times of today. So Ayurveda ends up achieving something which was extremely eco-physiological, personalized medicine, and community wellness at the same time. But again, let's pivot to what we are talking about here. So before that, let me give a context of what exactly we mean by the modern medical miracle. Okay, so all I need to do is show you some stats just to show you how, modern medicine has led to the decline from infant mortality rate all the way as high as 38 out of every 1,000 births, and falling down to such a dismal number. From maternal mortality rate falling from 900 to 1990, and from projected life expectancy. So antibiotics, sterilization techniques, better hygiene, better imaging technology, better critical care, all has brought into the system where we can think about but longer lifespan. But what has this led to? The biggest shortfalls okay, I'm not able to go back. Okay, so the shortfalls of conventional medicine was put to test when the global pandemic happened. You had the largest level stress test happening to the global apparatus. Okay, our systems were not trained to handle this much of input of patients. It's as simple as that. And this is where the patient starts complaining. And this is just before COVID, this data that I'm giving you in 2021, during COVID. So what are the patients talking about? They're talking about cost of accessing treatment. They're talking about bureaucracy. When you look at all these points, we as practitioners also relate with all of it. Even when we go as a patient, we are going to suffer from all of this. Oh. Sorry about that. So apart from that, let's give an idea of exactly how the cost of healthcare also has increased. So this is a data where I'm comparing between 2000 and 2016. So it's a little old, but you can clearly see how things have doubled in just 16 years. So you can just imagine what is the condition now.
You can use this one.
Yeah, thank you. Sorry about that. Apart from that, we have the leading causes of diseases. You can see the 4 horsemen of modern medical mishap, that is your heart diseases, cancer, neurodegenerative diseases like Alzheimer's, and lifestyle disorders like diabetes mellitus, making a huge toll over the humankind right now. Also, we have to look forward of what we are doing. It won't be an unknown virus. It will be a known bacteria, which is somehow, cultivating within our hospitals, which will be, reason for the next epidemic. And we have, pumping it with all those antibiotics in our system. It is learning, it is evolving, and it's just a matter of time. Apart from that, there has been extremely increase in the cases of allergies. You can just see the comparison between baby boomers and Gen Zs, just to understand how prevalent allergy has become. You can just take the cases of peanut allergy, how this simple thing has become so complicated where now you have to advertise about nut allergy. Otherwise, you are talking about someone having an intense allergic reaction. Apart from that, this all led to a complicated situation where doctors and nurses are made overworked. They are input into situation, gone and going, and interns are in 16 hours a day shift, 16 days shift, and it's really tiring. This leads to the whole issue of diagnostic errors, which we are not even discussing. Like how wrong are doctors in many things that they're able to, what they call as their diagnosis. So and this is not happening because they are not learned enough, or this is really happening because of the human case, that they are tired, that they are overworked. Okay, and they are not able to. If you look at the top ones, it's like delay in ordering test. The simple thing where they just forgotten to put in that order. This leads to so much of complication for the patient. So, and this based upon the US labor data, which is trying to show just in between 2021 and 2022, 1.7 million people, the highest ever in recorded history, have quit their jobs in healthcare sector. And we also have many who are complaining about that their jobs, especially after COVID, has been reduced, where majority is only about documentation. That's all they're doing. And 28% are considering, due to burnout, to quit their jobs. So who exactly is this system helping? If the patients are having issues, if the practitioners are having issues, where is the good coming out of? Okay, and this again, a question we discussed with, like what does people are asking about? So when you look at this segment, the patients' priorities are totally different. They are talking about brain health. They are talking about sleep, stress, and pain. That is the majority of our problem. Lack of sleep, too much of pain, and too much of stress is leading to the modern lifestyle issues. It's as simple as. So what can we do to address that? And the truth of the matter is, our entire healthcare system is designed as a sick care system. We are waiting for them to become sick. We have forgotten what primary prevention is. For us, prevention has become nothing but screening, lab tests, sending them on a reference cycle and every other thing. But we are not talking about good diets. We are not talking about exercise, simple things which they are supposed to do. So that's where now we come to the question which she was talking about, as what exactly is wellness? How do we define wellness? Okay, so I just put across a word art, taking all the words I could find out, and basically trying to go in. Some people find music, living, positive, diet, exercise, so many things they incorporate and they call as wellness. To make it simplify, this is how we perceive wellness as. We think, just like Popeye, that there is this magical spinach. Okay, there is an external solution to all our internal problems. We know as practice that the most powerful antibiotic, the most powerful antiviral, it's all produced in the human body. Okay, everything that we are doing is to elicit that effect, but somehow the internal mechanisms are being disregarded. So what exactly is health and wellness? Just again, to explore upon that. Health could be what the WHO definition is, absence of a disease state, physical, mental, social, all those things. But wellness is a deliberate set of choices that an individual take for a better health outcome. So to make it more simple, Health is a destination, while wellness is a journey that you take towards that destination. And this is where we now come. So now you know what wellness is, what well has an understanding about it. This is where resurgence of yoga and Ayurveda has come, which I'm calling as Indic Renaissance. So what principles, like how yoga has very much penetrated the wellness market, and it's being, cardiologists are recommending it. There's lots of science happening it, but somehow its sister science, Ayurveda, which also is in the same principle, is not even considered a fringe science. It's below that. So you have energy healing and a lot of other things being funded by NCCIH programs, but Ayurveda, which has almost 5,000 years of documented history, is considered as, for lack of a better word, not science. To address that issue, this is where me and my foundation have coming in. So first of all was to ideate what exactly are the main, broadly, the problems of Ayurveda that we are facing. Number one is of a perception and narrative. The major section is who considers this either as a fringe science. Second section is considered this as a magical drug. Okay. In both the cases, the actual message of the system is not going through. That Ayurveda is not herbology, it's a behavior science, it's a nutritional science. It's about how to incorporate things to have a better productivity, a more peaceful night, those kind of simple things. It's not talking about anything else. Next is the scientific studies that exist are very sparse and all over the place. They really don't give the justice that we are looking for. And there is no, as I mentioned, real world evidence, which is looking into the behavior aspect of Ayurveda. So whatever studies you see are like, for example, the most famous one, turmeric. Okay, so studies are done on turmeric, but the studies are done on the active ingredient of turmeric, that is curcumin, which I like to correlate is like, if most of us find honey as medicinal, then tell me what is the active ingredient of honey, which gives you that medicinal property. Because it is so multifactorial, you cannot do that. In the same way, the principles of the drugs also, which are coming from Ayurveda, they come from the similar principle. So first thing is to, how do I change perception? How do I identify the existing scientific studies and index them properly? Next is, how do I create a model in which real world evidence is captured? And the last is the lack of a data science approach. Okay, there is no statistical tools or anything which is really doing any type of outcome tracking for Ayurveda or yoga for that matter. So we give a concept here of what does exactly modernization of Ayurveda mean. So the main thing that we are saying is, get the number one priority is to get a biostatical approach. You create the mathematical tools following a non-linear, Bayesian methodology, where you're only talking about outcomes and not falling into the trap of mechanism of actions. Okay, this is the same model that psychology uses. You are talking about constructs like personality, egos, and everything, and you have all these studies which are non-replicable. Okay, but we can do the similar thing while for Ayurveda. Next is how health informatics come into play. Health informatics for me truly brings standardization, specificity, convenience, and safety. Not just for the providers, but for the consumers as well. We have taken the elements of remote patient monitoring, digital prescription, health record management in creating a system which is very similar to how you track fitness. Okay, if you have a fitness app, you're putting your morning routine. Okay, you're putting your calorie count. You're putting so many things. You are much, much more immersive in your experience when you're trying to get into your fitness routine. Last thing is how AI-based analytics can help. The greatest thing that has happened to us is artificial intelligence. This can be totally proven by one simple question that has happened is, we have folded the protein. DeepMind has allowed us to understand the protein structure. This is something that was unimaginable before. So this is the power of artificial intelligence. How can we incorporate these similar programs in trying to create Ayurveda? So without changing the scriptural aspects, we are changing Ayurveda in how do we track it in the modern times. So our foundation has come up with a phase. In phase one, we are trying to, first of all, create a repository of all existing information. Second is the axioms of Ayurveda. We are trying to create pragmatic trials, virtual clinical trials, in which using a questionnaire, we are trying to track whether again, the assumptions of Ayurveda hold true or not. Last aspect is coming to the validating of the cost benefit. What we are truly promoting is the preventive aspect that is involved here, and how this helps not only making the existing healthcare system function better, because by focusing on preventive healthcare, that load of patients are no longer coming. That's the thing. And every patient are having much, much better input. Based on our research, we have created a tech company, which basically is creating the first of its kind platform, which I will discuss a little more further later. But what we have achieved is first, global online Ayurveda library. This you can find out on ayurvedalibrary.org. This is our approach or our attempt in trying to index all things Ayurveda and yoga into one single platform. What we have done is we have taken a thematic approach rather than just putting into a boring way we have made sure. So the 4 themes are explore Ayurveda. This allows you to understand the history, the philosophy, the perception, and all the other visionaries who have represented Ayurveda over the years. Even though Ayurveda is believed to be something like a Hindu system, but the fact of the matter is Hindu, Buddhist, Jain, and even atheist had participated in development of this science. Next aspect is connect evidence. This is, again, as I mentioned, try to find existing evidence that already is there. NCCIH has been doing a lot of work in this matter. So our idea is to get all of that in a better format to you. It takes you to those links, and also to identify what are the current evidence gaps, which are not able to validate the system. And then we have also indexed all the web resources and creation of models of real world medicine. Next aspect is drive innovation. This is where we are trying to put all the Ayurvedic assumptions to test. Our first thing is Global Prakriti Project. This is akin to in the 80s of what Human Genome Project was to genetics. Till then, it was a fringe science. We do not understand the applications of what the Human Genome Code could do. Prakriti is somehow you can understand as an epigenetic approach to the same question. Can we, using a survey rather than any other invasive method, try to profile human beings on the basis of their bodily constitution? And can we predict, based upon the Ayurvedic assumptions, their healthcare status or wellness status? And using, again, digital transformation, big data analytics, we are planning to do a lot more over here. We are partnering with relevant agencies in also trying to understand how in silico pharmacological tests can also be set up for different Ayurvedic active ingredients. And Ayurceuticals, one more part which we have, we basically, there we are trying to help other entities in development of products and services based upon these principles. Last aspect is how do we promote integration? This is my and our organization's main thing. We are trying to find complementary models and not alternative medical models, how we are trying to be trained, but integrated model, just like how chiropractor is becoming integrated, how acupuncture has become integrated, how physiotherapy is integrated. These disciplines have less than 100 years of history. Yet, just through really good testimonials and outcome tracking and all, they are able to make their case and able to come to the mainstream. Our idea is to how to create similar environment for these kind of integrations. That is where now we are coming to the aspect of how we have developed with the health informatics system and the library together, created a unified platform which allows the user, the agnostic, to browse, first of all, the information about Ayurveda. Then they're able to book with a certified wellness practitioner, and the practitioner is able to create a system of not only able to diagnose them for their wellness issues. Again, we are focusing on sleep, pain, and stress. Okay, these things which are totally always kept out of the conventional medical system. Okay, and then our idea is how do we track that? Are we having any kind of success or whatever it may be? And also help the patient monitor. Along with this, we have an added system of intervention where our practitioner gives them a call when they miss their notifications or something like that. Just I want to add, like, just believing that the digital system can take care and you can remove the human factor is not the right. we have to develop and train how they can make, because the idea is all the system is supposed to make the practitioner or the doctor or the nurse or whatever it may be better at their job. It should not become a hassle to them. And in a nutshell, Ayurveda is the science of how to have productive days and peaceful nights. And with that note, I like to conclude with Hippocrates' quote that foolish the doctor who despises the knowledge acquired by the ancients. Thank you so much.
Thank you so much. Questions? Any questions from the audience? Okay, it's very insightful given the fact that
we're going to be speaking. So our next speaker is Mr. Carl Dowling. Okay, I'm passing him to the stage to deliver the speech on, is there a correlation with where or how the COVID-19 mRNA vaccine is delivered in young adults, which increases the probability of contracting myocarditis and pericarditis, if I have pronounced it correctly?
You did pronounce it correctly. Thank you for that. How's it going, everyone? Hope you're having a good time. Thank you very much for the conference, for having me here and inviting me from the UK. So I'm here to talk to you about if there's a correlation between the mRNA vaccine for COVID-19 and how it's impacted the young adults between 18 and 24 demographic. So let's begin. It's okay, I'll do it manually. Oh no, we have technical difficulties. I am pressing the right button, aren't I? That one. We'll be with you shortly. Please enjoy your refreshments and your fruit. Vitamin C is very healthy. I'll count on you, Barbara. I'm trusting you. Don't let me down. Was it the way it was loaded? Okay, so I'm going to press this button. All right.
Try now. Why it's not working?
Oh, okay. We'll do it that way. I can do it this way. We're going to go manually, back to old school. Okay, thank you for your patience, everyone. I really appreciate it. Okay, so introduction of what we're going to be looking at. We're going to look at a brief introduction on the mRNA COVID vaccine, how the lymphatic system works, how the lymphatic system can react to COVID-19 vaccine, Pfizer and biotech, possible variables that can cause a reaction, and of course, the dreaded conclusion. Okay. So, vaccinations were introduced to the world in the late 18th century by Dr. Edward Jenner, and has had a major contribution to global health. In December 2019, a novel outbreak of coronavirus came to the world and spread across, where it became a global pandemic. It's like a story time, isn't it? The FDA recognized the threat to public safety and approved the first vaccine. Dramatic effect. I'm trying, yeah. In December 2020, known as the Pfizer vaccine, was shown an efficacy between 75 and 95% in clinical trials. Very good. Within the first 6 months of the vaccine rollout, there has been an association between the development of inflammatory conditions of the heart in younger adults after taking the mRNA vaccines. Results gathered by the FDA in June 2021 relating to the adverse effects from Pfizer affected the heart, where up to 26 cases, 1 fatal of pericarditis, and 123 cases, 24 fatal of myocarditis in the 18 to 20 demographic. So I'm going to ask an open question to everybody. I need you to put your hands up for this, okay? Let's do a bit of interaction here. So I'm going to ask you what century the lymphatic system was first discovered. I'm going to go with 20th century first. Put your hands up for 20th century. I thought you just did then. I thought you would. I was like, no, don't do it. It's not a trap. 19th century. Have we got any takers on 19th century? Don't all jump at once. 18th century. Okay, that's good. That's good. Okay, we got a few people. Excellent, excellent. How about the 17th century? I mean, I'm not going below the 16th century. How about 16th century? Okay, well, it's the 17th century, but that's okay. We were close. We all got within the range, didn't we? Let's be honest. Good work, team. So, yeah, the lymphatic system was first discovered in the 17th century by Alaus Rebec and his partner Thomas Bartholin, where it worked alongside the circulatory system and contributes to immune surveillance, regulation of tissue pressure, and absorption of dietary fat in the intestine, so it has multiple uses. The mechanism of the lymphatic system begins with lymph getting filled through the capillaries into the tissues, and then it gets picked up by the lymph capillaries, putting through the larger lymph vessels to the collecting ducts where it drains. It's important that it drains. Everybody remember that when I get to the end. Okay, that's a spoiler right there. All right. When the pathogens invade the peripheral tissues and lymphatic vessels, transport the pathogens to the nearest lymph node. This is why when we get the vaccines, sometimes, into our arms hurt because the lymph node's released, it comes into there, it makes it swell, it causes a bit of pain. So don't worry if that happens, it's fairly normal for that reason. When I had my 4th vaccine, I had a really painful arm. I'm just putting that out there. Where adaptive immunity is initiated with the production of antibodies, which creates memory against the pathogen. I miss the days of the quill. So I've got a video here. I'm going to try and load it. I can't promise anything, but I'll do my best. Okay, here we go.
Did you know your body has its own version of a sewer system? A good system for handling excess water and debris is an important part of any community. It helps take away contaminated substances that might harm us. Engineers have designed great systems of pumps and pipes to help our sewer systems do these important jobs. Most of the time, we barely notice these systems unless they fail to work. PU. It turns out your body has a similar system for dealing with excess water and contaminated substances. There are millions of tiny vessels in your body whose job it is to gather excess water, proteins, cells, and various bits of debris. This is called the lymphatic system. The water, which is leaked out of your blood vessels, is returned to the bloodstream in your shoulders so you don't blow up like a big water balloon. The thing happens because each little lymphatic vessel has valves at each end to keep the fluid moving in the right direction. The vessel squeezes to keep the fluid moving along. This is happening in millions of little lymphatic vessels in your body every minute of every day. As this water is pumped back up to your shoulder, it has to be cleaned so that the bits of debris in the water stream, say if you get a cut, don't get into your bloodstream and make you sick. The lymphatic system pumps all that water through at least one lymph node. These are like tiny water treatment plants where specialized immune cells recognize and destroy the foreign debris. Voila! All clean and ready to go back into the bloodstream. Unfortunately, like any sewer system, things can go horribly wrong. Sometimes we get infections that cause the pumping to break down. This can cause your arms or legs to swell to huge proportions. That's a disease called lymphedema, and it is no laughing matter. Sometimes the debris or other bad substances can make it past lymph nodes. Sometimes cancer cells do this and spread the cancer to other parts of the body. Bad news. For now, we wish you all the best for your lymphatic health, which you can help maintain by drinking lots of water and exercising. Keep on pumping.
It all connects to wellness, doesn't it?
Yes, it does.
Yeah, just making sure everything connects to everything, really, if you think about it. All right, so how do I get... Okay, so this is a diagram. I made it myself. Obviously, I used other things to make this. I didn't use it just off the top of my head. I'm not going to put... But it basically shows you what happens when the lymph node activates and the lymph vessels and how it travels through the body on the right side and the left side. So to begin with, lymph drains from either side from the axillary nodes, which I think was mentioned in the upper arms over in the video. And before it returns back to the venous blood supply, it gets cleansed and squeezed. And that's when it goes to one of these sides, depending on where you get injected. So if you get injected with the vaccine on the left side, well, in 1990, Murakami assessed the bronchomediastinal lymph vessels and their formation with the circulatory system. And it showed that there was not always consistent formation on the left side. There were branches coming up the left side. So if you got injected on the left side, instead of it going down like it should there in that order, sometimes it could branch off. And one of the places it could branch off to was the uppermost paratracheal nodes, which is alongside the trachea, the anterior mediastinal nodes, which is anterior of the heart, and also the phrenic nodes, which is superior to the diaphragm. So if it came to the cause where it went anterior to the heart, well, then that could activate an inflammatory response within the heart and cause myocarditis or pericarditis. All this is theoretical, of course. It's not like it's a proven thing. I'm just putting it out there. However, when the lymphatic system does go into it reacts to vaccination, the vaccines are utilized as vessels of low risk infectious response by targeting the memory cells, which is in our lymph nodes for adaptive immunity. It's what we want. We want memory cells. We'll remember the invader and stop it. This will assist in the body by incoming invaders and prevent the potentially dangerous pathogenic agent from replicating or causing or reproducing or causing major infection. When the vaccination has been administered, the body's innate system must primarily detect the threat, and that's what it does. The innate immune system detects the threat, and then the adaptive immune system comes later to create memory against that threat. mRNA vaccines encode the viral protein and the immune modulatory proteins as adjuvants. Can't read my own handwriting, please bear with me. And stimulates the innate immune response, activating antigen-specific T cell responses without inducing systematic inflammation. And that's important because when we get COVID, it can cause systematic inflammation in the very bad, severe ill patients to the point where it can cause many problems. So that's why the vaccine was created, to prevent that, or prevent the severity of that. They can't prevent you getting COVID, the vaccines, but they can prevent the severity of how bad you get COVID. So then we've got this video. It's a short video. It's on myocarditis and the coronavirus vaccines. So we're going to play this. You know that circle of doom you get on? Oh, yeah.
Myocarditis is simply inflammation of the heart muscle. It occurs in response to infection or to injury. That injury can be from autoimmune disease, from the body reacting to a certain invader, producing antibodies to attack that invader. Sometimes it is confused and may actually attack the body itself.
Our bodies responding to COVID-19 by producing antibodies to attack the virus. And in rare cases, when these antibodies attack the heart, the resulting inflammation can start impeding normal heart function, resulting in a fluid signal.
The damage becomes a little more extensive, or in some way disturbs the nerves that you can feel it as chest. If it gets extensive enough that it disturbs the actual function of the heart, then it can cause shortness of breath because the heart's not functioning in the usual way. And there could be some heart failure. That is, some of the lungs can become congested because the heart's not functioning properly. Most often with myocarditis, these things just balloon themselves. In cases, they're not as they had it. It's only in some rare cases where the damage becomes extensive enough that it actually causes problems.
There has also been evidence of myocarditis in patients who have received a milder form of mRNA vaccine. And despite being an incredibly rare occurrence, we got one case per 50,000 patients, according to 2 Israeli studies. Myocarditis has been cited by some of the vaccine hesitant as a reason they are voting off.
What we've seen is that this increase in risk is localized to males, somewhere between 18 and 29. And the risk, again, in the very best studies, is suggested quite low. That the people who are affected are most often affected in very mild ways, what we call self-limited.
Federal officials have acknowledged the link between myocarditis and Pfizer and different vaccines. But experts agree the benefits of the vaccine far outweigh any potential harm, especially the harm caused by suicide infections. CDC reports that coronavirus patients have 15 times the risk of developing myocarditis compared to people who are vaccinated.
There may be some risks associated with the vaccine, but these are highly effective vaccines preventing COVID itself. And that provides a lot of offsetting benefit, both for myocarditis and for a wide range of other things that that are prevented as a result of taking the vaccine.
That's the last video. I swear. So we've then got variables that can cause a reaction from taking the vaccine. So vaccines are more commonly given in the intramuscular route because it maximizes immunogenicity of the vaccine and it minimizes adverse reactions at the site of infection. Hypodermic injections can be associated with pain and distress by the patient, which can lead to poor compliance, which is why it is vital that a highly trained professional give the vaccines. So skin bulging techniques, this is a possible variable. So deliberation of the needle gauge should be considered as a larger bore needle allows the vaccine to be dispersed over a larger surface area and reduces the risk of localized redness or swelling. However, Ramanov 2021 investigated the impact of skin bulging techniques via the intramuscular vaccination, where the findings highlighted skin bulging can prevent effective vaccination response in individuals due to an increased skin to muscle distance. So if you're doing this and you've got a certain size needle and you put a certain size needle in, you've already done that, well, you're not always reaching the very target you're trying to get to within that area. Only in certain people, the minority. Then the other variable is aspiration. So there are many sources of literature published on advising aspiration prior to injecting a muscle through the intramuscular route. However, it is crucial for aspiration to be effective. It needs to be negative pressure for 5 to 10 seconds. The US Advisory Committee on Immunization Practices have not given any advice during the COVID pandemic in providing aspiration or not, and have left it up to the vaccinator. I'm sure there's guidelines as well with certain places that will tell you whether to do it or not to do it. Vaccines are not designed for administration into the circulatory system, even though the lymphatic system runs alongside the circulatory system. And it can lead to a distribution of transfection to the tissues beyond the injection site if it gets into the circulatory system. So if you don't aspirate, or if you do go into, there's not many blood vessels in the deltoid, and that's why we pick the deltoid. If you do put an injection in there and it does go through to the circulatory system without you knowing about it, then it can cause transfection of those tissues beyond the injection site, which can cause serious issues with the heart and cause an immune response such as myocarditis and pericarditis. So it's important to be safe when you do these things. So in conclusion, it's the last one. All right, we're doing well. Just at the end. Am I doing well? Excellent. Thanks, Barbara. Bless her. 10 out of 10 for you. So in conclusion, over the years, vaccinations have been proven to be an effective tool against pathogens. However, certain aspects of vaccination procedures need to be considered to improve patient safety and overall outcome. It is important to have a highly trained vaccinator given intramuscular injections who can use their autonomy to prevent skin bulging techniques and follow guidance on aspiration, their local guidance, prior to delivering the vaccination to help prevent vaccinated-associated injuries. There have been studies related to possible avenues where the vaccination can affect particular areas of the body depending on the injection site. Although it cannot be proven and more research needs to be carried out in this topic, I'm just putting that out there right now. More research in that topic. If anyone wants to do it, they can. Theoretically, picking a specific site for injection, either left or right, could potentially reduce the risk of an individual suffering from an adverse effect caused by the vaccine. Second. That's okay. Here's my references. And this is my this is my thank you page. Thank you.
This from the audience.
Oh dear. Not looking forward to this. I know you've written some stuff down.
I have. Can't talk much about vaccines because pretty much you're talking about the clinical aspect of it.
Yes.
I'm more concerned with the filling and the contract manufacturing, which is the arena around the injectables and all that.
The other side, as I say.
Back end. So it's all, you've mentioned something very interesting. You said highly trained professionals should be the ones injecting, be it the adults or the children, the vaccine, for the sake of the intramuscular injections and making sure that the vaccine goes to the right location that impacts the whole lymphatic system. How do we do that? How do we make sure? Let me just be very specific.
No, by all means, go ahead. Specific is good. I like specific. You go, you be specific. Yeah.
With this technique and whatever technique that needs to be followed, and how do we guarantee that they're following it? So that the impact and the efficacy that's being claimed is actually seen to prevent the implications if you're hit by COVID. So
that's a great.
The only question I've got.
That's the only question. Wow. I'm shocked. That was a good question. Well, what happened is during the pandemic in the UK, I can't speak for everyone else in their respective places, but they brought in people who had some experience in clinical, but not nursing experience where they give intramuscular injections regularly or anything like that. And they trained them to give vaccinations. They did it with paramedics, even though we do intramuscular injections as well, not vaccines though. So it is a bit different. And they did that because of how much they needed to get the vaccine rollout. Like they had to get those numbers. The pressure was on. We needed people there so we can adjust for the numbers that turn up, because it was queue after queue after queue. Sometimes people weren't getting vaccinated because there was so many queuing up and we had to close at a certain time. So that's why that happened. So there should be, in their local policies and their own training, there should be, whoever does vaccinating training should have specific training on what to look for, how to inject. And I feel that when we were rushing and when everything was on, the pressure was on, as we say, I think that some of that went out the window a little bit, if you know what I mean. And then also you've got the fact of, oh, there's 100 people, there's 2,000 people, let's go inject, wait over there, inject. And it's like, you know, there's no patient-centered care there. That, you know, these people are scared, the majority of them, not just of COVID, but also of the fact of what's going to go into their bodies that they don't even know much about. So, you know, I think a bit of time with them. I was a responder there. I used to sit with them in the waiting room and talk to them and try and give them whatever information I could, mainly leaflets. But that's cool. Everyone loves a leaflet, don't they? But, you know, I provide information support the best I could. And that's what we should do as a whole, not just the person in the waiting room, but also the person before they go for the injection, the person at the injection, the person who gave it, the person after that. You know, it should be as a whole. And information is so important, and giving information to the people that are taking this injection. Health promotion, education, always goes back to other things. So education is important as well. Does that answer your question?
Thank you. In the UK, I have a last question from you, please.
So close yet so far. I blame you, Barbara. You whispered this to her, didn't you? So close.
I just want to say, over the course of the United States going through this COVID epidemic, it occurred to me after you've been sharing this that only 61 or 62% of United States citizens actually got their COVID shots, which sadly, a lot of those folks ended up in the hospital because they had underlying health issues. And since I work with a population that is their immune systems have been highly affected by addiction, it prevented a lot of those folks from getting their COVID shots, but also bringing it into a clinic. One person brought it in the clinic, and there was numerous staff, not only staff, but also patients that got it.
Bless them. They say 1 in every 7 will give one person will pass on to 7 people, and so on and so forth.
So thank you for bringing that.
No, thank you. Thank you. Anyone else? So I welcome it all. Oh, yeah. She's doing this on purpose. I want you all to notice this. All right, she's doing this deliberately. Yeah, go on.
So I think couple of years down the road in this pandemic where we started seeing that the general practitioner, people are being referred to general practitioners to assess their situation prior to giving it a shot, right? And the question I have, should this have not been the practice from the start, given the fact that it's a pandemic, it's a new vaccine, 52 of them are still out there in trials, and people assume that they know their chronic diseases. Many are not aware that they are walking around with chronic diseases.
No.
So should we have not implemented that protocol, regardless where? I mean, it's a global issue.
I think
That's the question.
No, it's fine. It's fine. I think that from the start, a lot of things could have been done differently, to be honest. But unfortunately, because of the nature of the medical emergency and how things were, it's like the vaccine, how it was created. A lot of people are saying that it was too fast. It shouldn't have been done that quickly. But the fact is, there was research on mRNA vaccines years and years and years before that. Yeah, and people don't realize that. People in the public don't realize that. When it comes to how we should be aware of when people are coming through, the practitioners, if they were there and more involved in it, they should have been. It was the nurses that led it mainly. And I've got to give credit to them because they're the ones that led the vaccine rollout more than the doctors. And when I went to London during COVID, they were the ones that were at the center of it all. The doctors were there and they were making decisions, tough decisions, and fair play to them. But the nurses were there, front, right, and center through all of it. And that should be recognized, because I don't think it is recognized enough. But yes, I agree with you. They should have been there. I can't argue with that. What, you know what I mean? What can I say on that one, really? You're absolutely right. I agree with you 100%. Any other questions? I'm literally crossing my fingers right now. Excellent stuff. Well, thank you, everyone. It has been a pleasure. Oh, yes.
Okay, we'll just take it together.
I'll make a hole.
Yeah.
There we go.
Oh, yes, of course.
Of course.
Excellent. I know, yeah.
Okay. All right. So the next speaker is Dr. Sahar from the UAE. I'm going to pass on the stage to her to deliver a speech on review and comparison of international breast cancer screening guidelines. All right. All right, where is that? Okay, apologies, everyone. So there has been a slight change in the topic that Dr. Saad is going to look into. So metabolic syndrome is actually the topic that she's going to talk about. So give her a couple of minutes just to connect and move on with it. Yeah, pretty much.
So it's okay. For this one. Okay.
So, good afternoon.
Yeah, my name is Dr. Sahar. I'll be talking about metabolic syndrome. Really, it's one of the important symptoms we have to discuss about because it's becoming very common as it's connected to obesity, and obesity is rising now worldwide. So we have to discuss about it. So
Let's start from where here.
Okay. Before defining metabolic syndrome, I have to say that it was there since 1998. It has been introduced, this definition, and it has been also defined by different organizations. I will be talking about the definition of the National Cholesterol Education Program panel, the Adult Treatment Panel 3, because it's the most commonly used. And also there is other definition by so many organizations, but this is the most important one. So what is metabolic syndrome? It is defined as the co-occurrence of metabolic risk factors for both type 2 and type 2 diabetes and cardiovascular diseases. The risk factors are abdominal obesity, hyperglycemia, dyslipidemia, and hypertension. If you have 3 of those factors, you will be diagnosed as having metabolic syndrome. As what I said before, there are several definitions. My voice is clear. Do I need to use this mic? What do you think? Let's try. Hello. Yes. Okay, as what I said before, there are several definitions for the metabolic syndrome. But overall, the prognosis and the management appears to be similar. The most common and widely used is the National Cholesterol Education Program, Adult Treatment Panel 3. So, what are the criteria or the risk factors included in the definition of the adult cholesterol, the adult panel? So, the first one and the most important factors is abdominal obesity. This is the most important risk factor to be encountered within the syndrome. Other factors, increased triglyceride more than 150 milligram per deciliter, and low high-density lipoprotein in men less than 40 milligram per deciliter, in women less than 50 milligram per deciliter, high blood pressure, systolic blood pressure more than 130, diastolic blood pressure more than 85, fasting blood glucose more than 100 milligram per deciliter. So if you have 3 of those factors, you will be diagnosed as having metabolic syndrome. And the most important factor is, I want to hear from you. What is the most important factor? What do you think? This is the most important factor and the keyword for my presentation. Abdominal obesity. Abdominal obesity is the most important K factor. And I'll give you more details throughout my presentation. So this to reflect that there are so many organizations and definitions by WHO, NCEP. Okay. So what is the pathophysiology? So as what I say, abdominal obesity is very essential and important factor because obesity will lead to increased insulin resistance. And when there is insulin resistance, so your body will not make use of glucose and fatty acids. And this will lead to hyperinsulinemia and hyperglycemia. And this will lead, of course, to diabetes, okay? And also, if there is insulin resistance, there will be, as what I said, hyperinsulinemia, hyperglycemia, and adipocyte release inflammatory markers. And this will lead to vascular endothelial dysfunction and abnormal lipid profile, hypertension, vascular inflammation, atherosclerotic changes, and cardiovascular diseases. Can I use another one? Can I use that one? Of course, I want to move around. It's better to be. Hello? Yes. This is better for me. This is working? Yeah. Use this one. Really? Yeah. Yeah, it's okay. I'm fine. How can I use this one? Yes. Okay, good. Okay, bad. So before we proceed, I want to define how we diagnose diabetes. Okay, this is the values. To be diagnosed as having diabetes, you have to have a fasting blood glucose of more than 126 milligram per deciliter and 2 hours post a glucose meal more than 200. And this is going to go this way. So this is how we measure the waist circumference. For abdominal obesity, we have to measure the waist circumference. In male, the cutoff point is equal or more than 102 centimeter, and in female, more and equal to 88 centimeter. And this is how we measure it between the lower lip and the iliac crest. Okay, is it clear how we measure it? Okay. But there is race variation, specific value for waist circumference for each different race. So just have a look at it. Okay. This is the other definition for International Diabetes Federation. It's mentioned that increased waist based on ethnic specific value, cutoff point, triglyceride more than 150 milligram per deciliter, or the patient is taking treatment for elevated triglyceride. Okay. High density lipoprotein less than 40, or the patient is taking treatment for low high density lipoprotein. Systolic blood pressure more than 130, diastolic blood pressure more than or equal to 85, or the patient is taking treatment for hypertension. Also, fasting blood glucose, so I will give this one, okay? So this is also the same values. Okay, there are other potential markers found on metabolic syndrome, but we have to mention it. It's not included in the definition, but it has to be mentioned. Metabolic syndrome has been recognized as pro-inflammatory, pro-thrombotic state associated with elevated level of C-reactive protein, interleukin-6, and plasminogen activated factor 1. Okay, it's very important to know this information. The value of measurement or treatment of inflammatory or vascular function markers in the setting of metabolic syndrome is unknown. Use of these markers should be considered for clinical purpose only in the setting of cardiovascular disease and assessment and reduction. It's not included, but it has to be considered. So, what are the risk factors to metabolic syndrome? The prevalence of metabolic syndrome increases with advancing age. So many studies established that Mexican Americans had the highest age-adjusted prevalence. Among Black Americans and Mexican Americans, the prevalence was higher in females than in males. In a study between 2011 to 2016 cohort, the prevalence was lowest among those identifying as non-Hispanic Asian and highest among those identifying as Hispanic. As what I said before, also increased body weight is a major risk factor for metabolic syndrome. Is a major risk factor. But however, metabolic syndrome can occur in a patient with normal weight as well. Other risk factors: postmenopausal status, smoking, low household income, high carb diet, and physical inactivity. Soft drink and sugar sweetening beverage consumption was also associated with an increased risk of developing adverse metabolic trait and metabolic syndrome. Use of atypical antipsychotic medication, poor cardiorespiratory fitness, a parental history also can be encountered for 50% of cases. So what is the clinical implication and the subsequent risk of the metabolic syndrome? As what I said before, there is high risk for developing diabetes type 2, and cardiovascular diseases. Prospective observational studies demonstrate a strong association between metabolic syndrome and the risk of subsequent development of type 2 diabetes. In several cohorts, the risk of diabetes increased with increasing number of components of metabolic syndrome. Metabolic syndrome also increases the risk of cardiovascular disease. The increased risk appear to be related to the risk factors clustering or insulin resistance associated with metabolic syndrome rather than simply to obesity. Metabolic syndrome has a fourfold increased risk for diabetes and threefold increase for cardiovascular diseases. So this is just a diagram will show you just very complex pathophysiology for metabolic syndrome. Here, okay, I already mentioned that there are so many risk factors encountered in metabolic syndrome, and it has to be identified early. Okay, should be assessed for the patient. Should be assessed if he's having any of the risk factors. If he's having one or two risk factors, he should be followed. Okay. So, metabolic syndrome, there is association with other diseases. Of course, all the diseases or the conditions are related to obesity can be considered to be associated with metabolic syndrome. For example, fat liver disease, hepatocellular carcinoma, intrahepatic cholangiocarcinoma, polycystic ovary syndrome, sleep disorder, breathing, obstructive sleep apnea, hyperuricemia, cognitive decline also. Yes, it has been found that if the patient is having a metabolic syndrome associated with increased inflammatory markers, there is a high risk to develop cognitive decline and dementia as well. Also, there is association with chronic kidney disease. Metabolic syndrome in multivariate analysis significantly increase the risk of both chronic kidney disease and microalbuminuria. So, in 2001, the adult treatment panel 3 recommended 2 major therapeutic goals in patients with metabolic syndrome. These goals were reinforced by a report from the American Heart Association and the National Institute of Health and by clinical guidelines from Endocrine Society. What are those targets? To treat the underlying causes, overweight, obesity, physical inactivity by intensifying weight management and increasing physical activity. The other goal is to treat cardiovascular risk factor if they persist despite lifestyle modification. So, what sort of lifestyle modification can help with this syndrome? I want to hear from you now. Can I have suggestions? Yes.
Stop smoking.
Diet, exercise, not smoking. What else? Yes, weight management, because I already mentioned that the major risk factor is obesity, right?
Mental health.
Yes, excellent. Mental health. Yes, to avoid sleep disturbance. Very important. What else? The work. Relationship strength, yes. How to resolve it. Yes, excellent. Alcohol, yes. We stop alcohol, right? Increase alcohol.
Everything in moderation.
Okay, moderate amount. Okay. Yes.
I have one thing that I felt is very critical when it comes to obesity. I personally had a yo-yo weight for quite a long period of time. And I've realized that if somebody taught us at a very early age when we were in school, our canteens, our cafeterias, be it boarding schools or be it public schools or private schools, it would have made a big difference on our choices as grown-ups. So rather than just, I'm a sweet tooth. I love my chocolates, but if I would have chosen dark chocolate over milky chocolate full of sugars, I think prevention.
Yes,
from an early
prevention
age
is very important. Yes.
associated with dieting, the whole 9 yards of all the options out there might make a bigger difference.
I think lifestyle modification should be a part of our lifelong, a part of our life process. It's not just something that we should do for a while. Okay. So, as what we say, aggressive lifestyle modification focus on weight reduction and increased physical activity is a primary therapy for the management of metabolic syndrome. Weight reduction is optimally achieved with a multi-modality approach, including diet, exercise, and possible pharmacological therapy with orlistat. Okay. Weight reduction with improved insulin sensitivity is important outcome goal of any diet. So, diet we can go for. Any suggestions? What is the healthy diet? Diet, yes, excellent. What else? High protein diet, yes. Low sugar. I hear someone was saying low sugar. Yes. Low glycemic index, yes. Fibers. That's very important point. What else? Vitamins, minerals, vegetables, fruits. Yes, very important. Drink water. Yes, plenty of water. It's very important for your kidneys. What else? Yes, all what mentioned here. Food with low glycemic index. The glycemic index should be less than 55. High fiber diet more than or equal to 70 grams per day. Limiting your salted diet to 2,400 milligrams. Okay, yes. So I will give you just this is an example of a healthy diet called Mediterranean diet. You can have a look at it. Yeah, so many options, right? Yes. So this is a table of that with glycemic index. We have to go for the diet, I mean, for the choice is less than 55, that's what I say. So where are we now? Where it should be, where? Okay, glycemic index less than 55. So we are here, right? Right? I need someone to read loud. What are the types of food with low glycemic index here, please? Anyone can read from there? Yes. Bread, strawberries, apples, orange, milk, natural yogurt, right? So now, exercise. What type of exercise is it? What do you think? What is the minimum exercise you will have to? Minutes. I need to for 4 days. Could be, yes. Yes, every day. Every day. Yes. But the minimum requirement. Yes. Yes. The minimum requirement is 3 times per week, but it's better to do it every day, at least 30 minutes. What type of exercise? Walking. Fast. Fast walking. This is the best exercise. And if you can see, it's not difficult. It's just walk for 10 minutes. There's so many complications and diseases. It's exercise would be good, really. But actually, exercise and lifestyle modification and changing is not a part of our life. Actually, we are not taking this part seriously. As we mentioned before about willingness, right? Exercise is a very important part of it, right? Yes. Okay, let's go. Physical activity guidelines recommended practical, regular, and moderate regimen for exercise. The standard exercise recommendation is a daily minimum of 30 minutes of moderate intensity at brisk walking, physical activity. Okay. Sometimes removal of abdominal adipose tissue with liposuction, it can help you for a while, but it's not good on the long run. Okay, it's not good in the long run, but you need, this will not replace the most important part of being active and go for healthy diet. It will not replace it. So, how can we prevent diabetes? Although not strictly addressing metabolic syndrome, clinical trials have shown that lifestyle modification can substantially reduce the risk of development of type 2 diabetes, and the level of the risk factors for cardiovascular in patients at increased risk. Both intensive lifestyle intervention and metformin therapy reduce the risk of developing metabolic syndrome. And metformin is very important, really, for the treatment plan, because it has been found that it has a great role to prevent the future complications like sudden death, hypo or hyperglycemia, causing death, myocardial infarction, angina, heart failure, stroke, renal failure, amputation, and other complications. And now, how can we prevent the cardiovascular risk? Guidelines recommended reduction of component of cardiovascular risk factors that comprise metabolic syndrome, including treatment of hypertension, improved glycemic control in patients with diabetes, and lowering of serum cholesterol. Among the individual metabolic syndrome criteria, recovery from hypertension was most strongly associated with a reduction in cardiovascular risk. Also, lipid lowering is very important, one of the risk factors. And it has been found that atorvastatin have a great role if it's given in high dose, 80 milligrams, to prevent cardiovascular events. Also, it's very important to treat hypertension with antihypertensive medication. Okay. I will not go through details in the medication, but in general, it has to be treated. So, do we have enough information for children and adolescents? The answer is no. Unfortunately, we need more researchers to have facts about metabolic syndrome in children and adolescents. Metabolic syndrome also occurs in children and adolescents, but there is no agreement on the definition. There are few longitudinal studies in children and adolescents with metabolic syndrome, in contrast to the data from adults. Therefore, long-term cardiovascular and diabetes risks are not well defined, unfortunately. Okay, now I will mention the most important message and keywords in my presentation. It should be noted that questions have been raised as to whether metabolic syndrome captures any NAQ pathophysiology implied by calling it a syndrome, and whether metabolic syndrome confers risk beyond its individual components. So what do you think about this sentence? Do we need to collect those factors under one syndrome? Because actually, if you have a patient with multiple risk factors, if I receive a patient who's having diabetes or hypertension, I can simply treat diabetes and treat hypertension, and that's it. Why we should combine those factors under one syndrome? What do you think? Yes, what do you think? I need someone to give me a beautiful answer. Yeah. Okay, I'll ask you the question again. Now I told you metabolic syndrome is combining so many different factors, right? Okay. Why do we need to collect those factors together under one name, under one syndrome? Instead, if you are a patient, you came to my clinic and you told me that I have hypertension, right? So I will simply give you the medication and that's it. Right? So why would you combine those factors under one syndrome?
Due to the nature.
Yes.
It's due to the nature of the condition. It's so multifactorial.
Yes.
Cannot
Yes.
fit into one syndrome.
Okay. The major connector is which factor? I'll make it easy for you. The major connector is which factor? Yes, obesity. So obesity is the link to so many factors. Okay, now, if say you receive the patient is having hypertension and diabetes, you will think about treating his obesity. You will measure his waist circumference. Did you get my question? No. No. Okay. Now, how frequent we are measuring the waist circumference for our patient? Do we do that in practice? Do we practice that? Do we do that here in USA? No. So, okay, that's mean metabolic syndrome is a syndrome that lies beneath the surface. We are usually missing the syndrome because we are not doing or measuring the most important factor, which is what? Abdominal obesity, right? Okay then. So what if I tell you only by simple doing life-changing medication and weight reduction, you will be having a great chance to reduce the chance of having those complications. Okay. So, the WHO ATB 3 and IDF definition include type 2 diabetes as a syndrome trait. Experts do not all agree that type 2 diabetes should be a part of the definition. And the importance of the syndrome is that it identifies patients at increased risk for the development of diabetes. Most patients with type 2 diabetes have features of metabolic syndrome in which it identifies those at great risk for microvascular, but not microvascular complication. Management of patients with type 2 diabetes should follow clinical guidelines, whether or not they also meet criteria for metabolic syndrome. So now let's talk about the defects of this, the defect in definition of this syndrome. Okay. American Diabetes Association and the European Association for the Study of Diabetes published a joint statement raising question about whether the component of metabolic syndrome as defined above warrant classification as a true syndrome. So what's the problem? Let's see. Inclusion of patients with clinical cardiovascular or diabetes as a part of the syndrome that is intended to define risk factor for these diseases. Is it true? Now we're talking about metabolic syndrome, we're talking about the risk factors, but as well, we are preventing the complication, which is the same. Is it clear? So diabetes is a risk factor and also is a complication. Cardiovascular diseases will have so many components. Hypertension, it's a risk factor and also as well, it's a complication. Okay? Okay. A high low-density lipoprotein cholesterol and smoking are major risk factor for heart disease, but they aren't part of the metabolic system. Risk factor, but it's nothing. Okay. Those factors are nothing. Other risk factors for cardiovascular that are not component of metabolic syndrome, such as inflammatory markers, may have equal or greater bearing on risk. We already mentioned that if a patient the patient is having a metabolic syndrome, in association with increased inflammatory markers, there is a high risk of cognitive decline and dementia. So it wasn't reflected. Okay. The cardiovascular risk associated with metabolic syndrome has not been shown to be greater than the sum of its individual components. So this is the answer also for the question. Okay, so by having the combined factors, the risk also will be there, even if you have individual risk. Sometimes you have a major complication with one risk factors only, right? This can happen? Yes, yes or no? Yes. I'm sure you all agree clustering of risk factor for diabetes and cardiovascular is a real phenomenon. All agree that the presence of one component of metabolic syndrome should lead to evaluation for other risk factors. The advice remains to treat individual risk factors when present and to prescribe therapeutic lifestyle changes and weight management for patients with obesity and multiple risk factors. So what is the summary? Metabolic syndrome is an important risk factor for subsequent development of type 2 diabetes and cardiovascular disease. Thus, the key clinical implication of a diagnosis of metabolic syndrome is identification of patient who needs aggressive lifestyle modification focused on weight reduction and increased physical activity, prevention of diabetes type 2, and also reduction of risk factors for cardiovascular, includes treatment of hypertension, glycemic control in patients with diabetes, and lowering serum cholesterol according to recommended guidelines. Metabolic syndrome is becoming more common due to the rise in obesity rates among adults. In the future, metabolic syndrome may overtake smoking as a leading risk factor for heart disease. This might happen. We don't know what will happen in the future, right? It is possible to prevent or delay metabolic syndrome, mainly with lifestyle changes. Healthy lifestyle is lifelong commitment. Successfully controlling metabolic syndrome requires long-term effort and teamwork with healthcare providers. Now I have a question. What can we do to prevent metabolic syndrome? Yes. Lifestyle. How can you identify the patient at risk? Assessment. Okay. Yes. Okay. What if you have a patient who gets to you with one or two risk factors? What can you do?
Education.
Education, excellent. Yes. What about follow-up?
Follow-up, yeah.
Do we have to follow this patient? We have to follow this patient because he might develop another risk factors, right? How frequent we should follow this patient? What do you think?
Monthly, every 3 months.
Every 3 months, any suggestions?
2 months.
Right, that's good.
I don't get how happens.
Yes. Is it bring the patient every month? Something like this. Yeah, that's sure. Okay, I suggest that
3 to 6 months.
no, it's about years.
I know. I know. Pretend to calm.
Yeah, but we don't know how frequently you will be encounter another risk factor, provided that we get a proper education. So according to guidelines, it can be as one every 3 years.
For how many factors?
Yeah, it's the condition of the patient.
Combine them.
Yes, of course. But we can follow the patient, we can call the patient, yes. We can do what we can. This is what we can do, you know. We have to educate, we have to follow as much as we can, really, because we don't want this complication to happen. Okay. So my next question, do you think that we have to implement waste the control in each clinic?
No.
No? Why no? Yes or no? Okay, if you feel that you have a patient with looks obese, yes, we
Measure the BMI.
So do you think that you will be missing some patient if you
the practice to take if we start to learn about it. Yes. Implement it in our clinics. It's critical. We are very to you. Implemented the blood pressure. We have to implement the change. We have to start change because we have to have an open mind to think about the consequences. And we have to start do something beneficial for our population. It's not easy, but it's very important. You see, it's not just simply you treat the factors and that's it. Weight reduction is more important than just treating the factors. The outcome is excellent and better with the life change modification, including weight reduction. So we have to start from our clinic. I think it's easy. What do you think? We learn to do that and hope in our clinics. Because, you know, as I said initially, the syndrome is lying beneath the surface. And we always miss the syndrome because we are missing this important factor. I think this is one of the purpose of we are doing
lack of awareness, because most of nurses doesn't know if it's important or not.
Yeah.
Why it's important.
So we have to start to implement education.
Yeah.
Yes. So the first step is education, raising awareness, then training, then very simple and it's very important. So the purpose of my presentation actually is about just to give you knowledge about metabolic syndrome and so many information about pathophysiology. It's about the key message and the important summary. We have to change our life. We have to change the way we think about weight or diet or exercise. It should be implemented as part of our life. It's very important. So this is my last. No. So this is also important, regardless of whether metabolic syndrome is considered an acute entity, individual components need to be identified and managed to decrease the associated morbidity and mortality. So make it a lifestyle, not a duty. The changes should be a lifelong change, not only for a while. Thank you very much. Yes.
So much. I think it's very insightful. I think all of us can relate with the content of the presentation in a way or another. If there's any questions from the audience. Yes, go ahead, Dr.
Thank you so much. That was a wonderful talk, and I totally agree with the importance of this topic. But I have some points which I think can be shared here is how we look at fat and obesity. Number one.
Yeah.
Human body is so efficient that with little food you are able to gain weight. This has something to do with our evolution. What agriculture has given to us, it's a very recent phenomenon where you have food for so long you can don't have insecurity. All the diseases which we are trying to say lifestyle or metabolic disorders or most of them. If you look at with the ancient roots, they were the diseases of the royalty or of the nobility. They did not were at this level in the masses. And somehow that gives you an excellent clue of exactly it's kind of more like towards indulgences when we go. So these are the diseases of the abundance. Too much fat, too much sugar, too much salt in my body.
Yes.
So the second question that is coming is, are we trying to create a system where we are fat shaming? Or are we creating, or we cannot fat shame anymore? Or the second aspect that we are talking about is demonizing of fat. Like how we have created a culture where we said butter is fat, but you can have all the margarine you want.
Yes. Yes.
Okay, and that has led to its own complications and everything.
Yes.
So what I am trying to basically add to it is fat is good.
Yes.
We have clear proof of people following keto diet and so many things in which they were able to reverse diabetes type 2. So your points on that.
The good fat and the bad fat.
Yes.
Actually, if we want to implement any change, we have to also consider the background and the culture. Yes, is that your first question, right? I totally agree with you, because to make the changes, it's not an easy thing. It's very difficult. You have to look at the background of the person who's sitting in front of you, his level of education and his beliefs. Because, you know, in some cultures, they do believe, like, you may be surprised with this information. Some ladies, they think if they are fat, they will be beautiful. That is beautiful. This is part of their beauty. In some Arabic cultures. So you have to manage so many things to make the change. You have to implement the change gradually. You have to educate, you have to emphasize of what is good and what is bad, what is right and what is wrong. And it's not an easy thing, but it has to be done. It has to be done. We need more education. We need to emphasize on, we need to, you know, take our culture to a safe place, take our population to the right practice. It's not easy, but we have to start to implement the change. It has to be. I think that's why we come here and we talk and we discuss. This is the aim and this is the target. So this is your first question. Your next question, the second question is the good fat and the bad fat. So it's, for example, we can replace like the oil with olive oil. We can use the olive oil. It's more safe and it's more healthy, right? So now it comes to what type of food we have to eat for some. This also to be part of education. Okay, did I answer your questions? Thank you. Any more questions? I have a comment. Comment. Just good.
Thank you for starting to. I just want to share with you what we're doing in Saudi Arabia. Now we have a big healthcare transformation in the region of 2030, and nursing is contributing to this transformation at a bigger scale. They're changing the role of nurses to be a health coach, to be a case coordinator, case managers, not only the educators, because we want the education to be part of all practice for all healthcare professionals. But yet changing the role of nurses in the community and comes with perseverance. We don't have a nurse professional or clinical nurse specialist, but now we are looking into the control where we can have the nurses take the lead and changing how the community all think about it. And there are a lot of programs to develop those nurses who are taking those roles at the level of treatment. So we can see there a vast future coming for nurses contributing to this new concepts of healthcare transformation and taking the people thinking of their health and their disease to a different diagnosis. So of course, health coach is very similar to life coach, where they help people change their lifestyles, and so they totally individualize them for each patient. It's not the patient who is trying to sit with the need of the patient of their lifestyle. So and they follow up with them, and this of course is very important. And we're looking forward to have this change. The whole thing about. So they look at obviously and lifestyle they look at the details, the patients, hypertensive, pregnant women, school and all kinds of areas where they can contribute. They always can find potentials where they can save the time. I believe nurses have a big role in doing all of this and contributing to healthier community.
I do believe the nurses have a great lead on the specialty. They have to have a great participation and helping preventing those major complications. Now I want to say add one thing. I think we have to start to target healthy people. It was part of your presentation, right? We have to reach every single person in our society. We should not wait for the person to encounter risk factors and to develop the diseases. So I think we have to implement a way to monitor every single person in our society, starting from home, right? You remember you said that you are targeting the healthy people, right? So where you can find them? So how you can find those healthy people to prevent complication of the disease?
That question, how like I later, the principle is, the kitchen is the first pharmacist. So empowering the homemaker, make sure the diet is going on. It's as simple as that. If you give them the best information available at the end, who is making it? Okay, who is getting everything? You can talk about all equality at the day.
When you don't have circles to visit the people at their home and visit, we need more people to be implemented.
No, people need to be self-aware, self-educated. People already have this awareness, even with you, someone telling you, we are doing that on it. If I'm having some kind of diet, I'm not able, if it's not rich in fiber, I'm suffering from constipation. Okay, and then I'm trying out different things to explore. And this is a very much a human exploration which we are doing. Even what we are seeing now, this is more to do with our sedentary lifestyle. We are eating what our ancestors were eating at that time, and they were going for real physical work. Okay, we are not doing the same, but we are still maintaining that. So that definitely adds more influence.
We can't get enough from this.
Yeah, sorry.
No. Thank you, but thank you so much.
Thank you very much.
Very, very insightful. I think we can take the days talking about it. Yeah, that's conscious of the time. We've got another speaker and then a lunch break and then the rest of the speakers. So allow us to wrap it up with the fact that you're absolutely right. Change has to come in phases. We can always change this element and start measuring the waistline as part of the vitals, and there has to be a component for nurses to learn more about it. I can see as a summary that the role of the nurse is just expanding day in, day out, and it does have an impact on the masses. And you're right, there has to be a public awareness that allows us to reach that change. You're absolutely right. Thank you so much. Very insightful, Doctor. Moving on, I'm going to introduce another speaker. No, absolutely not. That was very insightful. Allow me to introduce our next speaker, which is Ms. Subha Masa from Saudi Arabia. I'm passing her the stage to deliver the COVID-19 impact on home healthcare sector in Saudi. Stage is yours.
Until we prepare. Good afternoon. Thank you for your good listening. If you allow me, I will ask you just to stand up, please. Can you join me and stand up? Yes. With all this long day. And I want you to relax for a while. Move your hand. Relax your strength. Open your eyes. Hold the breath and exhale. We are given a lot of information and we need to access. Also, please share all your information. So we are sharing and we are accepting. Agree? That's why we are here today. Okay, good. So my presentation ready and we can set. And I am. Okay, I am ready. I will. Today, I will speak about the impact of COVID in home healthcare in King Saudi Arabia. We learn a lot of the things that all the time when we have good things, unusual things, we have also opportunity for something new. I don't want to say thank you for COVID because we have a lot of mortality. However, COVID is opening our eyes for a lot of the things, keep us to understand the healthcare system, keep us to return back for our life and understand the human again. I think with our dynamic life, we miss this time. So allow me today to speak again about home health care. And I want to return back to basics and to understand what the meaning of healthcare and what the meaning of system. Because on all our progress, I think we forget something. Okay? So today, in my research, it will become my presentation very quick, but please go again for the research and read it, which will have more information. But today we will go to understand again the healthcare system overview, and then we will look for the COVID timeline and the impact on the healthcare system related for King Saudi Arabia, the region, Then we will look for the discussion and systematic review for our research and the impact, and we will come with the conclusion. And I welcome all of you to come also with your suggestion and for improvement after this. Yeah. So healthcare system. What's the meaning of healthcare system? Again, with the WHO, they define the healthcare system that it's an organization. And here, not hospital, all organization. Organization and institution, people, resources. This is healthcare system defined, but they want to work together with integrity, which was added in the year WHO in the August 1722. Yes, we have everything, but they don't integrate together. They not speak to each other. We speak a lot about education, but do you think it needs to come from patient center, hospital center, or we need to speak from the school, or we need to speak from the home? So we need to communicate system with everyone. We are components and we need to integrate together, reducing the resources, utilizing the timing, and also the concept when we build with our small age, rather than to adapt it when we be adult, it's more easy. System need to go influence with our life, with all our skills. That's why we are looking institution, looking organization, profit and non-profit, private and public, all organization, community, leaders, also the public, also the religion, from regardless of the religion. But all this culture, they need to come together, agree that we are in the system. People. So in the people, healthcare worker, yes, resources, out contract, all the people who's coming together, integrating, they have impact. Patient, family, and care provider, all of them, they are work in play. The most important that we understand where we are in the system, how we can impact, and how we can affect as well. Then resources. You highlight many things, I think, in all the presentation that the economic level. I cannot go with the sport if I don't have economic level well. I cannot go for good diet if my diet economic only for carbohydrate. You know the car is the cheapest. So don't look for the way and don't look for the circumstances, and we have too much food, and we have also hunger. So we need to come together and to understand it. Why? Purpose for that. To promote? Yes, I need to promote the health. Yes, I need to stop. And by the end, I need to maintain it. I'm not coming to treat. Treatment is the impact. I need to work before. Working in the prevention in the beginning, I'm working also for the increased awareness. And by the end, the treatment is the disease, which is the chronic, which will become after all the high risk or the other problem is coming. Agree? Okay, good. And from there, we will start. So what happened with the COVID? COVID was announced in the March 2020, and it announced that this is the COVID. All of us are pandemic in that time. And in Saudi Arabia, in May 2031, it announced as pandemic, and we announced the first case of the Saudi Arabia, and we start all the regions. Saudi Arabia as another usual country, we have unknown disease, very fast to spread. Community, they have afraid, we are human, high mortality, unknown. And when we are fighting something unknown, we are putting all our resources for this, and this is what happened. And because they want to protect, and they are looking also to defend the health system. So they make all their effort to have the curfew, social distance, and they announced the national curfew in the June 2020. From that time, we have the curfew, social distance, and all the defense to protect. But again, what we are understand about healthcare system, we are understand that healthcare system on the hospital. This is the understanding, and not also in Saudi Arabia, but I think in majority of the country, we are told if we are sick, we're going only hospital. So our first defense is the hospital. So during all this restrict care queue and the thing, what happens in the hospital? Any patient who has signs and symptoms, he needs to occupy in the hospital. Anyone in the care queue, he's not able to reach to the hospital. So what we have, high utilization for hospital, for patients can be treated in different way. Yes. A lot of patients not able to accessible to the hospital. They need medication because this is only the way how to get the medication. Yes. So no accessibility. Yes, agree. And we need also the hospital number of the hospital, how much they are, but by the end it's totally occupied. No bit overutilized for patients. At the time, I think we have a lot of critical cases or priority that the time to show for utilization. Agree? And I think it's not only in Saudi Arabia. So this is all our problem for care. And by the end, we have private and we have public hospital, and all the things was guided by public hospital and government staff. Okay. So during my research, I did the research to study what's happening with all the system and the hospital during that time. And the research was getting with meta-analysis, and that's the time we go through more than 300 research overall and in Saudi Arabia. The key factor or key word was taken in that time looking for COVID, home health care service, and looking also for the pandemic issue. The system for the analysis was reviewed by two reviewers with my team, and also we analyzed. So we come over with more than 45 research speaking about our product. And the main analysis, what we found whole healthcare system growth and the service what we offer, and by the end, accessibility and the admission for home health care and future demand in the home health care. So those the angle what was discussed and addressed in the research. And now we will go one by one. But in this way, I want also to have your feedback from your country, because I think Saudi Arabia is not isolated, and all of us are facing in the same way or different way one of those. Again. So home health care. Yes, we have home health care in Saudi Arabia, but not in the maturity of United States, not in the maturity of Canada, not in the maturity that we have as institutions supporting the hospital. We have it as a part in the hospital, referring the patient, and keep me honest to tell you, it's not overutilized or properly utilized in that time. First home health care was opened in 91, and they have already the quality procedures, and they have a program, but for limited sources, only for long-term patients, and even not for all type of long-term patients. The effort in 91 is not mandatory for all the hospitals. They started only with the big public hospital, not in the private. And during the year from 91 until today, they have a lot of effort to develop home health care as a part in the hospital. Like you are telling, we are developing laboratory, for example, or radiology, only as a part in the hospital. And patients may be yes and maybe not referred to the home health care. But again, it's not using as a concept that the patient he can utilize and complete his treatment in the home health, out of the hospital. That approach is not mature enough that time. So before 2019, and the time of the COVID, before that, this is the service. So we can come to the conclusion that home health care not utilized enough, limited for the patient. They are not going with the proper service only for limited resources, and also it's only for public, and it's like child innovation. So it's only like limited efforts in the home health care. Like what again in the curfew in the 20s, when the people they are already restricted, not able to get the accessibility of the hospital, and they need to get approval. That's the time the demand and the need for home health care was really shown and really is needed. So what happened? All the hospitals who have home health care, they go to expand their service and they're looking for the way to provide the accessibility of the care for patients, mainly for the chronic patient, oncology patient who need the medication, who need still, they need to give the regular medication for long term. They start to extend their service and they're looking how much they can approach for the patient and to provide the care. That's the point I'm telling you. This is the opportunity for us to look for home health care as one union institution can supporting the hospital and reduce and the spread or the overnumbering of the patient to have to keep the hospital fully utilized for acute or more cases which really need the hospital. And from there we start.
We've got 10 minutes.
Yes, okay. So they already start to increase the service and they already start to open for children to have monitoring for them, for elderly to look care for them, to start also to think about the vaccination, especially we have it in March and that the time is winter and we have a lot of respiratory disease. They consider in the Saudi Arabia the importance of vaccination and the post-vaccination impact, which can become with another problem. And they try to find the way with the institution of Saudi Arabia, how to reach the vaccine for those children in more safe way to prevent any delay in vaccine. And also this is the same story was utilized in Mexico. They go also in the vaccine and they apply the vaccine in the time for pandemic in the same way, in this way. Also, we look for the physician visit. In the time for the pandemic, the private hospital, they recognize, and the private sector, they recognize the need and the impact for home health care. Yes, it impacts in the health and also it's impact in the marketing, and they're looking how they can get this opportunity. So they work again supporting the private, supporting the public, and they start to provide the approach for physician visit and to go to reach the patient, and also to provide some lab tests which can be taken and to be help in the diagnosis for the patient. They also provide some sleep tested also, and also they go with the PCR when the in Saudi Arabia allow for private hospital or private sector to do the PCR, which is really cost effective, proper utilization, easy accessible, and also providing the result in the kind of drainage with accessibility to patient. So again, they look for the service because we are in the digital and we are in the institution, so we are looking for all the resources, so they develop or they support the telehealth or telemedicine. And that's the time the telemedicine before the COVID, it's still little bit and not in the way to see the patient in the home actually, while in the COVID, the telemedicine was developed in proper way. They allow to be seen and to visit the patient, and that is effort is come with the health information system and all the system they communicate again together. Then they go with the remote health program. Health program is enhanced the physician and the nurse with the education for the patient and family, how to monitor and how to ensure that the patient can receive this care. So in the home health care, we look for the service, looking on not only to provide the medication but we look also for treatment, we look for follow-up, we're looking also for awareness, and even if the family they have any concern, they can look. And that's the way which the idea and the concept for home health care developed. And also the COVID was helping to give maturity as soon as possible. So we have rather to speed up for home health care. Again, the importance for health information system. During pandemic, we are looking for all the resources and we're looking for all our defense to come with the solution. So, and that's the time they look for all the hospital, public hospital, which they have the home health care, and they look for the data to develop the platform, and the platform to be utilized by the patient and family to request the service. I will tell you clearly, they have this initiative and they help to gather the data. This is the value of the data. If you will not able to gather the data to make your strategy point, what the value. And during the pandemic, everyone is looking for his resource, how we can come up with the solutions. That one was success because it's easy and easy to be completed and not complicated. The process was clear, so no problem with the communication and it's direct to the point. Also, it helped to assign again the patient with the hospital to relocate them according to their demographic area. Saudi Arabia is too much wide, and I am going with the hospital which I like, but during curfew, I need to go with the nearest hospital, which also keep us to become more accessible for the hospital and the healthcare service. So this is thank you for the technology, what we have it. Okay. So we finish in the here. So in the end, I'm almost done. In the end, we are feeling that yes, the COVID situation is a great impact to face on home health care sector and palliative. We support the home health care. We come with the idea that home health care can stand up alone, not only scheduled for the hospital. It's not accessory. You can have it as institution, reducing the number of the patients from the clinic and the hospital, and it can be stand up to support the hospital. Until now, the insurance not covering home health care, and we hope in the future that we can able to provide the service to the coverage with the insurance. Also, they come with the more awareness for the telemedicine, and now the Saudi Arabia they are looking for the regulation and the rules, and I think they are going to standardize the standard nationally level how to have the telemedicine in the proper way as governance. Also, we have contributing in the increased number of convenience to provide home health care. So before the home health care is only part for government hospital. Now it's for private and for marketing is yet. But again, when you will have increase with the service and marketing, the government will have high responsibility to deliver and to prepare the standards to protect the service and to prevent the harm for the patient. That's why now recently the national standard for Sibahi, the national standard for home health care was issued and going for implementation for this year to control the service and to provide the high quality service from the home health care. We're hoping in Saudi Arabia after that to have the insurance coverage for the cases and to define the difference between home care and home health care, to have already the privilege for the staff who already trained and be educated well to provide the service in a proper way and to prevent the harm. Again, the drive for a convenience to improve their service and to introduce a new service to cope with the curfew to try to replace hospital service. This is really what we need to look. The vision for Saudi Arabia 2030 is identified to look for healthcare sector in different way. COVID, it helped us to open our eyes and to look in the different way faster. And yes, we need to look because again, healthcare sector accessibility is right for everyone. I need to be treated, but I need also to be promoted and to prevent the illness and also to get needs to be well, live in wellness and happy. I cannot work happy if I am sick. I cannot work happy if I am well, not well. And definitely if I am healthy, this is not meaning I am wellness. Yeah, agree? Okay. Now, this is all my references. I'm asking you to read my research. It has all the process inside. I'm looking here to give you the key point.
Thank you so much.
Yes. Anything, any questions? I am ready. Yeah.
Thank you. I'm just conscious of the time. So is there any questions from the audience?
Yeah.
We still have, yeah.
So it sounds like you did a great job during the pandemic My question is about geriatric population and telehealth. And they have a very hard time with it. And it seems like everybody thinks that was the answer. And I'm not sure that was the answer. I have elderly parents, and if I wasn't there to help them run through how to get on the telehealth call, they would have never figured it out. So how do we get the elderly generation involved in this in a way that's going to work for them?
Okay. Geriatric is also one of the development in the community that the number of geriatric increase, and we're expecting also to be increasing more and more because the hierarchy of the community itself. And the demand for the geriatric not only from the disease, but to help them to take over with their life and to also they need some help and maintain and monitor. That's why in the home health care, the program is provided to support assistance and giving them the going well in their life is available. The family need to be preventative, available, or they need to have contact, so especially with the telemedicine to help them. So engagement of the family. Next, in the home health care telemedicine, we are supporting to provide the service, but we are not replacing the family. We are working together. Still, we need to engage with them. And still, they need to choose the representative from the patient to help them if they are not able to open the system or to come over with the telemedicine. So still they identify. The most important, especially in Saudi Arabia, the traffic and the time to come to the clinic, it will take long time. So I'm offering to service in your child, in your home, removing all these obstacles. I need you to be available with your patient, listening more and have added more value time for the patient, rather than to wait till the waiting time and other things which can be solved. And here the key. I hope that I answered.
Yeah, that was very helpful. I think it's based on kind of the culture as well, because probably 50 years ago in the US, that would have worked. His family would have been in the same house. But I don't think we have that same culture here any longer.
Yeah.
And it makes it a little bit more difficult.
Yes. The COVID, it helps us to change the culture very fast. And this is really important because before the culture, even for home health care, the concept of the culture, what the type of service they need is different. They look, for example, for companion to come all the time with the patient, but this is maybe the patient needs is not really that. He needs to be assessed by physician. He needs to have the correct caregivers. Maybe he needs to have a registered nurse, maybe not 24 hours. He needs only for some certain hours. So the COVID situation, it helps us to understand it more, accept the changes, and also help the family to accept the changes to help to have the proper caregiver with the patient according to his needs. And this is very important. Next.
Any further questions?
I don't. Question. You find that when you're visiting a client or patient in their home, that they are more forthcoming with you, they're more comfortable in their home so that they're able to convey their concerns than in a doctor's office or hospital?
Actually, yes, when I'm coming for their comfort zone, especially for elderly patients, they are comfort zone in their environment. We have more responsibility on us because we are coming to them, we are visiting them. So we need to understand and respect the culture, and we need also to be sure that the privacy for patients is more comfortable. With them providing the information and giving the care, we need to be sure that also the privacy is maintained. So if we have visitors, we have a lot of family, we need to be sure that everything was make it in the proper way. So with the good communication with the family, so they can understand, okay, now this is the time for the care. We need only representative one if needed. Otherwise, we need to keep the room only for the caregiver and the patient himself. Patient too much cooperative, and the family, they are too much welcoming, they are cooperative. I can understand because this is the fears for healthcare provider when we still we need to knock the door, but later you will find you are part of the family. Again, a good communication and to be professional and to know this is the time what I need to receive information. This is not to share. It needs also some tools for communication between healthcare provider and the family. Yeah. Yeah.
6 years since I'm market out.
Questions?
I think we're good to go. Thank you so much for a very insightful session. I need to kind of, Maria, I think your session is coming up, the workshop specifically. So are you comfortable to have it done now, or would you like to have it after the lunch? Your call.
Yeah.
All right. I think we'll do the workshop.
Unless people are hungry and they want to.
Preferences? Do we go for lunch or would we go for the lunch, I guess? People are nodding. So after lunch, I think Maria will have the workshop and then there will be a group photo prior to the workshop, if that's okay. All right, perfect. We've got a plan then. Thank you so much, everyone. Lunch is served. Thank you. Workshop already and when they, because they all. What are we doing with the semis from here to moving out? When's the somehow merge with these things on about he's taking any of that. And then you like that's not.
Figuring it out, right? Give some meaning. We don't know. We won't know in 5 minutes. Ask her again in 5 minutes, okay? Thank you, sir. The what? No, okay, great.
Of course.
Great. We're very listening, insightful, and right. And so you'll give me a sprinting house with large fun. Please. Okay. I need a shrink it large. Okay. Thanks. Yeah, just go back and change this and later. Put on this.
This topic is very
Lunch is ready. They can go now. Yes, but they'll put you down during lunch. Oh, I see. So I next year we're going to brings it out. No. And then there's one it's switching to trading. Great suggestion. But I need to get some process. It's not liar, Thanks. What's that all about?
They ask him to pay 100.
Yes.
So I don't know for
It is for security.
Oh, but they will reach on yesterday me I paid them. They will return it back.
No need of then I get checking it will start me a lot if I need that. If I try to change. I don't have
Yeah.
well, it is there honestly.
Yes, the hotel point, how much they will charge you if you will pay by using your card.
But it will be funded.
Yeah,
It's more deductible. But once I use it for dollar, this exchange rate, that will be charged. That will be around 2,000, 2,000.
It was the slightly shaken. The currency, pay, charge me for the exchange, and they will return it to me once you check out. He will help. Let's go to the lunch.
Yeah, you go. I have some work.
But you have to eat.
Yeah, but I have.
What I will bring to you, just tell me.
No. I don't want to have right now.
All right, hi, everybody. Yes, I am Professor Frank Chandamo. You can call me Frank. And I am very grateful to you for presenting this. Thank you very much. Let's hear it for Ines, please. Ines flew here from Dubai, and so she is, we're very lucky that you've done that. Thank you very much. All right. And I'm now going to thank everybody here from the American Healthcare Nursing and Patient Safety Summit, especially Dr. Pascal Annie. She's not here right now, and she's why we're all here, but thank you very much. Okay, so I'm going to be a little bit different of a host. I'm going to be much more ferocious about the timing. So if you go over, I've got this. And if you hear that, you know that life as you know it is over. Oh, don't make me use that then. All right then. So first I'm going to bring up to the stage here. Our first speaker is Ms. Tova Goldfarb Kuhl from USA. Tova, where is USA? Here. Oh, really? Okay, great. Yes. You know, I'm right up the road. Yes, it is. Yes. So I will also tell you that in addition to Maria, I'm also speaking a little bit of the local language. So buenos dias, ¿cómo estás? So there you have it, the local language. All right, and I'm probably your only pumpkin spice moderator here. So thank you very much. Here's Tova.
Thank you so much for all. Good afternoon. It's hard to follow both of those presentations, but I'll try. I may need those ice packs for my hips. My name is Tova. I am a senior program manager at Stanford Healthcare, which is the hospital associated with the Stanford School of Medicine. And today I'm going to talk about a pilot project that we did on the neurosciences unit at Stanford Healthcare in the inpatient setting. I'm going to talk about our pilot team. What is GIP? So inpatient hospice, the history of GIP at Stanford, specifically about our pilot and our different interventions, our lessons learned, and our sustainments and next steps. So our pilot team was incredibly multidisciplinary. We had CNSs, we had physicians, we had APPs, we had program managers like myself, we had social workers, case managers, and our partner and hospice institution Mission. We even had a nurse liaison from then. So what is inpatient hospice? Inpatient hospice is one of the 4 levels of hospice care. It's intended for short-term care, so a couple weeks or less. It's the care provided in an inpatient setting only for patients who have uncontrolled pain or other acute symptom management that cannot be managed outside the hospital setting. They need a specific nursing intervention and care. And it's for patients who cannot be comfortably cared for at home or in a ambulatory care setting. Qualifying symptoms for hospice would be uncontrolled pain, intractable or unmanageable nausea, vomiting, diarrhea, uncontrolled seizures, hemorrhage, pathological fractures, severe agitation or delirium, advanced open wounds, sudden decline necessitating intensive and frequent nursing interventions, and imminent death with symptoms requiring skilled frequent interventions. However, patients who would not qualify for inpatient hospice would be patients who are comfortable for caregiver respite, no symptomology, and difficult discharge planning alone. GIP is not a way to address unsafe living conditions outside of the hospital setting. There are multiple benefits of GIP. For the patient family, they offer additional resources and family support for the end of life process. And hospice caregivers, nurses, and physicians are experts in end of life and palliative medicine. For the hospital staff who may not be experts in this field, they help consult with symptom management. They provide education for the nursing team and the physician teams on end-of-life care management. They help with additional discharge planning and support, and they also round on these patients daily. Our vendor, Mission Hospice, is the largest independent nonprofit serving the peninsula. So for those of you who don't know, the Bay Area, be San Francisco down to San Jose. And it's designed to serve patients and families throughout the final years of life. So they provide community education, palliative care, hospice care. They have a hospice house for patients in the last weeks of life, and they also provide respite care for families who need a break. They provide transitional care for patients before and between other programs. They provide grief support services, and they offer these services for a year after the expiration of a patient. And on top of inpatient hospice, they also provide the other 4 levels of hospice care. So the history of GIP at Stanford is relatively new. The program began in 2016, was a very small program on a dedicated unit. There was an average of about 3 patients a month until 2019, when Stanford Hospital opened their new facility right next door. And then, of course, the COVID-19 pandemic. The average then went to 0 patients per month, with multiple months having no GIP patients at all. In this past February of 2022, there was a committee at the hospital, and they identified GIP as an intervention to help lower the mortality rates at Stanford Hospital. So patients who die while on GIP do not count as a death in the inpatient setting. And there is also a lot of interest in expanding this service to other patients at the hospital. So the current state, the pre-pilot state, was that palliative medicine, which is a pretty small team at Stanford, took over as the primary medical team. The patients were discharged from their service and then admitted into palliative medicine. They went to the dedicated unit. Mission Hospice only came in on an ad hoc basis. They had almost no EPIC access. And there was really a lack of what GIP and the education was around for the providers house-wide, and there weren't a lot of resources available. So the pilot team decided to do a full process improvement project for this pilot. And we decided on the neurosciences units because they're all cohorted in the same kind of physical space in the hospital. They're relatively small service line. That's neurology, epilepsy, stroke, neurosurgery, and then one ICU, the neurocritical care ICU. And there was very strong leadership support for GIP amongst the service line. Education for these 3 units began in June 2022, with the pilot officially launching on July 6th. At this point, we had our Mission Hospice nurses on site 5 days a week. They had full EPIC access. They were able to round and consult with providers on the patients. The pilot officially ended in September, with sustainment happening in October and through November right now. Our root cause analysis, which helped identify our interventions, was really informative, along with some discussions about how other medical centers across the country have and perform their GIP services. One big limitation that Stanford has is we only have a very limited number of licensed beds. We ideally would be able to have a dedicated hospice unit, but we don't have the beds to do that. There was really a lack of clarity on the handoff in the process for transitioning these patients from an inpatient bed to a GIP bed. There were multiple handoffs and conversations to Mission, and there was no standardized screening process for nurses, especially. So we took those kind of root cause analysis of why this was such a cumbersome process originally, and we identified specific interventions for this pilot. We identified kind of the biggest change for our providers, and the big change management portion that we continue to work on now is that instead of transitioning to palliative medicine, these patients stay on their units with their primary neuroscience team. They stay with their nurses, their case managers, their social workers. They don't have to transfer to a different bed. And this really helps with the continuity and continuum of care for these patients. Mission is now on site 5 days a week, and they are able to round and consult with the physician teams and the multidisciplinary teams. They have now full EPIC access, and they're able, which is our EHR, and they're able to potentially pre-screen eligible patients as well as put in consultation notes. And we developed with our CNS and other education team members education and resources that are on the units and readily available for whoever may have any questions about what is GIP, what are the processes at Stanford. Like I said, the big change is that the primary physician team, they stay on their units with palliative medicine only consulting for symptom management as needed. Another intervention that we developed was for the frontline staff. These are more specifically the bedside nurses, the charge nurses, the case managers, the social workers, even the respiratory or other therapists. This is a kind of a screening sheet that these patient care providers can review when they're doing their daily assessments and daily patient care. And if these patients, if they see a patient that may meet any or all of these criteria, they can go to their primary care team, their attending physician, and suggest that a referral for GIP is placed. Some of the screening criteria include that there has been a goals of care discussion. The patient is at the end of their life and death is imminent in days and not weeks. There's been discontinuation of life-sustaining interventions, and there's a request by the family to learn more about hospice or GIP. The big change for the physicians, I think that has been the hardest as far as change management, has been the discussion and goals of care discussion. As people who are familiar with Stanford healthcare, a lot of people don't go to Stanford to die. They go there for, their second, third, fourth, fifth opinion. So these goals of care discussions can be very difficult in this inpatient setting. So we've been working with physicians on having these goals of care discussions earlier and identifying patients which could be eligible for GIP. The physician needs to verify with the patient family that they are interested in hospice, they're on a DNR, and then they need to talk about life expectancy, symptom management, plans for any antibiotics and fluids, and then especially a disposition plan. You can't have a documented discharge plan for a patient to GIP. They should have a plan just in case their symptoms become managed and they're able to go home or to another facility. And then again, the patients stay with the primary team and the primary bedside and their RN, and Mission Hospice again is on site daily and able to communicate with the family members on any change in patient status. The nurses, they have any questions about what types of medications and when they can give, they can always send a message to the Mission Hospice nurses or physicians. So some of the key metrics that we have been measuring would be the total number of GIP patients. Really, there were none, and we had one in May. And then since our pilot launched in July, there's been an average of there has been at least one GIP patient. Not a huge change that could really affect some of the key performance metrics that the hospital measures, like mortality index, but it's been really meaningful for the families that are on GIP and the staff on these units. We've been measuring referrals consistently. In the beginning, there were a lot of referrals, and that's, I think, it's been a big learning curve for these providers. I think they were referring every patient who's at the end of life without really understanding what patients could be eligible. And as the pilot has gone forward, they have been able to refer more eligible patients. So now most patients who are referred on the neurosciences units have been accepted. And kind of interestingly, house-wide on other units, GIP has been, just by word of mouth, there have been more referrals from other units, and our numbers are actually up to pre-COVID numbers for house-wide. So these include oncology patients, medicine patients, surgical ICU patients, and we can tell how the process has changed through every intervention that we've had. Just by when it was identified in September as a potential intervention, Stanford has consistently had at least one patient over since then. So here's some of the data on the number of referrals denied versus accepted. I think here there are still about 40% patients that are denied. I think updated, the most recent data that I heard it's gone down to 37%. I think what's been most surprising for the team is that there have been patients and families who have refused GIP services. They really haven't seen the benefit of the extra paperwork because they may just be a patient and a spouse who maybe doesn't need the support or all the other wraparound services that Mission provides. And then there have been kind of other patients that are accepted but not enrolled, and many of these have passed before they were able to be enrolled into GIP. Like I said, these patients are very sick and this is the end of their life. So sometimes, you know, it can take a couple of hours or even a day to enroll a patient onto the service. And sometimes the patients do expire before that. Fortunately for the pilot, there have been the most referrals from neuroservices, followed by oncology. I think going forward, oncology is going to be a great partner in this service. They're very interested in working with Mission Hospice. There have been some from the ED, medicine, and then a surgery and trauma ICU referral as well. The team has learned a lot from this pilot. I think the biggest one has to do with the whole process of discharging and readmitting and everything that goes along with it. I think at Stanford, all the billing and the compliance and reporting is all tied into the electronic medical record. So it's a very multi-step process to discharge a patient from an inpatient bed and then admit them back into GIP. I think a lot of providers, this is a dissatisfier because there's more clicks that they have to have and more conversations that they have to have. We're really working on, for next steps, is optimizing this process so the provider just has to click one like box, and then the orders are in and the patient has been transitioned. I think another lessons learned is informing Mission early in the goals of care conversations. It's very helpful in streamlining and identifying eligible patients. I think, you know, we were discussing earlier, my colleague is here with me, about how physicians will identify a potentially eligible patient, but they haven't had the goals of care conversation with the family yet. So I think that it's on their mind that they want to use this service, but I think they kind of try to put the cart before the horse. And I think the most important thing is to have these difficult conversations with the family and the patients before. The number one denial reason by Mission is that the patient is comfortable and they don't have uncontrolled symptoms. These patients would stay in an inpatient bed under comfort care. They wouldn't qualify for GIP. And even if they're not GIP eligible, Mission does have their Mission House and home hospice that they are able to work with the case managers to transition them out of the hospital if they're appropriate. And also, I think the biggest one has been Mission on site, documenting in Epic their notes with the care team and being able to be paged on like an as needed basis has been really helpful, especially in supporting the frontline nurses if they have any questions. Some of our next steps it's been created a compassionate extubation and GIP pathway. So those patients who are going to be compassionately extubated, to have them admitted onto GIP before they are extubated in anticipation of their uncontrolled symptoms. There has been ongoing re-education for providers on the importance of goals of care conversations and speak to families early about hospice. We're in the planning stages to update and launch the workflows for medicine oncology. Those will actually go live in December. There's been a creation of an ebook for families and providers on end-of-life care and GIP, including words that work and how to talk about death to family members and patients. The re-education has been in process. And for nursing specific interventions, there's a competency that all nurses have to take every year, and GIP is included into the end of life competency for bedside nurses. So we really want to empower the nurses to feel comfortable talking about GIP and hospice with the providers and the admitting teams and in multidisciplinary rounds. The module goes live this month. And there's a big project with Epic, which is our EHR, on streamlining the discharge and readmission. And this goes with, this is multi-tiered because of the billing billing and compliance issues. And then we're partnering with our community hospital to get an automatic report around these patients and that are pulled from Epic. Right now, all of the data and chart review has been done by hand, and it's very cumbersome and time consuming, but it's worth it for this. And that is the end of my presentation.
All right, well, thank you so much.
Thank you. Are there any questions?
No, go for it. Yeah, let's get some questions, you guys. I'm warning you, no questions. I'll bring those answers right back in here.
Yeah, of course. Yeah.
Yeah, I mean, it's a continuous improvement project.
Yes.
Right, and well, the fact that you did the as is, and then the root cause analysis and the lessons learned out of the effort. But it wasn't quite sure, why did you choose to kick off that pilot as a starter? What was
So the pilot was really driven from an institutional desire to lower their mortality. Because these patients, when a patient does expire on GIP, it is not counted towards towards the mortality of the hospital. However, the team, that's not why we got so many people on board. Like, these are all like our team members, and every one of us are incredibly passionate about end-of-life care and providing the highest quality end-of-life care to as many patients as possible. And this is one way that we are able to do this. But institutionally, I would say, so Stanford is ranked higher. Any other questions? Okay.
All right. Thank you. Tova, thank you very much. Let's all wish Tova good luck with her new baby as well.
Thanks.
And now our next speaker is Ms. Rama Al-Awlaki from the UAE. Did I say that anywhere near close to correctly? Correct. Okay. It was just online. I'm passing her the stage to deliver the speech on highlights of healthcare management and safety challenges during the COVID-19 pandemic. All right, so let's hear it from Ms. Rama. You should have it because it circulates the blood, folks. It just doesn't make her feel good.
Okay, until the lady will fix the laptop. So here, this is Rahma Al-Awlaki. Actually, I'm from UAE, that's the United Arab Emirates. So I came today to explain for you regarding, we already have been during the pandemic and the COVID, but I'm just here to try to highlight what the achievement that we have been done during this whole, like we say, almost 2.5 years, like from the country level to the organization level, to the department level. So my title will be about actually the healthcare management challenges during the pandemic. Are we even close? It will work now. Yeah. Sorry, guys. No. Which side? Yeah, I tried to find this one. It's not.
An excellent time to get to know the person next to you, by the way.
It's not here. So you can. So you can mount like this. The pointer to be. No, it's not a pointer. It's just to change the slides. We can just.
That's fine. That's fine. Okay. That's fine. Yeah. Perfect. Thank you very much. So sorry to keep you actually waiting a lot. So my topic today will be about the highlight on the healthcare management and safety challenges during the COVID-19. So there is no conflict of interest to declare. So my content will be about healthcare management origin and definition, core and value, the UAE combating COVID-19, the measure that how we contain and combat the COVID-19 in my hospital, the Sheikh Khalifa Specialty Hospital, core and value, the other achievement and importance of the safety during the outbreak, and then we'll specify more about the pharmacist's role during the COVID-19. So the healthcare management. So what is the definition of the healthcare management? Why we focus on the healthcare management? So everybody knows that the healthcare management actually, it's a very first modern program which established by Father, he called it Father Moliner, which is associated with the Catholic Hospital Association, which had been released and published from the University of Chicago in 1934. The healthcare management actually, from its name, it can be implemented on that it's an overall management on the healthcare facilities such as clinic and hospitals. So what is the core and the value of the healthcare management? So the healthcare management can be the umbrella, cover a different type of job titles such as clinical director, supervisor, healthcare coordinator, and home facilities as well. The healthcare mainly depend on choices, hierarchy of action, and the goal. So most of the time that we keep saying that the value actually guide our action. So we're going to speak about more in UAE, in the United Arab Emirates, how we actually combat the COVID-19. So the first step was the emergency response mechanism. So we have authority in UAE, we call it as abbreviation of NCMA, that's acts for the National Crisis and Emergency Management Authority, with the collaboration of UAE government, with issuing the first alert in how to face the coronavirus outbreak. So even this all the announcements, the alert had been issued in the first beginning was always as an initial country, even before WHO was declared about the emergency of international concern. So the UAE have a very comprehensive action that the whole government was actually funded the health system, especially covering the government and the private as well, for the whole health facilities to deliver a high standard of the healthcare to a population. Especially during the pandemic, the whole healthcare system was prepared by issuing the first protocol on how to help the people to face and handle the crisis. So these are just a few samples of the whole circular that's been issued and released by the UAE government during the COVID-19. So it's what's starting from January 2020 till October 20. So the second step was the risk communication and the public engagement. So the most important part from the government itself, they was focusing to assure that all the information will be transmitted to the whole community regarding actually from the clinical background or even from the community background. So everybody needs to be involved in this. So the whole actually detailed awareness campaign was target a different group of community by having a daily update regarding the status of the disease locally and internationally. And help on that, so the UAE was trying to have a very effective smart technology platform. So like there's just a few examples of that for example, in MOH, what we call it Ministry of Health and Prevention, they had their virtual system, which is called a virtual doctor for COVID-19, which is about like a chatbot, a service was providing for every member in the community. Second one actually was initiated by a doctor for every citizen as an application as well. So third one, we call it wiqaya. Wiqaya, that it's an Arabic word actually, but the meaning of wiqaya is the protection. So wiqaya platform actually was issued by NCMA government, which is utilized to enhance the awareness among the public regarding anything about the health crisis. Then the last app was about Al-Hassan app. This application actually was integrated digital platform to using for the whole community when you get your result from the COVID-19, whether it's positive or negative, and actually you're by receiving a text message during your smartphone. So what was the vigorous public health measure to contain and combat COVID-19? So the country launched what we call it as a first world third clinical trial. This trial we call it for humanity, that the whole, like we had a group of people was get a COVID inactive vaccine to be injected for free for everybody. And that was actually in collaboration with G42 Healthcare by using Sinopharm, CMBG, with the under authority of Department of Health in Abu Dhabi and Ministry of Health and Prevention for the whole remaining Emirates. The vaccine actually was authorized to be used, giving, as I mentioned, free of cost to the all residents to assure that we're going to be the top ranking of the highest rate of vaccination. So the most target is that for UAE actually to handle the crisis as much as they can. So they continue to be a pioneer in the whole Middle East as a leading example to have a comprehensive protecting procedure and protocol for the whole population. In addition to that, to be reopening the economy without any losses. So we'll degrade more that to have more emphasis in my hospital, which is Sheikh Khalifa Specialty Hospital. So my hospital is a leading medical facility that in the Emirates, which is also it's a repair hospital for 3 subspecialty: oncology, cardiology, and neurosurgery. The vision is to be a world-leading medical hub in GCC, and our value is integrity, quality, respect, and teamwork. So there's a few achievements for the clinic as a clinical achievement in my hospital. So there's around actually 85 achievements have been done within 8 months. And I just tried to make a brief for you, which is the most important related to the healthcare management. So for example, we initiate the remote work for the whole admin staff, especially for the special cases like who have like infection, vulnerable employee who, like, for example, the ladies for the first trimester pregnancy, and if we have a chronic disease. For the visitor control, especially that as an OBD visit, inpatient visit, and other visitors as well. There was also restriction in the entry to the hospital. Regarding the drive-through services, so we had a 2 drive-through service. First of all, that we had any patient will be, for example, assigned to enter the hospital, we're gonna have we had a cabinet for the drive-through test for the COVID, and they will do this test for them for free as well. Second drive-through service was actually for the pharmacy. We have actually a special construction cabin for the patient. So instead, if they will receive their medication from the pharmacy, they will receive it from the drive-through cabin. The other thing is about also for how we was treating the patient. So actually we have 2 different triads for the treatment and consultation that I can explain in the next slide in details. So what is the importance of the safety in our field during the COVID outbreak? So we had 2 procedures. We call it teleconsultation, that every patient will get a consultation from their physician and by providing a communication technology either during the phone or during a video call, which we call it through app Zoom. The on-site visit will be physical availability of the patient in the hospital to see a physician or to receive any kind of examination or kind of test you need to do. So our hospital was providing a teleconsultation for the patient who need medical service and OBD, which is the outpatient department, during unexpected infection of the pandemic. So what are the criteria for having a teleconsultation and for not? So for a patient who are gonna have a teleconsultation, so no need to visit the hospital in this case, they will have for a normal revisit patient, so a normal refill for their medication, and they are very stable. Then if any case, for example, if we need to explain their lab or result of the X-ray or whatever. The other on-site visit, which is they are not eligible to have any teleconsultation, so their presence physically in the clinic, it's more is very significant, especially for the post-operative visit check, wound and clinical condition, patients who require invasive procedure, the new patient, a follow-up less than 6 months for the interval cases, post-discharge for the first visit, the revisit patient with any new complaint, and the patient who receive any required tests like X-ray, blood, and screening, etc. So let's also more specify about the COVID pandemic, how we can combat that as a pharmacy perspective. So what is the pharmacist role in this case? So we all know that it's the COVID pandemic was a very significant, actually affected the whole individual. So the pharmacist role was that how to assure we provide a medication with a good supply to the patient. So the country issued a circular, we call it like, it's a special circular only for the COVID, that all we know that as a control medication or semi-control medication, it should be only by the regulation dispensed for 1 month. But because of the pandemic, so to reduce that patient will be exposed to any kind of infection, we had by the Ministry of Health issue a circular released as the number 3523 on March 2020 that the doctor, especially the consultant for the semi-control and the control, she are eligible to to prescribe for 90 days, and the pharmacy also allowed to dispense for the 90 days. Then we have a remote pharmacy services, for example, as a medication delivery system and telehealth, providing emergency supply refill during the COVID to renew and extend any prescription for the continuum of the care, to have a guidance for other healthcare providers during the infection of the treatment, especially for the infected patient. Then follow up on the patient medication safety and efficacy being actively treated with the proposed COVID-19. So that, for example, the importance of the compliance, whether the patient are still taking their medication, even if they get infected or not. So from the pharmacy perspective, that we had, as I mentioned, pharmacy drive-through announcement. It was actually initiating from May 2020 till December 2020. So there was 2 locations, the outpatient pharmacy and the drive-through the pharmacy. So drive-through pharmacy was located near the main entrance of the hospital, so the patient can be entered easily, and the ground level pharmacy will be inside the hospital. So all patients was receive a text message in English and Arabic when their medication is ready for collection from the drive-through. Where are the notification also for the patient, even if they need to be physically available in the hospital, but they don't want, for example, to wait in the pharmacy to receive the medication, they're allowed to go back to home directly and coming next day to collect their medication from the drive-through. So this is actually an example of the cabin of the drive-through and the car, how it can be easily collected from the window. So the pharmacy was implemented a very 3 important initiatives during the COVID-19. First of all, I mentioned the pharmacy drive-through services, which is minimize the number of the patients entering the hospital, actually, which is around more than 50%. In addition, that most of the patient was very happy to receive their medication from the cabin and happy to collect it with 0 waiting time and without any parking service. This is one of the way of dispensing window. So the number of the number of the prescription was actually increased a lot dramatically until we reached the highest number in July. Then until December. This is the second initiative was the medication home delivery, which was free of charge, that the service was provided to the limited group of patients who need specific criteria. For example, the most responsible physician will prescribe the medication up to 3 months. The pharmacist will actually validate this prescription, except the control, because the control needs to be the patient available on the spot in the pharmacy itself. Then the pharmacy will prepare the medication, and the pharmacist will communicate the delivery company, which is a third party company, who will transport the medication for them. So the percentage of the medication was successfully delivered around 98 to 99%, and the return was 1%. The challenge for this kind of opportunity was the patient compliance. proper communication and receive their medication, and the language barrier. However, that as a third achievement based on the home delivery was medication home administration services. Actually, this was a very significant step for the oncology patient, especially when for example, if they have like any kind of an injection, they need to be injected and wait like for an hour or 2 hours in the infusion room. So instead of waiting in the infusion room, the doctor will allow them actually to be administered this medication at home with a special healthcare provider. So as a challenge from the pharmacist practice, that sometimes because of the COVID and the pandemic, we had a lot of issue with the medication shortages and out of stock medication from some suppliers. The high increment of the patient number, especially for the people who are coming from abroad, because of the COVID, especially for the oncology patient, the patient expectation, some of them were really frustrated of the long waiting time because of the fear and the new service that had been actually, even as a medical staff, it was new to us. Then lacking of the clinical counseling, insurance issues sometimes for the co-payment, then inadequate staffing because all of the staff sometimes was infected with COVID-19, then lacks the discomfort of the temporary expand practice services. So I can say that the healthcare management, actually, it can be like an umbrella to cover many activities and actually achievement, whether in hospital or even in the clinic and the home service. So that's why we need to focus most of all on the safety of that. However, any challenges actually we're going to have to encounter by measuring the efficacy and consider these challenges related to our framework. So that's why we need to make a judgment about the efficiency and throughout the health system to improve our policy and managerial decision. This is my references. Thank you.
Thank you so much, Ms. Rama. May we open the floor up to questions, please?
Yes, please.
Become so knowledgeable. I mean, like, who put this in you? I mean, you are so well read. How did that happen? I mean, you look very young, first of all.
Thank you.
I mean, like walking encyclopedia, you know, you might as well be in the World Book of Health Encyclopedias. How did you get that? Like, tell us how you learned all of that in the hospitals and becoming part of the leadership in hospitals, and then knowing how to navigate every step of the way in patient care and patient safety.
First of all, this is the enthusiasm. When you are really an enthusiastic person, you will do it from your heart. So, because at the end, you will focus, you will say that, God forbid if this patient will be one day one of your family. So you need to make sure that every service you need to provide it, this is belong to you. So you provide as if it's for God forbid for your father, for your mother, for your family. So make sure that every service needs to be provided. Actually, you need to provide it in 100%. And let's let's say that the media and everything and our leadership, the UAE government leadership as well, we really have a very objective, and we have a smart target, and we really have a very skill in the high professional leadership how to help people to get involved. So there's no difference between, let's say, those are UAE national, or these are resident, or these are just a visitor. No, we are in all one community. We need to cover all of them. That's why UAE was a pioneer in the 100% vaccination for their people. So this is one of the very successful achievements have been done by the country. So from that, when you see as an example of your country as a leadership, that will build you inside to work and to be in a very high professional way. I think that's maybe help also in that. Yeah.
Thank you.
Yeah. Yeah. Thank you.
Simple answer and a beautiful question. You're not related, you two, are you? Any more questions? Okay, so the rest of you are just know-it-alls. You know everything. Okay, great, fantastic. Then I don't need to go tomorrow. All right, well, thank you again, Ms. Rama. Thank you very much. All right, our next speaker is Ms. Antigone Koliakis from the Antigone. Antigone is going to be speaking on quality improvements in disease management for Joint Commission International Clinical Care Program Certification.
Yeah.
And again, during this little break, it's either you talk amongst yourselves or bring in the dancers again. But get to know your neighbors.
Are we ready? Ready? All right, good afternoon, everybody. Can you hear me? Okay, I tend to be very loud, but sometimes not loud enough. So I hope everyone is enjoying the conference. I'm happy to be here. I know I'm enjoying myself. I'm here to present an overview of Joint Commission International's Clinical Care Program Certification and introduce the new changes to the program with the upcoming 4th edition. And by doing so, I plan to demonstrate that the foundation of JCI's CCPC program focuses on quality improvement in disease management. So I'm going to begin with a brief overview of JCI accreditation and certification. So what I wanted to start with is talk a little bit about what accreditation and certification is. So I have a sneaky suspicion that most of the individuals in this room are familiar with Joint Commission International and accreditation and possibly certification. So bear with me while I provide you with a little bit of an overview. So fundamentally, healthcare program accreditation is about improving how care is delivered to patients and the quality of care that is received. I'm going to focus with providing you a definition with accreditation first. So we're going to talk about accreditation, okay? So in talking about accreditation, basically, it's about improving how care is delivered to patients and the quality of care they receive. Okay, there really isn't one definition for healthcare accreditation, but if you think about it, perhaps you'll take into consideration that the definition on the screen here is a pretty good definition of what accreditation is. Take a moment to read it. Okay, let's take a look at some of the words. Third-party organization. Excuse me, I'm sorry. I went a little fast there. Okay. Third-party organization, eligible program, institution, complies with the required setting and standards, indicating a level of quality, performance, similar attributes that have been met. Okay, we're focusing on the left side. You tend to agree that that's a pretty fair definition? Okay. The idea is that unless you're an organization whose mission and goal is about quality, you probably need external help. Okay, arguably the best approach to employ that external help is through accreditation and program certification, where you invite an independent, unbiased set of outside eyes to assess your performance and identify quality and safety gaps. Okay, and because certification fundamentally is the same thing as accreditation, I'm going to say that we can probably use the same definition that we're using for accreditation to define certification. Okay. So we're going to go ahead and do that.
And then we're going to add a few different elements to it that we see to the right. Okay. And the reason why we're going to add these elements is when an organization adds the element of certification, they're doing that voluntarily. Okay. And when an organization pursues certification, they want to do that voluntarily, and they're doing it with a conscious effort. And they're doing that by setting another level of goals to the accreditation goals that they're already aspiring to achieve. Okay. And they're doing that with standards that are optimal and achievable. They have a visible commitment to do so to improve the safety and quality of patient care. They want to ensure a safe care environment. They've made the commitment to reduce risks to patients and staff. And they've made the commitment to do that with global recognition as an effective quality and evaluation management tool, which is what certification is. Certification is global recognition as an effective quality and evaluation and management tool. Now, if anyone is familiar with JCI, they know that there is accreditation for every setting. And you can see, as you can see that here. We do the accreditation. What we take pride in is addressing continuum of care. There are certifications that are available in all of these settings except laboratory. Laboratory has its own accreditation, therefore certification is not necessary. What is the value of accreditation and certification? While it is complex to quantify the outcomes resulted from accreditation and certification, we have anecdotal evidence from our accredited organizations and certified programs, as well as from some studies indicating that accreditation and certification to be positively associated with many desirable outcomes. Such outcomes include these 5 buckets that you see here on the screen here. In addition to these, we're going to move beyond accreditation and talk a little bit about disease-specific certifications. And the reason why I want to focus on disease-specific certification today is because I'm not here to talk about accreditation, because we can talk about accreditation all day long. We're going to talk about certification because I'm very excited to be here to talk about the 4th edition of CCPC program, the CCPC program, and the upcoming changes that we've made to that program. So what are the benefits of certification? Certification creates a culture that is open to learning. Certification establishes collaborative leadership that sets priorities for quality and patient safety. It also improves the public trust, and the CCPC program does that very well. Okay. The CCPC program has components that listens to the patients and their families, respects their patients' rights, and partners in the care process, provides safe and efficient work environments that contributes to the worker satisfaction. And in addition to that, certification programs, in addition to CCPC, is very mindful to negotiate with sources of payment for care and with data on quality of care. I'm going to go ahead and move forward and talk a little bit about our CCPC program. As I mentioned, the JCI experience does not begin and end with accreditation. JCI offers disease and service-specific certifications for organizations via its clinical care program certification. JCI CCPC provides an evaluation of a clinical program that delivers care to a defined patient population. Certification is designed to evaluate the acute and chronic disease management and clinical care programs provided by hospitals, ambulatory care, home care, and long-term care centers. There are 18 different designated JCI certification programs, and they are all very different. They cater to target populations. JCI has awarded more than 100 clinical care program certifications. JCI's unique designation for excellence in disease and condition-specific care. Many organizations choose to pursue multiple CCPC programs to improve the quality and safety of patient care, attract more patients, and draw top-level talent to their services. JCI certification is available for all accredited organizations. Any clinical program in a JCI accredited organization may apply for certification, and the program uses its clinical practice. If they use clinical practice guidelines that is evidence-based and endorsed by a professional society. And we're going to talk about clinical practice guidelines that are clinical based and endorsed by a society momentarily, because that's going to be one of the changes that we're making. I'm not sure if you're familiar with this, but the CCPC program also has another component to that. We also have a specialty center certification. So certification as a specialty center for specialty hospitals is also a certification that is available by JCI. A specialty hospital that is JCI accredited and meets specific eligibility requirements may apply for certification as a certified specialty hospital for the specific specialty provided. For example, a JCI accredited hospital that treats only cancer patients may apply for certification as a certified cancer center. Similarly, a JCI accredited hospital that only performs joint replacements may apply for certification as a certified joint replacement center. The standards are organized to follow a logical order of evaluation. The first chapter identifies the updated international patient safety goals. And if you're familiar with JCI accreditation, you'll be familiar with the fact that IPSG chapter is also in the accreditation manual. The second chapter evaluates the program structure and leadership support. The remaining 4 chapters follows a natural progression, delivering care, encouraging patients and families to self-manage their disease or condition, managing the clinical information, and also monitoring performance measures for potential areas of improvement. The survey process gathers standards compliance information throughout the entire program, and the certification decision is based on the overall level of compliance with the standards found throughout the program. Now I'm going to spend a little bit of time talking about the updates for the upcoming 4th edition that is effective January of 2024. The 4th edition is currently in development and is due to be published in July of 2023, and the standards for the 4th edition will be in effect in January 2024. Today, I plan to highlight some of the more notable changes we are making to the program. In keeping this brief and on a high level, this new edition was revised and organized to align with the applicable requirements found in the JCI accredited standards for hospitals 7th edition, the Joint Commission Disease-Specific Certification Program Core Manual, January 2022, current evidence-based practices, clinical practice guidelines, and for the purpose of clarifying requirements and expectations. How many people in this room are familiar with JCI accreditation? JCI CCPC program certification. Okay. So some of the high-level changes in certification is that this the revised and the reorganization that we just talked about will align with not only the accreditation manual, in addition to on the domestic side, as I mentioned, their certification program. And is anybody in the room familiar with the Domestic Joint Commission certification manual, the disease-specific certification manual, not only the core manual, but also their advanced programs, like the heart attack programs and the stroke programs, all of their programs. Okay, so the JCI CCPC manual that I'm talking about now, the clinical care performance manual, it is their core, it is the international certification program that is similar to the Joint Commission Domestic Core Certification Manual, the DSC manual. It's the same thing, but on the international side. That's the manual that I'm talking about now. Okay, JCI does not at this point in time have advanced certification programs. We are hoping to in the future, but we do have the core manual. We haven't revised it in a long time, but this 4th edition manual right now, we have revised and we used the TJC DSC manual along with JCI's 7th edition hospital manual, and we crosswalked that and brought this manual up to standards. So it really is in comparison with those manuals. So the changes that I'm talking about today are significant changes compared to what the 3rd edition manual is. That's why we're very excited about this manual. So some of the revisions that we've made are to the eligibility requirements, in addition to the certification participation requirements. And some of the new additions that we brought into this manual we are introducing, it is still in development, but we are introducing a JCI clinical practice guideline selection process. What that means is when our customers who submit their clinical practice guidelines for their target population, we are developing a process to assist them in selecting the guidelines for a submission process. Because I know sometimes our customers struggle in selecting guidelines for the target populations. So we're hoping that the process that we're putting in place will assist our customers in their selection process. So it really is to assist our customers. And then we are also, we've already developed an automated CCPC intracycle review process, and that will be going live as well. So moving beyond a high level, talking more into the specifics, I'm going to talk about some of the specific changes specifically. And that will be moving beyond that. We have noted that, and you'll see this both on the domestic side and on the international side, we want to remove a lot of the duplication. And what I mean by that is when you're going through an accreditation survey, we want to, and then you're going through a certification survey, there shouldn't be duplication. So if there are any requirements in an accreditation survey, you don't want to have to be surveyed to those requirements again when you're going through a certification survey. And we were very conscious of that when we were reviewing this manual. So, and because of that, we tried to remove any requirements reasonably if there was duplication. Now, there will still be a little bit of duplication because if it will lend to the target population and if it was justifiable, we will leave it in the program. But again, if it lends to the program and is justifiable, but we were very conscious of the fact that we didn't want to, we wanted to eliminate the duplication. And we worked really hard to do that because you already been accredited. There's no reason to duplicate any requirements. So we removed those. In addition to that, there used to be an enrollment and discharge of the program for patients, and we removed that because a patient should not be enrolled and discharged of a program. Enrollment of a patient is dependent on their diagnosis. If you have a stroke patient and your certification is a stroke certification program, if you have a primary stroke program and your patients, if your population is a stroke patient and you have a specific target population and it meets the criteria for your program, then your patient does not need to be enrolled in the program. The diagnosis of the patient, if it fits your program, then your patient is automatically enrolled. Should not be an enrollment. So we removed any criteria or requirements for enrollment and therefore discharge of the program. We added a requirement for a program charter. We felt that there should be a charter for your program because everything should be in alignment. And we felt that if everything is written and that you had everything in order and you were able to identify what your program was about, a written charter, we felt that you would have everything organized in your program and you would be able to identify to a surveyor and your multidisciplinary, your interdisciplinary team, therefore everybody in your program, what your program would be about. It just made sense to include a charter in your program. We also added written documentation of compliance to more of the requirements. We focused requirements on the target population, and then we also refined clinical practice guideline requirements as well. Now, moving a little bit more into specifics, I wanted to provide some examples and to tie these changes to these examples of proposed program requirements. And what I mean by proposed is that we are still developing the requirements. They have not been finalized yet. I'm also at the end of this presentation will provide you with an opportunity to lend your voice before these requirements are finalized. So some of these examples are up on the screen here. One of the examples, or two of the examples, are regarding the program plan or charter. So, and that requirement is focused on the purpose, mission, vision, objectives, scope of the service, and the target population. In addition to that, the program charter will also require the roles and responsibilities of the program leaders and the interdisciplinary team members. And that requirement will also specify that those roles and responsibilities will need to be clearly defined. Okay, so if you take a look at that, I want you to think about what's missing. Did we miss anything? Because the opportunity for you to lend your voice, and I'll explain that later, is I want you to think about if we missed anything, we want to hear about that. Okay. Perfect. Okay. In terms of target population, those components will be included in the proposed requirements for target population. Clinical care will align with best practices relevant to the target population, access to and appropriateness of care and treatment, acuity of the patient's condition, determining the resources allocated to meet the patient's needs. Level of care will be equal. We don't care patient A, B, and C, what resources they have or who they are. We want equal opportunities and equal resources for every single patient of that target population. That's very important. Okay. And then standardized process to deliver or facilitate the delivery of clinical care. We want it to be based on the target population served and align with evidence-based practices. And we want to demonstrate evidence of clinical practice guideline compliance. All right, additional updates. We are having a public field review next month. So that's where we would like everybody to lend their voice. We have a new companion service process guide that is in development that will be coming up in the next 6 months or so. And customer education prior to the effective date will be coming out as well. And we will be heavily providing customer education. That is something that we think is extremely important. So this is where I am asking you to help me. If you could right now take out your phones, please scan the QR code. And it will take you 1 minute to provide me with your voluntarily, of course, provide me with your information. I will send you the field review next month. And you can then also with that information, you can pass that information out to anybody. I'm happy to send the field review to anybody who wants to take it. Claire, my colleague, Dr. Claire Sorensen, who will be speaking tomorrow, is also passing out my business card. Please feel free to reach out to me. I am happy to send the field review to anybody in any organization who would like to take it. We want to hear your voice. If you haven't realized, I'm telling you now that public opinion matters. When we write our requirements, we write it with the voice of the public. We want to hear what you have to say. I've written field reviews before. I've written requirements for Joint Commission on the domestic side, and I'm writing them for Joint Commission International. We take your thoughts and your feedback into consideration when we write our requirements. We want to hear what you have to say. So please send me your information if you are interested in taking the field review. And what the field review is a copy of the new program. And I will send you the field review next month if you want to review the new requirements and provide feedback on what you think about them. And you are happy to pass that along to your colleagues to take the field review as well. And I thank you for your time today. Thank you. I'm happy to take questions.
And one can transition, please.
Yes.
Hello, my name is Leola Williams, and thank you so much for what you do.
Thank you.
My question is, I know that during COVID time, this was a very, very much challenged time, and especially for reviews. And to be able to do things under the Joint Commission. What I'd like to know is, was there any challenges in doing Joint Commission during COVID time?
Yes. I'm not sure. I'm sure you are aware. I'm not an international surveyor, but what we had to do is we had to change our model of survey. We changed our model to virtual surveys to accommodate COVID. We learned some very valuable lessons. We also learned that we can do virtual surveys. Our customers liked virtual surveys and they didn't. We now have 3 models of surveys. We have on-site surveys, hybrid surveys, and virtual surveys. And we are not sure what the future is going to entail, but as of now, we are continuing all 3 models. So it was a difficult time. We had to stop surveys completely. And that was a difficult decision, but it was a safety matter for all around. But with the 3 models of surveys, we've been able to accommodate our customers' requests. And we have been able to continue surveying and keep everybody safe and do what we do best and what we love to do. Yeah. Thank you.
All right, and we have one last question from my cohort here, Eunice.
Thank you. I think over the past 5 years, I had the chance to work on 3 JCI accreditations from 3 different hospitals. And the first magnet in the UAE as the first in the region, give or take. So 2 facets for the same kind of question. The first one is the international surveyors that I had to deal with. It struck me that for FM chapters, like 16 and all. Exactly. They're very facility management, engineering in nature. Correct. Heavy duty. But we got dentists. That was a shocker for me as a first. And I was like, why is this happening? Is it because doctors are the end users and they should dictate what facility management should look like? Or is it because of the situation, over the years, we can't find specific kind of surveyors? But typically you would expect an engineer for that particular chapter and a doctor for the other kind of the clinical chapters, nursing for the other components of it. That was something that wasn't clear for a lot of the international clients. And the second facet to the same question is international operation. Hospitals that operate internationally, per se, they've got so many accreditations, certifications they're expected to meet. And will there ever be a light at the end of that tunnel where rather than having so many, it's a unified one, so that the aspiration is delivering. But the standards are very much similar. It's just that the body that's granting that for an international operator is a different body, be it JCI International or Magnet or any of them out there.
it's becoming a little bit overwhelming, I think, for international operators. And will we see any change on that aspect, other than the upgrades that we get with additional components or removal of certain components? Thank you.
So with, in response to your first question, I don't have a response per se for your particular situation. I will tell you that being a nurse in an organization, I'm familiar with various aspects of a hospital setting, for example. So I can manage the majority of FMS. I can tell you that the roof will give me a problem if I have to assess a roof, but I can do the majority of it. I don't know why they gave you a dentist for that, but they may have expertise in all of it and have done it for a long time. I'm not sure. But the expectation is that we have training and that they usually will give you an administrator. For the most part, a survey would entail an administrator, a physician, and a nurse. There's usually 3. It depends on the how large the hospital is. And so there's usually 3. So I'm not exactly sure why that rendered that in that situation. I wouldn't know, but we're expected to know how to facilitate a hospital survey. In terms of the second one, I know there are different certifications and magnet is one, there and accreditations. Why we don't all speak the same language in terms of, are you talking about like Joint Commission and magnet and all the different?
Internationally, we're expected to go with LEEDs, with ISOs for labs.
Correct.
With, magnet, with JCI. It's just in addition to the local regulators. So
there is a concerted effort for us to all speak the same language. We're not there yet. I can say that there are partnerships. We do work with ISO. So we do work, I know there are domestic partnerships, there are international partnerships. So there are some that speak the same language, but there's a lot of work to do. And it does complicate matters when there are several languages. Yes. I don't have an answer as to when it will be easier down the line, but we know that we do understand that there are complications. But the reason why, for example, our accreditation and our certification, the reason why we are trying to eliminate some of the duplication is because we recognize how difficult it is, how difficult duplication is, even within our organization. When we come to accredit an organization, and then we come 6 months later to certify an organization, and we see that the certification requirements are the same as some of the accreditation requirements, and how an organization must feel that they were just accredited and yet they're trying to meet the same requirements that were in the accreditation manual, and now they're trying to meet them for the certification manual, and how frustrating it is. That's why we were trying to eliminate that. So within our organization, we understood that. So I can understand the frustration with external organizations. So we're making that conscious effort to eliminate that. I can't speak to the external organization. I get it though.
Antigone, thank you so much. Very nice presentation. Joint Commission with the question. Very nice. Okay. All right. Our next speaker is Ms. Lisa Ritu. Lisa, come on up here. Thank you very much. And Lisa is going to be talking to deliver a speech on public community health medication assisted treatment services for those who suffer from addiction and how medically assisted treatment services help communities.
Folks, it's an honor to be here.
And you need a microphone.
Yeah, I can talk a little louder. This one?
Yeah.
It's an honor to be here and be able to present in front of an international community. Oops. So my question is to you, just raise your hand. When you were 5 years old, did you ever think about becoming an addict? That's what I want to be when I grow up. Can everybody hear me now?
Yeah.
Okay. Absolutely nobody. So addiction can affect anybody and everybody at any time. And I've worked with folks that were from 17 years old up to 86. It touches every demographic, every race, religion, culture, everywhere. The point that I want to make is that I'm not a nurse either. I'm not a nurse. I'm a former corrections officer.
Yeah.
I worked at 2 maximum security prisons in the state of Wisconsin. I saw their programs and they were horrible. They disrespected the person. They swore at the folks that were sitting there trying to get treatment. These folks were serious. I was appalled. When I was working on my bachelor's program is when I started a program getting into AODA counseling, because I thought I could change the demographic of this. This is horrible. I take my job very seriously when I was in corrections. Correctional officer is supposed to correct bad behaviors. And what I had was bad behaviors being inflicted upon those that were incarcerated, re-traumatizing people that already came in there. About 40% or more were in there for addiction issues that were related to their crimes. So I got involved in this because of that, and I do have a son that has an addiction. So as a mom, I think this was very passionate of mine regarding how do I address this in a better way. And so I got involved in the program. I got my associate degree in addiction counseling while I was getting my bachelor's degree. It was kind of funny, plus working a 3rd shift job in CNC, welding, anything I could do while I was trying to get through school, and I was working full-time as a corrections officer. So I don't even ask me how I got through it. On top of an internship, 20 hours a week. I think I got a lot more done then than I do now. And it wasn't too far away. So I just brought up some paperwork just to familiarize people with what my, here, this is a clicker. Okay. Clicker. So I was chosen one of the minority fellowship through NADAC. There were 64 folks that were chosen across the nation. I got one of those minority fellowships. So I was really, really appreciative. This is my 3rd conference this year, which is great. So I get exposure to a lot of folks and really pushing the message. So the opioid crisis. So what I wanted to go through was what I wanted to present from this program. Actually, this presentation was to identify the benefits of having medicated assisted treatment, which is what I do right now. I work in medicated assisted treatment. I worked in residential. I've worked in an ATR, which is an alternative to revocation. I've also worked in another clinic. I came upon Acadia a month before COVID hit. Identifying oversight by state and federal entities for MAT treatment. So we are run by state and federal authorities. At any time, the DEA or anybody can walk through our clinic. We have to have the utmost professionalism, certifications, records, everything has to be up to date. Identify barriers which prevents patients from seeking treatment. Identify the safety of the prescription monitoring programs and ongoing wraparound patient care, and identifying as a community how we can advocate in a respectful and dignified manner in patient care. This is the reason why I came to address the nurses, because God bless you, you are the front lines of folks coming into emergency care. So these are the trends per 100,000. This was 2022 statistics. And as you can see, all drugs were trending up And it's not getting any better. Now we have fentanyl in everything, every street drug that even our marijuana users, they're getting it off the streets, there's fentanyl in it. We're having more overdose deaths now than ever before. And here are all the age groups that it's affecting. So the biggest age group, male and female, 25 to 34, 33 to 44. Pretty sad. So medicated assisted treatment services. So I was going through trying to find what states had medicated assisted treatment. And here are overdose deaths per 100,000 residents. So as you can see, there's some states that are a lot higher than other states. I'm in Wisconsin. So I broke all this down and I put this together so then everybody could see. So here is every single state and how many per 100,000 people have been overdosed. So we have Wyoming here. There's no MAC clinics in Wyoming. Those people don't have a chance. We got South Dakota, Hawaii, Alaska. So this is about diversity, equity, and inclusion, the access to getting treatment. Here we have California. Over 100 clinics are here. We still have overdose deaths, but at least we have a lot more access. Oops. Can you still hear me?
No.
Yeah. So I just wanted to give you some statistics. Preliminary reports indicate the number of drug overdose deaths in America increased 29.6% in 2020. That was the year of COVID. 996,779 drug overdose deaths were reported from March 2020 to March 2021. This was a highlight of COVID. In January 2021, drug overdose deaths exceeded homicides by 306%. So statistics on gender and race, according to the National Center for Drug Abuse Statistics. So among women, American Indian, Alaska Native are the most likely to die from overdoses. Just as an example, I'm just honing in on one demographic here. For American Indians, 4% have illicit drug use. 10% Native Americans have a substance use disorder and 25% report binge drinking. This was the American Association studies. Among men, Black and African Americans are most likely to die from an overdose. Among both genders, Asian and Pacific Islanders are the least likely to die due to overdose. Men aged 25 to 34 years old are most likely among all age groups to die from overdose deaths. So I want to get to the reasons why we want to have more access to MAC clinics. And I think it won't go back. All right. Well, the benefits of having MAT services for those that suffer from addiction, especially during this time of the opioid crisis, continues to ravage communities across the United States. According to SAMHSA 2022, there are the benefits from suffering from addiction to opioids or opiates: improved patient survival rate, retention in treatment, affordable treatment for opioid addiction, less painful withdrawal from fewer drug cravings, better family stability, ability to work, attend school and daily activities, decreased illicit opiate use and reduction in criminality, which is huge. That's huge for communities. Reduce risk of overdose and disease transmission, and healthier pregnancies. Probably in the last year, we've had 10 babies born to women that had methadone, and the babies are very healthy. And they had the right doctors that knew exactly about the medication that they were taking. So I'm a licensed addiction counselor in the state of Wisconsin. I'm in my graduate studies program for clinical mental health, which is a co-occurring disorder, especially with this population. Not all, but quite a few. I work with patients using motivational interviewing techniques, cognitive behavioral therapy, dialectical behavioral therapies, and I educate patients and promote growth. I work with the whole person, mind, body, spirit. That's what I work with. You know, choosing a better diet, wellness, sleep hygiene, you name it, I go over it. Counselors work with patients with psychoeducation. I do a lot of psychoeducation with patients. We run groups every single day. I run 3 groups a week. One of those is for folks that work during the week. So I come in on Saturday and I'll run a group for them. I also bring snacks, so that helps. So if they're hungry. So I'm bringing up some of the medications that we use in the clinic. Methadone is a golden star for medications. It's a blocker. It blocks the receptor. So if somebody does use, they're not going to get high from it. So it's a deterrent. So they're not spending their money anymore. They're like, oh, I can't get high anymore. Let's work on that. Buprenorphine or naloxone, that is a combination that creates Suboxone. So those are film that goes underneath the tongue, and then they have to sit there for 15 minutes before they leave the clinic, as long as it's absorbed. Vivitrol, that's a once a month shot that works also for illicit use for opiates and alcohol. It's very beneficial. It's a once a month shot. Buprenorphine extended release injection, that's Sublocade. That is similar to Suboxone, and it's a once a month shot. So I went over the benefits. My slides were a little screwed up, sorry. So we are state and federally oversight for patients receiving MAT treatment take-home doses. So our patients do work on the first 90 days that they're there. They don't get any take-homes unless they're fulfilling all these. It's very strict. So when somebody comes to the emergency room, you know darn well, if they're coming from a MAT clinic, they have to follow this regulations. These are 8-point criteria to earning a phase. A phase is 1 dose that they get a take home, which is on a Sunday. So if they have take home doses, they can earn 1 day that they can take that home. It's a part of building up that responsibility and them showing us that they can handle 1 dose so it doesn't get distributed on the street. So absence of drugs, any kind of use, we go through all their drug screens with them. Anytime that we get one, we have randomized drug screens. We also have observed drug screens too. Regular clinic attendance, they have to come to counseling and their doctor appointments. Absence of serious behavioral problems. I'm sorry, can everybody still hear me? Absence of any serious behavioral problems at the clinic. Mind you, we do have fights on occasion. Sometimes we have to break up that fight. It's because there's a lot of things going on when that person started using. That's when they emotionally stopped growing, mentally, emotionally. So we do have 40 and 50-year-olds that'll start a fight and if somebody skips somebody in line. Okay, let's deal with that. And of course, I'm from corrections. I know how to, scoot them in. Let's get you dosed right now. Then you can go home. That'll be okay. Breathe. We got to breathe. Absence of known drug activity, drug dealing, theft, multiple misdemeanors. We have to look up their records. If they are somebody that has been in and out of jail or prison for dealing, They have to come to the clinic. They are exempt. They don't get a take home until all their cases are cleared. Stability of patient's home environment and social relationships, length of time and comprehensive maintenance treatment, assurance that take-home medication can be safely stored within a patient's home environment, has to be locked up. They have a lockbox they have to buy themselves, has to be locked. Whether the rehabilitation of benefit for the patient derived from decreasing the frequency of the clinic attendance outweighs potential diversion. So we don't want anyone diverting anything. We are very strict on that. We have a lot of folks that are in this population that have a lot of health issues, and some can't get to the clinic every day, but they earn their way. So then they can have more take homes. So barriers to treatment services, financials and costs. You know, we have Medicaid, Medicare coverage. So a lot of the folks that do come to the clinic, they can apply for that insurance and they get it. We do have full working people that come in. They have really good insurance through their companies. We have people coming in suit and ties, and they're in management or supervisory positions, or they're running, you know, machinery, and they're doing it in a safe way instead of being under the influence. Stigma, that's the big thing. We got a lot of stigma about these clinics. We actually had an open house before I came here, probably a month ago. We invited everyone to come in, all the business owners, everyone in the area. Guess who showed up?
Don't say no one.
No one.
Oh.
So that's how bad the stigma is. It's and the folks that do get to the emergency room for something, you know, they're carrying shame, guilt, admitting that there's a problem. Their friends and family don't want them coming to a MAC clinic because of the stigma. I have patients that won't even tell us who their doctors are that are prescribing them other medications because they refuse. I have to get an ROI. If they're not willing to sign it, we just have to keep a super close eye on them. Co-occurring treatment availability. There's a lot of folks that have to be referred for mental health issues and be assessed. Some of them have not been assessed. A lot of the folks that I see have a lot of depression and anxiety, a lot of bipolar. So I'm working with mental health anyway. So it just made sense for me to go to college and get that degree. Transportation issues. You know, we have a lot of folks that are picked up at their home, brought to the clinic in a van with everybody else, and then brought back home, just so they can get their medication. If they miss a day, they are going to get sick, or they're probably going to use. So it's really important for them to get there. And we also have the prescription monitoring program. That is so important because that is how we can see what they're being prescribed. If they're being prescribed any kind of opiates, we have to have an intervention. We have to have an ROI to contact that doctor because they are in a methadone program. Ironically, our clinic doctors who prescribe methadone or Suboxone, they're not on here. So if they're going to a mental health provider and they get in the psychotropic medications, they don't know that they can't see that they're coming to our clinic. So that's something that has to be changed. And I'm not afraid to go and talk to my lawmakers about it either. This is for the state of Wisconsin. So this is about wraparound services. We want people to be safe. We don't want to have people have a syndrome that they may go through because of the interaction of medications. And we're going to prevent deaths from happening just because we know exactly what's going on. Only healthcare providers have access to PDMP. That would be a dentist, that would be the pharmacist, that would be the medical doctors that are having access to this, just to make sure they're not giving the wrong medications to someone that's already on a methadone or Suboxone or Vivitrol. The criminal justice system, recidivism and addiction treatment. So there's a higher mortality rate among those who are released after serving time in prison or jail who have been found to have a higher risk of overdose rates. So as soon as folks that are released back out on the jail, within 12 weeks, are going to have an overdose and die. So I think that we've been doing this all wrong. So even folks that go into prison or they have to do jail time and they're in a MAT clinic, they should not be prevented from getting their dose. It should be administered in there, just like somebody has diabetes, somebody's got high blood pressure. This is about equity. This is about not you giving that person that medication because they need it. Otherwise, they're going to get sick. They're going to go through withdrawals, and it's horrible, absolutely horrible. I don't find anything funny about watching someone go through withdrawals. This could actually send someone in a break, a mental health break. And then we're doing a lot of damage to these folks that are in there and having the medication. They need to have that. We don't tell a diabetic, oh, I'm sorry, you don't get your medication. We don't do that. So it's just as important as to make sure that these folks get their medication. Also, they are just starting to do this, which is introducing these folks when they do come out of prison, they're ready to get released, as they get them the Vivitrol shot. And the state pays for it, which is great because it at least gives them a jump on if they want to go through treatment or not. And then the state will also pay for a whole year of these injections. So it gives them a good chance, not only with the medication, but also the counseling when they come into the clinic. And that's where I come in. So it's a dual course, medication and counseling services. It's all included in what they come to get. So advocating for quality patient care. So this is really important. What can you do to advocate for better patient care for those suffering from addiction? So what we need to do is stop using stigmatizing language instead of saying, oh, you're just an addict. And I'm depending upon my nurses to not say something like that, or look at somebody and say, oh, I'm sorry, you're not getting drugs today. That further stigmatizes somebody. What we can do is really look at what's the problem. Where's the pain coming from if that's what they're in there for? A lot of the folks, they get infections in their arms or legs. They're getting all kinds of stuff because of long-term use. So it's really important to address those. Take additional classes in addiction medications. I think it's so important for our nursing staffs to have more education on the medications. So I'm going to just say this. I had somebody given Suboxone when they were on methadone. What do you think happened? No, they got very sick. They went right into withdrawals. Yeah, so it's really important to know what medications, if they come to the emergency room and said, oh, I missed my dose at the clinic, is there any way that I can get medication? We don't want to give them Suboxone. Make access available for addiction treatment to marginalized communities. As you took a look at going back here. Oops, I don't know if I skipped it or not. Here you go. Marginalized communities. It's so important to have MAT clinics in every state. There's a lot of clinics out there, but they are not specifically designed for methadone. We have doctors that'll prescribe 2 weeks worth, but there's no oversight. So where do you think that Suboxone is going? It's getting distributed on the street and sold. So there is no oversight. So what we do is we oversight everything that goes on. Some folks prefer to come to a MAT clinic because they have oversight. They're going to come there every day. That's their routine. Oops. Address misconceptions of MAT treatment services. So instead of just thinking that it's just a clinic for people that have addiction, come on and take a look. Visit any of your local MAT clinics if you have any. I know there's a lot in California. But just ask them questions, be there, walk around. These clinics have to be clean. I am one of those folks, however clean it is, that's a reflection of how we treat our patients. And I take patient care very, very, I can't even, it just makes me sick to have somebody be treated with disrespect and indignities just because they're coming to the clinic. You know, this is important for them to lead a wonderful life. These folks are raising kids, working full-time, they're functional while we work on the underlying issues. Facilitate area referrals for emergency room patients. So if there are any emergency rooms, or if you work in an emergency room, it's really good to have those referrals on hand. These are places that you can go. I've even had police officers refer folks when they come and they revive them after an overdose, and they've come to the clinic. Thank goodness they did. Contact. Okay. Contact your state representatives. See what we can do better. Remember, addiction is a chronic disease and must be treated like any other disease with dignity and respect. And my last slide is people, even more than things, have to be restored, renewed, revived, reclaimed, and redeemed. Never throw out anyone.
Thank you very much, Lisa, for two. That's very moving. Do we have any questions for Lisa, please? Yes.
Yes. Thank you for what you did, Lisa. I was wondering, do you ever reach out in the advocacy area as far as peer support?
Peer support?
Yes, because that has found to be very successful in having someone being a peer that could go in and advocate, and they pretty much trust other people who feel like they're on the same level as they are. So I'm putting out there to look into peer support. And it was passed in California for the peer specialist.
We're getting there. We're not there yet. California is, I think, on the cusp of everything that's new and can be tried. We haven't gotten there yet. However, I have had to send people to the emergency rooms or to doctors because they couldn't speak for themselves on what was going on with them, unfortunately, and they weren't getting the health care that they needed. So peer support, we do need peer support. I know they're talking about mobile units going out there. So that's in the talks right now. I'd be more than happy to do that. I don't care what hood I'm going to go to. I'm going to do it.
Lisa, I have a question for you. Do you integrate with 12-step programs?
12-step. We don't have 12-step. I mean, we do, but it's more for the AA. We do the NA or HA. We do have those. There's a separate entity with some of those folks. We have fights between the AA groups and the NA or the HA because they are like.
Tell them what AA and NA are.
NA is Narcotics Anonymous. HA is Heroin's Anonymous. So yeah, they kind of have a battle like, yeah, you ain't one of us because we got alcohol. No, you're not one of us. We got heroin, so they go battle.
All right, well, ladies and gentlemen, again, thank you, Lisa.
Thank you.
And now we're going to take a 15-minute break. So if you don't know every single person in this room, it's your homework to do that by the end of this break. All right, we'll see you in 15 minutes sharp. Thanks.
Because I saw you that you are so busy. Because I want from you to learn me how to move the slide, so I can do it tomorrow.
First, let me
Exactly.
let me just download this first. Switch on. You sit down, I'll just assist you.
Okay, sit where, here or there?
You can sit anywhere.
Okay, because of my speech will be after the break. So I need to help you because I saw you are so exhausted. Let me go to my room and bring my charger because my phone only 5.
This is your presentation.
Could I check my presentation file?
Is this the
Yes, yeah, yes.
Let me just rename it so that it will be more clear.
I am post presentation is the invitation time
It's
over
a
50 minutes.
Yeah.
It's a short time, but it's I speak very fast and abstract.
You to be.
But it's, I don't know. My major is computer engineering. This is different.
Okay.
So, quick questions.
Yeah.
This one has got access to internet, right?
This
This
is not live now.
No, because but can I actually, because I have my presentation, which is based on a link in Prezi.
Okay.
So I just need access to internet for my presentation on DNC.
This is internet.
This internet.
Yeah.
Yeah, that's fine. Yeah, I just wanted to make sure.
If you close this, does it shut off or does it continue to project?
It will.
It will continue to project.
Yeah.
If you post it like this.
I think so.
Close it, it still should project, I guess.
So no worries, you can just log it like this. So that's not a problem. It won't show you.
Okay.
Yeah. Or else because from morning I'm removing and inserting, so it is a problem. It's becoming a problem. I'm facing some error. That's why.
Okay.
So that's not a problem. We'll just
Put the mic up here and.
yeah. Tomorrow we'll adjust.
Okay, perfect. Thank you.
Forget it's my giveaway.
Now time out. You gave me at the last.
Huh?
You gave me at the last.
No, I have something. People just don't. This time. And then my website is in the back. It's not fully ready yet, but you can certainly browse.
If you can, we will allow the team to update your website information on our conference because you'll get more attendees from there.
Okay.
I mean more visitors. Yeah. So we'll do it for 10 to 15 days.
Okay.
Yeah. Because your website was not ready. So we'll do it now.
Thank you.
I'm keeping all the presentations here and I am downloading your thing is your video is hidden. That's why. How can I download?
I've sent it via WhatsApp for you.
So how
The
can I
video.
download this?
Can you use WhatsApp web and you can download it to your WhatsApp to the laptop.
It's downloading.
Learn about NCDs with Johnny Sophia. This video aims to raise awareness on account.
Yes.
So fruit smell. I'll also have
So I need it from you to learn me how to.
yeah, because my back pain it's going like hell.
That's why I've asked you many times. You need any help, so I would have to be active.
Yeah, because people are coming and searching for chairs and nobody is there to assist. That's why.
That's
be our speaker, but our chairperson tomorrow. And Amal is going to be talking about the improvement in the address of chronic non-communicable diseases in Palestine through research, application of innovative protocols, capacity building, and community prevention. Did I get that right?
Yes.
I did. Surprising. Okay.
Thank you
All
very
right.
much.
Thank you very much. Are you good with the microphone? We want people with microphones.
Yeah.
I'm going
Microphone.
to suggest that one.
All of them are working.
Okay. All right. Then.
Okay, great.
Just use it though.
Okay,
All right,
thank
good.
you very much. Thank you, Prof. Frank, for this amazing introductory. Thanks for having me for today. Let's quickly introduce myself. I am Amal Ibrahim from Jordan. I am a certified professional in healthcare quality from National Association of Healthcare Quality, and certified from the American University in Washington with a health project management certificate. Currently, I'm working as a project coordinator and a public relation officer in HWC organization in Palestine and the Middle East organizing secretary in UCG conferences. Today, my presentation will be about improvement in the address of chronic non-communicable diseases in Jordan and Palestine through research, the application of innovative protocols, capacity building, and community prevention projects. Our project is funded with the University of Jaén, a Spanish university. Our project is still running and will end by the end of next March. Okay. The aim of our project is to adopt intervention protocols on chronic non-communicable diseases to the current global pandemic situation caused by COVID-19 and the training of health personnel to contribute to improving healthcare for people with NCD disease. Also reduce its community impact by raising public awareness and making the protocols available to the counterpart health centers more effective. The main aim of the project is the gender approach will be mainstreamed with a dual approach with a specific protocol and a total revision of the protocols. We have general goals and specific goals. The general one is to contribute the improvement of healthcare for people with NCDs under pandemic conditions in Palestine population of the West Bank. And the specific goal is to strengthen capacities to respond to NCDs through alternative and innovative solutions adapted to the current epidemiological, social, cultural, and political context in the West Bank, Palestine. We have 6 project strategies. First, the observatory. Then the protocols, health trainings, public awareness, and COVID-19 prevention workshop prevention protocols. Let's start with the first outcome. It's the observatory. 3 meetings were held with the Palestinian Ministry of Health and the NGOs to provide the protocols for the NCDs and for the GPVs. One of the important things that we have, this is NCD's observatory link in our website. We have provided the NCD statistics in Palestine and in Arabic countries. The comparison will be regarding the illnesses, sex, age, and years. Here we can see that charts that illustrating the data. Also, we have provided a small test to test your variability to disease. Actually, this is a pre-diabetes test to know the knowledge of the people about their information about NCDs, and actually for the diabetes regarding the health awareness, we have brochures and the reports of what we have done. Okay, for the observatory, first we have done the strategic document for our work. A number of cross-sectoral meetings were held in creation to the observatory, and number of protocols analyzed and observatory web plan regarding the number of protocols. We are working to have 8 protocols by the end of this project. The second strategy is improved professional skills of healthcare workers in relation to protocols and procedures for NCDs. Okay, for the capacity building, the training, theoretical and in-person training program aims to improve the healthcare workers' professional skills in relation to NCDs protocols and the procedures, also to improve technical assistance for the local staff, the HWC organization, and the workers about all of techniques or all of information related to NCDs protocols and the procedures. Okay, the first process was to identify a training need. We have made a training need assessment to know the healthcare workers' needs and what kind of capacity building training and topics we have to give for them, drawing an annual training plan and development and implement of the digital distance training platform for the health training, and carry out workshop and theoretical practical training. Here is the theoretical, online, and personal training. We have done all of the online training session via Zoom with the lecturer from the University of Caen and the lecturer from Palestine. A lot of important topics we have discussed, for example, for the respiratory and lymphoma, physiotherapy, mobile devices for care of chronic patients in Palestinian centers and Spanish centers, and make a comparison between the experience in the two countries, basic and advanced life support, and also emotional intelligence. Here is some pictures for the online training. During the online training, we made 3 personal sessions. One of them is emotional intelligence in the second photos. And the first 2 photos was the introductory online training. Here is an example for the basic and advanced life support sessions. For the first third strategy, comprehensive approach using awareness raising campaign. As we all know, a lot of people are facing a health problem they are unaware of, and currently with the treatment and medicine available as a result of this, many people can receive treatment or can't receive the treatment in the same way. As a result of this, we conduct 28 health awareness campaign in the Palestinian territories to improve the Palestinian community knowledge about NCDs and reduce the impact of NCDs and reduce the stigma, because we have a cultural community that they are denying or they are shying they have NCDs. The targeted population was women, men, children, and disability patients and marginalized people. Okay, in this situation, we have designed and implement 28 population campaign around the Palestinian regions, also implement from 25 to 28 raising awareness campaign. Here's some example of our banner and our brochures. And in this strategy, we have made a video. The video script, the main character in this video was a Palestinian granny called Safiya, wearing the Palestinian traditional thobe and the white scarf as a symbol for Palestine. Let's start the video. We have to close this.
NCDs with Granny Safiya. Learn about NCDs with Granny Safiya. Learn. Learn about NCDs with Granny Safiya.
Maybe we have to close this one.
Learn about NCDs with Granny Safiya. This video aims to raise awareness of chronic non-communicable diseases.
This one. I will continue then. We will share the video. Okay. Okay, sorry for that. We will move it for the end. Okay, regarding the workshop, we have made a 28 health awareness campaign, and because we are believing with equity and equality, a lot of our healthcare workers, male and females, are sharing the educating and awareness sessions for the Palestinian population. Some of the sessions was for the nursing fourth year students. Here is the health educator, the woman health doctor, and the nutritionist is educating people aware about diabetes and physical activities. Here is our health educator is educating the university students and at Al-Najah National University in Palestine. Here is an open day was done at Ikram Association for the care of the elderly trip on Jericho City. Here is a session was at Al-Ikram and Al-Rayyan Cultural Center in Palestine for the children. And here is our medical director educating the people about breast cancer. Okay, the fourth strategy is mainstream gender approach to address gender inequality and violence. Actually, last month we have received the first draft from the University of Hayan about the GPV, and they wrote it with 3 sections. The first sections they explained and defined the emotional, sexual, and economical types of violence. Then in the second section, they explain about the productive, mental, and sexual circumstances. And the third part, and the main important part, they explain how to protect the patient and how to diagnose the GBV patient, how to educate them, to treat them, and how to follow with them, and what will be the next step for their treatments. Here is previously the timeline for our project. We have started on October 2021. A lot of meetings were held to create the observatory, then the strategic document to constitute the observatory. After that, training needs assessments and design the brochures, workshops, calendars, start raising awareness, observatory web link, training platforms, training program for the healthcare professionals, protocols, and in September, we already ended the raising awareness campaigns. And for the roadmap, first, we have started with the strategic document for the culture of the observatory, meeting for creation, workshop, and the observatory web link. Okay, we have made a little bit SWOT analysis for our project. For the strengthening point, we have seen that a primary focus on quality improvement, gender approach, and addressing chronic non-communicable diseases. Internal teams dedicated to research and analytical, highly educated local staff, high quality management personnel, and funding and resources to support the program. Regarding the weakness, healthcare facilities and technology, lack of NCD's updated data, because currently we have the data only for 2020, websites and equipment, lack of doctors' knowledge about NCDs and health protocols. For the opportunities, collaborate with different healthcare organizations, authorities, and the media to facilitate networking, develop and analyze healthcare protocols and training awareness to drive more community outreach and engagement, and create space for observatory and training platform. For the threatened economic or political insecurity. Before, thank you, and the questions, let's try to share the video. Here.
From Jamal.
Learn about NCDs with Granny Safiya.
Okay, maybe you have some problem with the video. Is there any question?
Throughout your presentation, you talked about campaigns. What made you start these campaigns, and how do you think on a continuum or a timeline that they're going to be effective? And then how do you mobilize the people to join you based on your campaigns?
Okay, that's a very good question. First, we do a need assessment for the population to know what topic they are aware and what topic they have to know about NCD. And we are facing in Palestine a cultural stigma about NCD, and also we do a separate training for women and male. They don't accept the mess and doing the health awareness campaign regarding the results of the training and their need. We have run these capacity building, and also it's still running. We have done 28 training awareness or health awareness for the people. This was done by the operational calendar of the project, but it's still running. Still running till the end of the project, till next March. So in order to educate more of the Palestinian community about NCD, to remove that stigma point of view that they are shying or denying that they are facing or having this kind of disease.
Wow. What's the main disease in Palestine?
Actually, in Palestine, the main disease is diabetes and hypertension.
Oh my goodness, because all that rich food that you guys are cooking?
Actually, they cook a lot of with the Irans and oil. That's one.
How do you get them to stop? How do you get them to stop?
Actually, we are educating, and we are still working with them to stop it.
That's hard to do. Thank you so much, Paul. Yeah.
Thank you very much for this next question. Pay more attention to them.
From the project, what we understand that the project it was closed in the March 2023. What the mechanism to be sustained, or to be sure that after the project, the awareness is built on the players, or what the second steps you have in the
Okay, thank you for your great questions. The project actually will finish on March 31, but on January 2023, we will have a meeting with the University of Hayyan team. They will come to Palestine, and we will work to continue our training and continue the health capacity building awareness after finishing the project, in order to continue another project, inshallah, in next year. Okay. Yes.
That was a good presentation.
Yeah, okay.
Thank you for that. I was just wondering, the people that are being taught now, the people that are there and learning these different things, are they going to play a part afterwards in teaching others? Is it going to be like so what we do in my trust is we teach resuscitation to people that don't teach resuscitation in order to get them to teach others, like peer support or whatnot, and they teach resuscitation, so they're called cascaders. So we get them, we teach them, they do their thing, and then after that, they go and teach people in their team and people that know them. It just makes it more connecting, to that audience and those people.
Yes, great and interesting questions. Yes, during our health awareness campaigns, we educate the Palestinian community about NCDs to let them educate their relatives and their neighbors, their community, how to improve their knowledge about NCDs in order to improve the effects and impact of NCDs for the individual. Is there another question?
I'm safe now this time. I can actually say thank you. Yeah? Okay, all right. Jamal, thank you very much. All right, for the next 15 minutes, we will see a presentation of the day, our first poster presentation from the good Professor Soo Chung Ju from South Korea. So as you can see, people have come a long way to get here.
Yes, they are.
I should pay more attention.
So left and right. Yes,
here.
start with here.
This is button.
Point the button. Here is the lighter. Here. Okay. And here for the next slide. Yes.
I'm looking, yeah.
Yes. Okay.
It's time for 5 o'clock p.m. Good evening. I came from Korea. My major is computer engineering. Have you graduated from the engineering college?
Yeah.
I am PhD and I am technician of computer engineering. So for 35 years ago, I graduated from computer engineering. Now, today, I'm here. So I'm unfamiliar with this atmosphere. But I will understand. I try. Today, I'd like the presentation of this kind of topics in international conference or computer engineering, information technology, like this. But this place first presentation. It's an honor to be here, and then I'm happy to presentation my paper. So my topic is design and implementation of healthcare information platform. This I'll introduce this HIP for supporting the automatic authentication service. I know that you have smartphones and you can use any information by your smartphones, but you cannot access. You need authentication service, and then is you always access the medical information. You write the PI password, your ID, and then the others. I think that the way I focus on, we don't need any password, ID, and the other information. This information is used, is automatically input from the system. All is supported using system. This using system is a healthcare information platform. My index is, sorry, I allocated time is just 15. I'm speaker a little fast, sorry. That is index is 4. That is for second, third is very important. I will focusly explain these topics. The introduction is the healthcare information platforms require medical information service. It's managing patient over medical information. And then this from personal information is divided two. It use medical information and the other information, biometric information obtained from IoT medical device. This information is real time. That is many in real time is stored. The system is very easy to store. If the volume over big, we call this type of data is a big data. Yeah, that is next to the medical information is very important. Anybody that cannot use this information, cannot access this medical information. Medical information is protected. It's from everybody. Then next for like this, the information is protected. That is for this reason, healthcare information we
there is some system is added to. This one is authentication server. The other is edging computing system. Edging computing system is the adaptive system. For example, is automatic car is support too. The automatic car has 2, 3 over camera and LiDAR. And that information is real time and immediately processed. That is get out is made a good answer. This time is very fast, very short. We as violate this time, they occurred accident. If somebody's died, it's very dangerous and may is serious. For solving like all of these, we designed and implementation systems. This here is many research here. This our research is different from other research. There is for making some decisions. We usually use the rule-based authorization, but at the end of the year, it's more here the patient various situation. According to the patient situation, that is the medical staff in charge of patients can access the patient's information. Yeah, this access time is very short, but it's very important. There is the access time is slow. Then this the in emergency situation cannot access to patient. Very important, I think. That is we research is for decision or first a rule-based method and the patient use situation that information we use. That the other is access right. There is knowledge and doctor in charge cannot access information is different. Normal station is access it's 3 over levels. Low level can access at any time. But it's that the patient is in emergency situation. The nurse and or doctor in charge can access a high level for cure of the treat of patients. But it's do we have this that our platform is originality of automatic authentication. That is why information platform use of patient medical information determine whether the patient's healthcare situation is normal or emergency state. We have to decide. It's fast in the system. The provide service usual authentication and mobile owned mobile terminal authentication. This engine, the authentication service that is you only know your password and ID is okay, but it is different. You have a smartphone, and the smartphone is also authenticated. But it's I'm doctor authentication, usual authentication, and a doctor's smartphone is also authenticated. That system is 4 parts. The platform is consists of 4 parts. It's a sensor. This part is obtained from the biometric information. It's real time from obtained from patient. Next is this is edging computing. Pro is check in patient emergency. It's normal. It's no nothing. It's about this patient is emergency and something is have to proceed. That is medical information management. This part is the exist medical system is the same. We just added medical management systems added to edge computing. And that here, this third part is information management part. This is a medical server, medical information server means same. This is authentic server. We added two authentication server and edge computing system to our proposed platforms like this. That is why we use edge computing system. There's an edge computing system support to collect of patient biometric data real time. From here, second is determine the emergency situation of patients. This using biometric data collected people, IoT medical device, and the patient's medical information. But this third, the medical platform is very here system is overhead is very high, and real time data is obtained in time is very high required. That is, we are just sharing for this tool. We use the edge computing and the medical server. This edge computing system is added to my healthcare information platform. That is here reduces the overhead over the medical server. That is sharing to by adding edge computing. That is the overhead is sharing. This here like this. This part is we are separated. One part is allocated to edge computing. The other is the medical information server. Part is, and then we need to some program is implemented like this. Two kind of program here. This part. It is in its existing platform is has two processing module are here. We are separate. That is two program is interface with is for getting the result. But we have to two modules. Have to implement it, two modules, and then here send a message over to this send existing platforms emergency send emergency message to the charge medical staff in charge. That is this time is one time here. The edge computing system send emergency information to server, and the medical information server send to the medical staff. Here is we say four phase explained here. So one, two, or three, four part we I explain. This part is first the sensor part is collect data. Like this data, biometric data is a BP, and pulse, SpO2, temperature, ECG. That is we for implemented the system we use MIT BIT data. This big data is obtained from MIT University. That is the emergency decision is tiny. It's okay.
You have
So I'm next. Yeah, this we AI the for the optimal result. That we use AI-ID CNN AI algorithm we used. Next, the in patient emergency. The patient is in emergency. That is a step in charge of patient. Step is a doctor or nurse. The other is a medical practitioner is including. Authentication over here, we use two kinds of medical authentication. This first is the user. User means is medical staff, and the medical staff own the mobile terminal. There's a user authentication we use like this. That is, you can be familiar with the ID and password. And the ID and password is enter the system. Can your password and your ID is saved. Then you real catch. That the other is the authentication character. Is and then the user owned mobile terminal any authentication. This is your smartphone is authenticated. It like this. The checking is user rule. User rules means I am doctor, I am nurse, I am a practitioner, like this. And his work time. And then the medical steps work time in medical time. The medical steps can access medical information. This is a work location. It's about all the in any place, any times can access information. Not is the hospital is a second floor only. You can access the medical information. It's a limit. It's a limited. This is very important. But it's he's out of a hospital cannot access. If that the patient is a very emergency, that case then out of hospital is stay, the medical system can access the medical information. It's some we need some politics for accessing. Here is a part is the process. The emergency message is sent. Then authentication, user own the mobile terminal authentication is a procedure like this. Here, that the patient is in emergency situation. That in case there is a phone, is a message sent and receive that to a medical information manager part. And then next, this authentication is automatically. Now this in details, we this part is medical information is stored to database systems, and then the medical information is divided to three parts. One part is level 1, 2, 3. Thus, in normal stage, nurse and doctor can access level 1 or level 1, 2. And the patient in emergency status, that is nurse is level 1, 2, and doctor is 1, 2, 3. Let's show you this like this. This part is a normal state. Status can access that like this, and the emergency is this. Is here urgent or medical staff like this. It's the same. We are here. Here is evaluation. First is we use a manual and the automatic authentication. How to compare with two kind of method. Our suggested method is good. Like this, some people. Next is we evaluation analysis of platform. That is, we use the edge computing without edge computing. That in case is we spend a lot of money. One system is required, but its performance is good. Yeah. I am summary is my conclusion that my platform is adapting to automatic authentication and etching computing systems show improve two kinds of evaluation analysis. This is my we are safety protected patient sensitive medical information or normal situation through patient situation oriented authentication. That is this our system is good. This system is registered is a Korean patent. I try to it's a technology, it's a transportation and transport to industry. And then my university is very famous in Korea. There's a medical is a hospital and Oriental medical hospitals. And yes, we have 10 hospitals. And then my system is in field test is our university hospitals. And then the system is good. I'll be later, I'm a billionaire.
All right, thank you very much, Professor. And now our next poster presentation is by Dr. Kadashia.
I think
Dr. Kadishia.
and access at the questions I email. Okay.
If you run over,
Here.
we can't have time for questions.
My email here.
You can talk to him outside.
Thank you so much.
Thank you for coming. We're an hour behind schedule, Professor. All right, and this is Dr. Khadija.
Hi, how are you?
From UAE. Presentation on
slideshow because it's a PDF.
Innovation in healthcare management.
Okay.
And then after that, we talk about Barbara Delegates, so have your presentation ready. And then finally, my partner in crime is.
Because it's been years before I do many times. Okay, you can minimize, that's it. No, it's not coming. Can we announce Miss Barbara? Then meanwhile, I'll just share the date. You can't print it even though you have a printed it. We can print it for all. Otherwise, I can't supply like. No, I'll just sort it out. Okay. Meanwhile, you can. Yeah.
That was a fantastic presentation. I'm sure you all felt it moved much too quickly. So let's move on to Barbara DeGroot, please. Barbara, are you ready? Okay. Jump right in. Barbara's going to be talking about the presentation on improving fall risk to reduce falls in assisted living communities. So maybe I shouldn't have said jump on it.
Yeah, be a better choice words. Sorry, Michael. I'm afraid if I stand behind the podium, nobody will see me. These are my crutches, just so you know. So I am a doctoral student, and I had to come up with a project for my doctoral degree. And having worked as a nurse for 30-some years and as a regional nurse for a large assisted living community, I look back on falls. And initially I thought, well, gosh, falls have been done to death, really, in hospitals and skilled nursing facilities. But there's nothing out there about falls in assisted living communities, very little information. Out of 923 articles I retrieved originally, only 4, count them on one hand, 4 articles addressed assisted livings specifically. So falls are a safety issue no matter what the healthcare setting, hospital, skilled nursing facility, physician's office. It doesn't matter. Excuse me. They are also one measure of the quality of care that we deliver. And they're the #1 leading cause of accidental death in the Mexicans age 65 and older. That was astonishing to me. So falls and fall reduction strategies, as I said, have been, studied extensively, but again, very little about assisted living communities. I'm going to wander around because I like to walk. So the significance of all of this is that falls, #1, they increase healthcare costs. I'll be sharing some figures with you here in a little bit. They also contribute to emergency room and hospital overcrowding, especially with the COVID-19 pandemic. People are being taken from their homes, and these are very frail, fragile people. They're being put in beds in hallways without hall lights and having to use a restroom. And who must think that these people are going to fall? Amazes me. Increase the risk of future falls because people develop a fear of falling. They stop getting up and moving. Their muscular strength goes down. Their joint mobility diminishes. So the risk of falls increases there. And falls, this one was also kind of interesting for me. They're often underreported because people either don't know how to define a fall because there's no accepted definition of a fall, or they don't know how to use the reporting tools. How do I use this incident report? What do I put in this box here? Do I check this? Maybe, maybe not. So the end is in adults age 65 and older, does using the Morse fall scale, the medication risk score, and the universal or individualized fall reduction strategies, compared to not using the Morse fall scales or any strategies, reduce falls in assisted living residents age 65 and older over a 3-month period. Initially, my investigation period was going to be 6 months. However, there were some problems with contracts with the university and the community. So it's been truncated. The goals or the purpose are to reduce falls and repeat falls by 20% in the time period. Also to improve staff fall knowledge using the AHRQ fall knowledge assessment and trainings. And then also to determine if the resident is using their personal alert system to call for assistance before they fall, because that's a big issue too. The search for evidence, as I said, I gathered 900 and some odd articles originally. I whittled it down to 36 eventually. And I identified 4 themes in the literature. One was using validated tools to assess fall risk. The second one was identifying the risk factors. Excuse me for walking in front of that. Consequences of falls, we kind of touched on very lightly. Cost, of course, fear of falling. And then fall reduction strategies. So there's a lot of information out there on that. My change initiative, I think I have enough time to go over it real quickly. I like simplicity. Orlando's theory is very simple. I know this is difficult to read, but you can see that the person is in the center of the circle. The person interacts with the nurse on each and every step of that. So it's a collaboration between the nurse and the patient. Change process, I like Rogers' diffusion of innovations theory, not quite so simple. But it does help staff understand the reasons behind the change. It gives them an opportunity to trial the change, to look at it, to feel it, to make sure it fits with their current practices. And then also it allows them to identify that changing their practices is not a bad thing. So it gives them that opportunity. And then my evidence-based framework, I like the Perry's framework, which is promoting action on research implementation in health services. Again, it's very simple. It's evidence, excuse me, the cross-section of evidence, facilitation, and the context. So the evidence would be evidence-based practice, current practices. The facilitation would be the management, the leadership in the facility. Sorry, I get a little dry and get a little tense. And then the context would be facilitation itself. Methods-wise, IRB, the University of Missouri, Kansas City approved the research as exempt research. So the risk to residents is no more than their everyday activities. The risk of falling is actually reduced because the staff are implementing these fall risk assessments and fall reduction strategies. The design of the study is a prospective quasi-experimental repeated measures design, because I get fall risk scores initially and at the end of the program. If a resident falls, gets hospitalized, has a change in medications, then there's also another assessment at that time. It uses, as I said, the Morse Fall scale and the medication risk score to identify participants who are at increased risk of falling. And then implementing universal or individualized fall reduction strategies based on the overall score that they attain. So there's a cutoff point that was established of 45 on the Morse Fall scale and 6 on the medication risk score. If they score higher than that on either one of those measures, then they are considered a high risk and they get individualized fall reduction strategies. Again, it's adults age 65 and older who meet the eligibility criteria and live in the participating assisted living community. Criteria are so much on that. Actually, I do this when I lecture in the class also. So the criteria for inclusion in the study are age 65. They have to live in the participating assisted living community. They cannot have a diagnosis of dementia or a neurocognitive disorder. Pull it out of the back here. Didn't have those memorized. They cannot be on hospice service initially at the time of enrollment. If they do decide to go to hospice, that's fine. And they cannot be a resident in the memory care unit. This is going to be a whole separate project. We said the timeline was 3 months. It'll be completed December 31st. The goals again are to reduce the falls by 20%, improve staff knowledge of falls and fall reduction strategies, and determine if the resident activated the personal alert system. The instruments we talked about, Morse Fall scale, medication risk score, Community incident reports are my only way of gathering information about the fall. Alert system history will give me information as to whether the personal alert system was activated. And then pre and post test, AHRQ fall knowledge test. Now we get into the area that is a little dicey for me, the analysis plan. So for demographic data, I have demographics not only on the participating residents, but also on the staff, because it helps me define the mix, and it of course allows researchers who follow and might want to replicate this to compare groups. That data is analyzed with frequency distribution and measures of central tendency. Activation of the personal alert system is a simple dichotomous yes or no. We'll analyze that with chi-square. Total and repeat falls, z-scores and differences between two populations. Morse fall scale and medication risk score, because there will have the potential to have multiple data entry points. We'll use a repeated measures ANOVA, and then the staff pre and post test scores, we'll use a pair of t-tests. The research process, I know this is again very difficult to read. The resident will be assessed at enrollment. They'll be monitored. Step 2 is just to monitor. If they have a fall, they'll be reassessed, changing condition of any sort, changing medication, go back to step 1. So it has the potential to create a loop. If nothing happens, they're just monitored throughout the course of the study. And then at the end of the study, there's a final assessment that's due. So, expected successes. Well, I'm hoping that total falls and repeat falls will be reduced by 20%. Staff fall knowledge hopefully will improve. I'm hoping that the community will develop a culture of safety related to falls and fall reduction, that they'll develop a program and they'll maintain that. I'm hoping that they will also receive annual education on fall prevention and fall reduction strategies. How they report falls hopefully will also improve. I've been doing some education with the staff on how to complete the incident reports as well as can be expected. And then the potential usefulness, this is where some figures come into play. In 2014, the cost of falls in New Mexico totaled $257 million. That does not count hospital emergency room visits or doctor's visits. That is just hospitalizations. So I found a commercially available inflation calculator. And I sat down with my trusty pencil and binder paper, and I inflated those costs to 2022 dollars.
Well, 1 minute, 1 minute.
Dollars. If we reduce that by 20%, that's a savings of $19.8 million. Now imagine with $19.8 million what the state of New Mexico or any state could do with those funds. They could take those funds You turn them around, put them back into the Medicaid program, put them back into other benefit programs, senior programs, and hopefully improve the quality of life for New Mexico's aging adult population. Thank you so much for letting me be the last person of the day.
Barbara, you're really smart, but we are not the last person of the day. Yes,
Well, the last non-professional.
the last non-professional.
There you
Well, you know, bottom of the barrel. All right, so now we are going to bring back Dr. Khadija.
I'm so happy that the last one.
You're also not the last one.
I converted into PPT. Now it's work. It's only clear.
All right, so this really has to be a maximum of 15 minutes
Okay.
starting now.
Okay.
Hi, good evening, everyone. Hi, good evening, everyone. I'm Khadija Salah. I'm the last one now. Inshallah, I hope this poster will be simply and easy for us at the end of this day. My title is about efficacy of implement innovation and healthcare management. This paper demonstrates the effectiveness of implementing innovation. The aim of this paper is to investigate the critical success factors that affect the diffusion of lean innovation and healthcare projects. In introduction, as we know, innovation is a development and introduction of a new idea and transforming this idea into product or service or objects. While the diffusion is a social process that occurs among people in response to learn about the innovation as a new evidence-based approach for extending and improving healthcare. While the lean was defined as a serious activities or a solution to minimize the waste and non-value added operation and improving the value added process. For the method, the frameworks that we used here, the GIF, which is the generic information frameworks. The guideline here is prescriptive and focused into two dominants, which is innovation and individuals. While for the modules, we used here 3 modules, which is the first one is innovation management. This is the model classification, depend on open innovation, technological innovation, type of innovation, project management, knowledge management, and the project management organizational strategy. The second one is the lean, which is the occupational model. Here by mistake, they written the model classification, which depend on value professionals, customer focus, cultural and change management, measurement as a matrix, quality and lean tools, and infractional and methodology, human resource management. The third one is a purposed conceptual model, which is the important one here. We are used in this research as a successful diffusion of lean innovation and depend on 6 factors, which is the first one, the measurements matrix, leadership and management, financial capability, organizational, cultural, lean healthcare practice, employee involvement. And the result continued. Here, the results are adapted from the public hospital in United Arab Emirates that are published their result in scientific articles. The external drivers, after implementing this efficacy in healthcare management as an external drivers, we can get the high governmental expectation, governance expectation, reputation, competitive market, accreditation, joint commission international. While for the internal drivers, we can lead as a result in patient quality of care and safety, staff satisfaction and empowerment, setting the cultural innovation and meeting internal KPIs. So at the conclusion, the diffusion of innovation offers a ready set of concepts and approaches that can be used to explain respectivity to healthcare policy and practice by individuals and organizations. Diffusion principles can be to accelerate the rate of adoption and broaden the reach of health innovation. So as recommendation of this study recommended further implementation, this lean diffusion, and accelerate the innovation health care management. And we will refer back, if you remember, in early morning to colleague Dr. Sahar. She mentioned that metabolic syndrome. Why not we implement weight the waste to save the time, and we discover this disease. As here, we implement the small idea and lead to patient safety, equality, and achievement, the KPIs of the organizational. And this is at the end, and this is the reference. And thank you so much.
Okay, and now closing our show tonight. No pressure. Anything else?
Is everybody awake?
Do you have a mic?
By the time the slides are on. I kind of chose to look at a different angle of what healthcare kind of lives with every day. So I'd like a show of hands for the people that dealt with supply chain in the course of their careers. Oh my God. Did you deal with supply chain?
Oh, yeah,
in the
yeah,
course of your
definitely.
career?
Yeah.
All right, so if I am to simplify supply chain, it's the whole transportation of the product all the way until it reaches the patient, right? And if something goes wrong, we have to track it and replace it with something that will function well for that patient. So that was the main reason behind me choosing this topic and not any other common topic while we lived it during this pandemic for a reason. It was a hard truth to wake up to. Supply chain not only has the biggest budgets in any operation, let it be in healthcare or any other industry, but also the pandemic has shown the flaws that is in the entire value chain. And there was a lot of lessons learned. So I'm not going to fixate myself on any of the markets that I operate in. And I have operated into like in quite a substantial wide radius of market. But I'm going to take it generically, and the content that will be presented today has been actually published in one of the industry magazines, leading industry magazines and publications, and they're out of it send a research that's in the making right now with one of the American universities around how do we change our model in supply chain to make it more resilient, more sustainable, more practical, and can deal with crisis mode. So is it? Okay, all righty. All right, so for the past 10 years, drivers have always been an issue. We don't have enough drivers in X market. We can't seem to locate drivers that can operate in weird shifts that are aligned with the operations in healthcare. We always knew that that was a problem, but we never tackled it. Multiple reasons, be it fatigue, be it demands from unions, be it the weird hours and long hours, they're opting out of the entirety of this line of work, but we never found alternatives. And what happened during the pandemic, not only drivers, the small amount or number of drivers that we had or are existing for heavy duty or for truck transportation or for even medication transportation was sufficient. But as a matter of fact, they're humans, they fell ill. So there were times where you just can't transport the product. And the product that I'm talking about and the content of this presentation is about medication delivery in specific. And that's how it relates to healthcare. So tapping on a couple of the presentations that we heard about home healthcare and handling the pandemic from different angles. Home medication was something that was not thought about except months down the road, like post-March 2020, people started saying, okay, how do we deliver the medication? The true problem was drivers are not there. Drivers were afraid, they're humans. They fell ill, lockdowns. So if you want to look at this presentation, sorry, it's not very fancy. I have to do it like midnight, but it was all about what did we encounter from a logistic perspective when it came to home medication delivery specifically. The last mile delivery companies had a lot of problems securing those alternative drivers. So one of the lessons learned is that we found out that rather for the sake of survival in a pandemic mode or crisis mode, we needed to have a consortium where competitors started acting like partners. Those who have an excessive number of drivers should start sharing those drivers, even for a fee, so that the business can continue that for them, and also cater to the needs of the society and the healthcare industry specifically, because that was the one on the front line. And the second lesson learned was that when drivers were crossing borders, they needed to present a lot of documentation when it comes to who are you associated with, do you have that letter, what are you transporting, where are you transporting to? That was a little bit hurdle. And I'm not talking about a particular market that had multiple lockdown areas. I can hear yes. All right, so in attempt to strengthen that, there needs to be a collaboration, not only on an operator level, which everybody's so fixated on, especially for those that have multiple facilities in multiple locations or even international presence. But we're talking about regulators being more lenient about what standards should be followed when it comes to transportation or last mile delivery. And the regulators should have some protocols in place for the case of crises, and we didn't have that. So I can see people voting. And the problem is operators have to improvise. They have to find out their way. They have to figure out a safe mode of transportation. And that was a challenge if you are to keep your costs and again, if you're able to kind of go competitive and still be compliant internally. So crowd logistics was pretty much an alternative that was used by 3PLs. So if they've got a delivery for a certain area, they would tag along and say, you know what, deliver this medication as long as they've got those trucks, you know, the medication transportation units, as we call them, medical transportation units. So crowd logistics all of a sudden became the thing. It's not a new concept, but it became a needed concept that's been applied. Some lessons that needs to be considered. Yes, we were able to tackle it, but there are root causes that we need to resolve on all tiers. We're not there yet. As I mentioned, medication home delivery, you know, the drivers were at risk. Driving licenses If you, for example, found somebody who knows how to kind of drive a truck, MTUs as we call them, just the paperwork to get their driving license, the whole 9 yards of documentation was still bureaucratic during a pandemic. That is something to be considered. The registration process is for somebody in the language that's being used on those platforms. It's for somebody who's so educated. It's a very complicated process. It's not catered to the users, and that needs to change. Because the majority of your drivers are of an X nationality or know a certain language. So that should be an option on those platforms. Eat it up. And this is not the case. Home medication delivery as a service. Now, if you talk to any patient, especially those that have chronic diseases or those that rely on blood pressure, I'm just taking a couple of examples of like blood pressure or cardiology medications or any chronic disease out there, and you tell them, now that everything is convenient and you can go to the hospital, take your medications and come back, would you opt for home delivery? The answer would be absolutely yes. Now, the expectation from the patient is that they want to have that option. Some of them are okay with paying for that option. So operators need to understand, and so from an accreditation perspective, that home medication is becoming the new thing. It's part of what they expect. We're not talking only about chronic disease. We're talking about everybody. If I've got the option to have my medication delivered to me, even if it's normal vitamins or whatever it is, and I have to pay a fee for it, I'll opt for it because then I don't have to waste 2 hours on the road or get stuck in traffic. That has become the new norm. But not all operators have accepted that, and not all management members have accepted that. So the system is still not built against it, nor is the accreditation element of it. Something to think about. The ability to offer the service is part of the inpatient and outpatient facility accreditation and licensing process within the operation of that market. But what we've realized is that the way our EMR systems are kind of built does not take into account that this is something that has to be filed for. There are certain tactical aspects of it and the encounter of that patient that have been missed out. So you can imagine the patient safety aspect of it. This is something that if, for example, somebody is expected to take a medication delivered to him, how are you going to consult them? Forget on the side the regulatory element of it. The consultation that has to be documented, the signatory, the whole patient ID and all that. But think about it from a safety element, not a regulatory element. How do I guarantee that this patient who's 80 years old, who probably speaks one language, is going to understand how to take the medication? How do I guarantee that he's going to be safe? If who's delivering it is a driver, give me your ID, you're the person, good day, goodbye. That is one thing that caregivers need to take care of. And the point is, as of today, probably we still have some work to do. Drive-throughs that you pointed out, I think, earlier on, is a great option because you know for sure that probably the patient might be in the car or at least the daughter or the son or family member. But we're talking about medications being delivered there by literally folks that might have not finished their education, like high school.
Can I add something?
Please, go ahead.
Actually, in the territory coming with the driver and the kids to home, we're actually a healthcare provider. So they were pharmacists and nurse. And that's what assure the safety because we especially deal with special categories like oncology, cardiac patient and neurosurgery. So that's why we assure because it's a free of charge. This is also a pioneer standard.
They go with the driver, right?
The healthcare provider go with the driver to assure the compliance, the patient receives the whole information about how they can do. Yeah,
that's one of the solutions. Yeah. Absolutely, that would be used. However, from a cost perspective, our skyrocket.
Yeah.
So a lot of you're talking from a government perspective. You're absolutely right. For government entities, it's always the safety that comes first, and everything else follows because they've got budgets to deal with. But if you're talking about standardizing it, and you're talking about
actually covered government and private,
that's market. Players that are competitive. We've got players that are trying to make sure that they've got the bottom line going off it. Market that there. That's truly a problem because they've realized that they have to hire pharmacists, that the only role of that pharmacist is outreach pharmacist. They just go with the driver and do the whole 9 yards of consultations and things of that sort. But still, not everybody does that. And how do we protect patients? Let's just put it this way. Another pointer that was worth it is, as I said, the whole EMR, when we're, how many minutes left?
5.
Our EMR system is kind of built on outpatient, inpatient. Satellite is very weak. We need to look into that. Let's just put it this way. Emergency supplies was one aspect. That was a shocker because everybody was saying, oh, we've got enough stocks. We've got enough 14 weeks, 2 weeks, whole 9 yards. A lot of medications were out of stock. A lot of supplies were out of stock. And that became a disaster. So, stockpiles and the way we manage stockpiles needs to be reconsidered. A lot of markets that I've kind of researched or been part of, they centralize the stockpile, but you don't have accessibility to the content. You don't know what's there. How do I get access to it? And when can I replenish it? And who's going to replenish it for me? So this is a weak link that healthcare needs to look into. Not specifying a specific market, I care less. I'm looking at it from a global healthcare industry. We are weak in emergency supplies. Having a storage at the basement of the hospital, or be it a warehouse that I outsource that has 2 weeks is not good enough. At 6 weeks is not good enough. The way we plan and the way we forecast those supplies needs to be reconsidered with a proper calculation and proper planning based on the operation, based on what we're offering during a pandemic mode or a crisis mode. Are you offering outpatients? Probably not. Are you doing elective surgeries? Probably not. So it's the emergencies and the inpatient. Do you have enough of those? And if they kind of get depleted, what happens next? Who's going to replenish those? Those questions are not necessarily looked at cohesively. We look at one piece at a time just to get through the day. And in my opinion, we've got a lot of work to do in that arena, to be honest. One other thing that I've kind of surprised me is that how come we don't have, when we talk about logistics, we're like, oh, 3PLs, 4PLs nowadays. Okay. But every governmental entity, healthcare regulator, needs to have that arm to secure the infrastructure. We're not talking about competition. We're not talking about commercial world. Yes, it's important. Yes, we're all working for that profit line. We get that. But then at a time of crises and a time of pandemics, who's that partner of ours? Who do I go to? Any operator out there if I fall short on fleet, people, price? Where's my partner in crime? Not there. That's an area that a lot of markets, developed or undeveloped, it doesn't matter. We need to consider that. And I've noticed one good thing is that last pointer, a lot of the developing markets are considering. Because they realized how much of a shortage in warehousing, cold warehousing they're encountering, and said, why not? We need the whole cycle if we're going to build something from that. MTUs, as I said, medical transportation units. If I go to any commercial website or any 3PL, 4PL, any of those partners that I can commercialize an agreement with, it's very difficult for us to know their capability when it comes to MTUs or controlled medication. On their website, you don't see that. Can I go to a centralized database and say who out there in the world, from all those big names and brands, can any healthcare operator leverage or strike an agreement with so that they can mobilize their resources? Not there. That's a gap to be considered. On an operator level, be it those companies that fix their websites and tell us how many MTUs do you have and are they accredited or not accredited, regardless of the market, because every market has its own regulation. But reality check in crisis mode, regulations loosen up to be the fundamental and very basic ones. Temperature control, 24/7 accessibility, awake drivers, safe drivers, and that's it. And a whole manual log of time. Doesn't necessarily have to be an IoT connected or a sophisticated dashboard with control charts. I touched on the first 2 points. The third point pretty much is when a company has a lot of fleets, they're fitted out, They've got what it needs to become temperature controlled. The process of registering them in certain markets that kind of demand a long process is gruesome. It takes a lot of time, a lot of paperwork, a lot of photos, even in the virtual kind of arenas and platforms, just to get them to operate. But we're still assuming that we're talking a crisis mode. How can that be? When it comes, sorry?
Easy. It's monetization.
Okay.
Without the people.
Elaborate more on that. Can I give you the mic for a second?
It's monetization because we have a medical supply company in Sunrun. And what we found out during the pandemic, ordering masks and gloves and everything, you know, a lot of stuff was stopped in China. A lot of the government in the United States stopped it because they needed it in certain places. So what we find is that the government entities were monetizing it for themselves and for commune and nepotism, for who their donors were politically. And then there were a lot of people in the government who were benefiting. They might have got their wives or their cousins to open up a business so that they could be into the game. So when I say monetization, is that there is a backdoor in to medical supplies, which the people don't know. The people just really want to get healed and they want to walk and they want to, you know, watch their favorite television program and eat, you know, eat good, you know, but at the same time, when you get sick, you know, you don't know what's going to happen. And so that's why I say monetization. A lot more people have their hand in the cookie jar, if that makes sense. Does that make sense? When I say they have their hand in the cookie jar, it's you don't know who's making the money because they don't reveal it. And then you find out the supply chain is not there because certain people don't do business with certain people. So we had a hard time as a small business and women-owned business and a women business enterprise and a women-owned small business who could federally contract. It was tough. Would you agree? It was tough, and my business partner is a 33 nurse from the VA, and she's got a lot of stories to tell when you hear us on the third day, but it's still just so amazing. And so I just find that when people have their hand in the cookie jar because it's money centered versus people centered. Does that make sense? Okay.
Okay, thank you so much. Thank you so much. Sorry for crossing. Okay, intelligent traffic control system. All right, we're gonna now shift a little bit to the utilization aspect of what we started with today. So, reality check, when lockdowns happen, ideally you'd expect the people who are kind of the frontliners and their cars and the vehicles that are transporting whether people, whether supplies, whether medications, whatever it needs to get to that patient and keep them safe, should be registered somewhere, right? To be recognized somewhere rather than, you know, them being fined or being stopped or being flagged. And that causes a little bit more stress on the care provider. And I see a lot of people nodding their heads because the aftermath of cleaning that mess and they were just doing their job, or they were doing a good job, they're exposing their lives, you know, putting their lives at danger and that of their loved ones, just to be able to reach to the patient. So the least we could do is leverage technology to register their vehicles and anything that's associated with them. That is not there. That's a gap. Another pointer I think is around the smart systems and the leveraging of smart systems. That is on the vehicle registration aspect of it and the private cars as well. It's not only on those vehicles that are used in the hospital, but also on the private cars, because a lot of my friends in different countries have used their modifiers. They've used every way possible just to get through the day and reach to that patient. So the least we could do is leverage a very, very strong system and platforms out there to register them. Simple. Not everywhere. That's still not everywhere. And that puts us a lot of stress on our folks that are registered. Please.
I'd just like to add to what you're
to what you're saying right there, is that something may have to be put in place that people can become first responders. So when we have a first responders like class, anybody can be a first responder. And so initiating that, I think would be very helpful.
We need the system.
Yeah.
Allow them to be the first responder, and it should be.
Yeah.
I think another thing that was very, very shockingly important, but least considered. And here we're talking about urban planning, we're talking about the folks that design the cities, smart cities nowadays. Is that unified street system? How am I supposed to deliver the medications if I don't know where that person lives, especially in remote areas? Mark my words, it's really difficult if the only thing they can tell you is that I'm next to that tree or I'm next to that icon that you can't really find. That puts us at risk, right? Patient safety. This is very important. It's about time that either we kind of standardize it or localize it. One of both. But urban planning needs to kind of hike it up and step up and find a way for people to know how to reach people when it's time of crisis, especially when it comes to delivery of medications. Drones, I know a lot of people were so excited about drones and with AI and.
No, I'm just coughing.
A lot of people were very skeptical about drones, and drones had it was very controversial talking about drones and all the readings about drones and all the researches that were done. But in reality, drones have their limitations. They can carry as much as X weights. But a lot of markets out there are opting to using drones. Drones are expensive, but when it comes to emergencies, drones can do wonders. Why not?
Yeah.
Why not?
I mean, they do it for the prisoners. That's how the prisoners get their phones. You know, nowadays, really, they come over, then you're laughing, but this is real. You got to have the phones and everything, So.
But the thing is, it doesn't solve things radically over here. Drones have limitations, but people are kind of shying away from it because, well, it's so complicated, yeah, but we need a plan C. Don't consider this as plan B, but plan C. So that if somebody is in a remote area, you can drone something to them. Now, the good news though, is that 3PLs nowadays, they're considering this very seriously. They're building towers, and drones will become the new mode, minus areas that are sensitive, whatever that market looks like. But this can be leveraged to that. And I'm all for drones, to be honest.
Well, what about crisis management? Because I've done logistics for the Olympics in Georgia. And I remember it was an instance where we had a meeting and it's like a bomb was going to hit downtown Atlanta. Well, a bomb did hit downtown Atlanta. But thank God, the logistics of it, we did it ahead of schedule. I hired 12 people, hired vans, took everybody, the broadcast engineers on the outside. So it's that logistics with that crisis management, so that the person that is in that rural area, there are people that can get to the people in the rural area. So they have a little team, my mother's 81.
You've got a functional task force.
Say it again.
You've got a functional task force. You've trained people. You've educated them on what needs to happen. And when stuff happens, they mobilize without the need to go back to you.
There it is, and that's the people.
Absolutely.
Sometimes we wait on the people who are having money in the city jar, and nobody's mobilizing. You can't wait for them because time is of the essence.
Right.
So, AARP is giving out flashlights now for seniors. So in case the lights go out, guess what? That senior at least has that lantern that they can at least see through the house, And so
it's like anticipating the bad happening. Be ready for it.
I think that's good.
You're right. You're absolutely right. We'll come to that one, but here's, well, it's all tricky from that point for a reason that are we preparing people's rights? Are we educating people how to respond to crisis as part of the curriculums that are graduating folks? No. We look at crisis like if it happens, well, guess what? It did. Globally. Here's the funny part. So that needs to change. What you did stems from experience, stems from leadership. You need a task force, you need the best out there, you need to rely on them, and not have to go back. Nobody needs to come back to you for every step of the way. We don't have that. We need to start having that in every single operator out there. And this is a gap. And thanks for bringing this up. All right. So mobile care, to the point, the whole mobile care is that it's not only about COVID, PCRs, or it's not about reaching to the chronically ill to measure their vitals and make sure that their IoT information that kind of triggered, the wearables triggered like that info. That's not the case. We're talking about trucks that are equipped to do lab results, to see United, because that was once assumed, but it turned out to be a little bit expensive. But we need those. We need clinics, mobile clinics. We're talking about vanilla rooms, as we call them at times. Clinics that can reach to remote areas that just recovered from a natural disaster, and be able to at least provide you GP services, right?
Right.
Generic services. Change the wound care. Check on the elderly, to your point. Why should this be so sophisticated? It shouldn't be. It should be basic of safety. And then whatever happens in it, it's subject to the credibility of the care provider. But what we're realizing is that they want everything to be so sophisticated, so complicated, a replica of what a hospital said. I can see the nurses. Absolutely. It's like, it has to be a similar setting as a hospital. Well, that's a hospital. Lift that building, shake it. It's a building. But you need to have a mobile operation. We're lacking that. The pandemic showed that we need that. So it's time that, here's the lesson learned, that every operator that has resources, has the ability, has equipment, has the phone, should have a mobile operation. Associated to it. Now it's not option. It's a need. So we just need to look into increasing that landscape and think about it right. So rather than have, if you've got in one county or one city or one country, let's say, you've got mobile trucks that cater for specific services, then at least you've got a heat map. You've got a landscape that you can leverage at the time of crisis. It should not be a replica. It can be one area having two trucks that offer, lab services, another area that caters to a specific kind of service. And then when there's a need, you leverage that. You mobilize whatever is needed. We're not even taking that serious yet. That's way behind.
I think what we have to do is you have to meet people wherever they are.
Yeah.
So if somebody calls you and says, "Hi, I'm in need of this," if you can't fulfill the need, I'm sure with the level of influence within this group, if you don't have it, you can sure call somebody else.
That's a referral network.
Yes, and you gotta have a referral network. And I'll tell you this story. We were out one day, got a call on the business line, and we were driving, and a gentleman called and he needed a toilet seat, old Jewish man. And so we just said, okay, we'll drop him by. He was so happy. I mean, we had to even go into the bathroom with him. And I'm like, I've never been into the bathroom with him. Not even my husband, And I told Leola, I said, Leola, we're going into the bathroom with him, right?
Right.
But he was so happy that we delivered that toilet because he could have been subject to falling too, because in the older homes in Los Angeles, the toilets are like here. So raising the toilet up, something very simple. He was so happy and he pulled out $40 out of his pocket. He was so happy to give us that $40. And he just said, we're so happy to do that. So I think it's those things like that when you have that need to fulfill that need, and if you can't fulfill it, have somebody to fulfill that.
But in healthcare, we need to stop doing one thing though, is that we think of great ideas, we deploy them, but we don't know how to sustain them, let alone optimize them.
Yeah.
So, great to have a No, it's great to have, let's say, the example prior to this is that we're talking about mobile care. But where's the framework? Where's the regulation? Where's the referral network? Where's the command center? Let's just put it this way. If I need something in that area, what's the process like to dispatch? And if I, as an operator, own 2 trucks and another owns 10, I need 10 of those. Can I go ahead and take them? Or is it going to be a gruesome fight? Trying to get the bureaucracy out of our way so that we can care for whatever patient in whatever area. That is where we're falling short, and we need to change the way we deploy initiatives, I guess is the right statements used.
Unfortunately, we're reactive, not proactive. So unfortunately, we're going to react to these things. If what happens, we're not going to do anything, even though we all speak about it and say, you know what, it's going to happen, that's going to happen. I can see that happening. Let's do this, let's do that. Great ideas. But unless the right person's in the right place at the right time, it's never going. Okay, we should stop.
No, but
It means we should carry on even harder.
Going harder. You just said it. So once.
Well, no, not much harder.
No, work smarter, but here's the deal. Is that if one of the operators, and when I say operators, I'm talking about hospital operators, as you know, regardless of the complexity of their operation or the scale of their operation. But if 1, 2, thousands of them, imagine that. And what happens? That's it. That's pretty much it. It becomes the new norm in operations. It's because, we've lived without it for 10, 20 years. Let it be as it is. Great, okay, then what? Then that pandemic comes and we realize all those, I call them the cheese, the Swiss cheese, all those goals are just getting us in our place. And that's pretty much what's happening out there. Right? Oh, sorry.
Yeah.
All right, so just to wrap up, this whole world is all about business continuity. And do we have a lot of work to do on it? Yeah, there's a long road, but we're taking baby steps, I think, across the globe, different initiatives. And my recommendation is to kind of, it's way much better than nothing. But business continuity is not a clause in a contract from your suppliers or from yourself, like a policy in company. It's pretty much the actions, the processes, and the initiatives that you roll out. And that summarizes my presentation. Thank you so much, everyone. I think I've covered it.
Thank you very much. And that concludes our day today. Those of you who survived are welcome to come back tomorrow morning. What time do we start tomorrow? We start at 6 a.m. tomorrow? Yeah, what time do we start? 5:30 a.m.? What? 8:30. Okay, I got them to push it back till 8:30. Those of you who survived will be here tomorrow at 8:30 a.m. And if you've passed on, then we'll take care of your remains. Thank you. There are plenty of doctors here.
You were speaking. Yeah. We come up on that, isn't it?
This is really interesting. How it's Journey took one and